Can you hear me?
Yes, sir. Want to talk? Satish sir want to talk, sir. Just you can talk.
Yes, Farooq, good morning.
Sir, good morning, sir.
Yeah. Carry on. I'll wait for your call.
We welcome you all to the 45th AOICON 2021 State Conference of Bihar and Jharkhand. It is an honor and privilege for us to have you perform live surgery. I'm sure we will all be enjoying the treat of your surgical magic skills. And we have the president of our association with us, Dr. S.P. Singh. He will just say a few words.
Sir, good morning, sir. Hello, good morning, sir.
Good morning, sir.
Sir, मैं स्पीकिंग डॉक्टर एसपी सिंह सर, भागलपुर के एओआई और बिहार झारखंड के तरफ से आपको सुबह का नमस्कार सर।
आपको भी थैंक यू।
हाँ, इस प्रोग्राम में आप हम लोग सब आ गए हैं और इस लाइव सर्जरी शुरू किया जा सकता है और हम लोग के आप लोग गाइड हैं और इसके हिसाब से अपना हम आप लोगों को अपने गुरु की तरह समझते हैं। हम लोग का प्रोग्राम आप स्टार्ट कर दिए, इसके लिए बहुत बहुत धन्यवाद। हमारे गेस्ट लोग आ गए हैं, बहुत लोग आ रहे हैं सर, काफी गैदरिंग होने की संभावना है। हम आपके सारे टीम को आपके साथ में स्वागत करता हूं। धन्यवाद सर।
थैंक यू सर।
ओके सर।
माइक्रोफोन फोकस करा दे, ऊपर माइक्रोफोन दोनों भी लगाना है, शूट करना है, कौन सा दिखाना है।
सभी लोग बैठ जाएं। अब प्रोग्राम शुरू हो रहा है, सर की तरफ से सर्जरी शुरू हो रही है। सब लोग आराम से अपना सीट लेके बैठ जाएं और सर के सर्जरी का एंजॉय करें। हमारे यहाँ जो है आज दिन भर लाइव सर्जरी होगी, डिफरेंट तरह के लाइव सर्जरी लाइक पैरोटिड सर्जरी, थायराइड सर्जरी, टिम्पनोप्लास्टी, डिफरेंट टाइप्स ऑफ टिम्पनोप्लास्टीज, mastoid surgery and CSF rhinodia surgery, and so many surgery will be done by the great surgeon of our faculty, Dr. Satish Jain.
Hello. Meanwhile, the patient is being prepared. We'll just update you with the schedule that we have for the conference. This is a 3-day conference, 17th, 18th, and 19th of December. Today is dedicated exclusively for the live surgery. Dr. Satish Jain is our hero today, hero of the day. It will be from 9 to 4. We have chairpersons, Dr. T.N. Singh, Dr. S.K.P. Singh, Dr. B.M.K. Sinha, Dr. C.G. Agarwal, and moderators will be Dr. Prakash Monka, Dr. Ashwini Verma, Dr. H.I. Farooq, Dr. Abhishek Srivastav, Dr. Akbar Ali, Dr. Divesh, Dr. S. Sahi, and Dr. Manish Kumar. we will have a working lunch in between 2 to 3 p.m. today, and program hopefully will be over by 4, and then we can proceed for a break. Then there will be a welcome dinner 7 p.m. onwards. The second day we have a hectic program from it will begin with the state oration at 9 p.m. The speaker of which will be Dr. R.K. Sinha. Then there will be Padma Bhushan Memorial Oration, Dr. R.D. Kumar Oration, guest lectures, Dr. Raghav Sharan Oration, Dr. R.M. Ravi Memorial Oration. And there will be 2 invited guest lectures followed by lunch. Post lunch, we will have a panel discussions, the panelists of which are Dr. Saurabh Varshne, Dr. Rajesh Vishkarma,
एक्सटर्नल कैमरा बंद रखो, अब लो मेरे चालू करो ना। हेलो 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 हेलो
Yes, sir. We can hear you, sir. Hello, sir. Can you hear me, sir?
Yes, yes, I can hear you, but
Sir, Bhagalpur got disconnected and they are going to connect, sir.
hello.
Yeah, Bhagalpur team, can you hear me?
Yeah, hello.
Yeah, sir. Continue, sir.
We can hear you, sir.
Yes,
Sorry, there
Farooq,
is a
how are
power
you?
break. So we were out for a few minutes.
Yes, Farooq. So thanks to Team AOICON, Bihar and Jharkhand for giving me this opportunity, involving me for this live surgical session. Thank you once again. It's a pleasure and privilege to be part of this event. And it's always pleasure to be part of particularly Bihar and Jharkhand state. Been there a couple of times because of the COVID, I know, couldn't make it to be there, but still happy to be attached with you all. Thank you so much. So we are starting our session today with, as you have seen, number of surgeries listed. to begin with the basics, we'll start with the tympanoplasty case and then we'll move on to the more complex cases.
Okay,
So
sir.
this session is going to go till 4 o'clock in the afternoon. So for the first case, tympanoplasty is a patient with a large central, or you can say a subtotal perforation. We all know there are a variety of techniques proposed to treat such cases of large central perforations. Variety of surgical techniques like underlay tympanoplasty, onlay tympanoplasty, onlay underlay tympanoplasty. There are so many things.
Yes, sir.
And our technique, what we have proposed for years together and done thousands of cases, has been the interlay technique of tympanoplasty. The basic difference in all these techniques, if you look carefully, underlay being the most common. Believe me, all techniques offer good results. The difference is how you tackle the different situations, how it works good in your hand. But there are intrinsic differences among these techniques as well, which we need to understand to improvise our results. We all know all techniques offer results over 90%. The difficulty or the challenge is to reach 99 from 90%. And that is how the science is evolving, and we are here to discuss all these things. So underlay technique, being the most popular technique in the world, offers good results, maximum number in the world done with the underlay, wherein the graft is placed underneath the tympanic membrane.
Yes, sir.
Underneath all the layers of the tympanic membrane. Means tympanic membrane is composed of 3 layers: epithelium, fibrous, and the inner mucosal layer, and the graft is placed underneath the mucosal layer after making it a little bit raw to keep the graft in place, to make the graft adhere to it. And that is how most of the time it works, it heals up and the graft is taken up. But the drawbacks are very obvious. It is not the most physiological place for the graft, which is a matrix, which is obviously a fibrous layer. It's not the usual place for the fibrous layer. Number 2, there's always a problem with the security of the graft with the underlay, particularly in large anterior perforations. To secure the graft, to prevent its dislodgement with the negative pressure which may come across in the post-operative phase. So any
Yes,
negative pressure may dislodge the graft and graft may fall off and get necrosed. There are many ways to secure the graft in the underlay also by anterior tucking, inferior tucking. It works majority of the time. So other technique which has been proposed over the years, having excellent results, is the onlay technique. When the graft is placed over the fibrous layer by denuding the epithelium, technique is good, results are excellent. The problem is the challenge is the removal of the epithelium completely. Denudation is essential so the graft is placed underneath the epithelium. We are not supposed to, trap the epithelium underneath the graft. And in that situation, if the epithelium happens to get trapped underneath the graft, can even lead to cholesteatoma. And because of this technical challenge and possibility of cholesteatoma, and anteriorly also the blunting, the 2 layers of the graft may unite together to give blunting. All these things led this technique to disrepute, and it's not very popular now. So to overcome all these challenges, even the graft may lateralize with the onlay, because the graft is most of the time placed over the handle of malleus.
Sir, it is very difficult to remove the entire epithelium. It is a real challenge.
Yes. That's why it's technically most challenging. And there is always, possibility of leaving the epithelium underneath.
Yes, sir.
So to overcome all these, lacuna, the pros and cons, we introduce, or what I have been following, is the interlay technique, which was initially proposed by Dr. A.B.R. Desai. We did modify a little bit, but the basic principle is same what Dr. A.B.R. Desai proposed initially, to place the graft in between the layers of the tympanic membrane. That is for placement of the graft. But the technique in itself is complete reconstruction of the middle ear cleft. It's not about just tympanic membrane or reconstruction. Perforations in the tympanic membrane can lead to complications in the middle ear cleft anywhere, including cholesteatoma and other things. Middle ear cleft means eustachian tube, mesotympanum, and the mastoid air cells, attached to these system. So the mastoid air cell system, mesotympanum, and eustachian tube together composed as middle ear cleft. And whenever there is pathology anywhere in the middle ear cleft, ideally we need to have a look into the entire middle ear cleft to prevent any possibility of future complications and failures. That's how, as I mentioned, 90 to 99, reaching to 99 is the challenge. That's what we are striving for. So in this technique, we explore the entire middle ear cleft, including eustachian tube, mesotympanum, and the mastoid air cell system. And that is what I am going to show you. And in this technique, the entire tympanic membrane is literally divided into layers, wherein the graft is, sandwiched between the fibrous and mucosal layers. So it remains in place, doesn't get easily lateralized or medialized. It remains underneath the handle of
Provided very adequate support.
Yeah, there is no question of dismantling the epithelium layer. It remains all the way intact over the graft, over the fibrous layer. As such, the epithelium and fibrous layer are not disturbed at all. The plane of dissection or sandwiching the graft is between the fibrous and the mucosal layer. That is what the technique is, and that is what we have been doing for almost now more than 20 years. And Farooq has been part of our system, Jain ENT system, and has we had the pleasure of having him for almost 2 years here, and he did thousands of procedures over here. So amazing, and that's what he is doing there in Bhagalpur now with his amazing work.
So
He's
your
very
place
popular
is
there.
an epicenter for learning.
And I know Farooq, the thing which I am going to show you, the same you can see from the Farooq and even better what he's been doing day and night. So in a couple of minutes, we'll be there with the case. We have already opened the canal. By default, we do all cases post-oral, sometime on patient demand in, for regions. We may have to go, or we do transcanal or mini endoral proposed by Dr. A.B.R. Desai again, and all this. But by default, our technique is post-oral, universal for all surgeons here. So the rule is to make the system universal for everybody to follow. To follow up, most important is the follow-up. So all cases can be followed up in the same manner by all the team members. So here in couple of minutes, I'll be there with the surgical case.
Okay, sir.
देखिए
We welcome Dr. Ashwini Kumar Verma, the legendary surgeon of Bihar. Sir, most welcome. Sir has taken pain of coming to Bhagalpur after I called him around 10 p.m. Boss, Ashwini boss. बस 10 बजे रात में फोन किया, आप ब्रोंकोस्कोपी कर रहे थे, उसके बाद आप निकले हैं. तो सी द लेवल ऑफ कमिटमेंट ऑफ दिस पर्सन. आई एम श्योर आई हैव बीन सीइंग हिम विद सो मच एनर्जी सिंस अराउंड 10 years बॉस. एनर्जी लेवल का सोर्स क्या है सर?
हमारा जैसे मित्र हैं और क्या. इट्स ऑल ड्यू टू फ्रेंड्स.
So we are just beginning with the case. The sir will be performing the interlate tympanoplasty, first case. Sir, mic is over to you.
Hello. Hello, Dr. Satish.
Good morning, boss.
Good morning. Good morning.
Nice to see you.
हेलो.
Hello.
हाँ, कैसे हो भाई आप?
All good, all good. Nice to see you.
It is always fun to watching your surgery.
Thank you, boss. Are you getting microscopic picture, boss?
Yes, but picture is not so good.
What happened?
Maybe due to transmission problem. Generally, your picture doesn't. It is world
Yeah.
class.
What happened? Why picture is not?
Lights off करो जरा सा. Lights off करो जरा. सामने वाला lights off.
I can see good picture on monitor. Output कहाँ से लिया? Hello.
Yes.
How's the picture, boss?
Little better.
Better.
Little
So
bit.
we have a brilliant picture here in the OT. I don't know what screen is there. Is that LED there?
This is LED, large LED screen.
Okay. How are the colors?
Colors are okay, but contrast, the lack of contrast here.
I think you need adjustment from your end there. Here the picture is brilliant in the OT.
Okay, then continue it.
I don't know, fail to understand.
No need to do anything, no to change.
Okay. Are you able to see the perforation there?
Yes,
See the large perforation there?
yes, there's a very large perforation.
Okay. So just now we were discussing about the various techniques of, reconstruction of the tympanic membrane defects, tympanoplasties.
Yeah.
And our proposition was to reconstruct the entire medullary cleft, to have a look at the Eustachian tube, mastoid air cell system, along with the mesotympanum and the tympanic membrane reconstruction, to have a look at the ossicles in case required to reconstruct, all those things to be done at the same time. And the technique we propose is the interlay technique, wherein we divide the tympanic membrane literally into layers. And that is what I'm going to show you. So this is the perforation.
Give
Okay.
the little centralized so that we can get the better picture.
Okay.
Not centralized. Yeah, now it's better. Now it's better.
Fine. Fine. So this is the perforation margins you can see, but little hump anteriorly, not very significant. I can manage. I'll tell you the reason why we tend to avoid mostly, canal plasties. So,
What is the reason?
like any perforation we deal with, our goal is to fashion the margin to make it healing. Why it has become a permanent perforation? Why it has become non-healing? Because the medial mucosal layer has gone across the margin of the perforation, or the outer epithelium layer has gone across the margin of the perforation to join the mucosal layer and making it non-healing. In underlay technique, practically, we divide the tympanic membrane into layers. So it has been earlier proposed that there is no need of, freshening the margin.
Yeah,
But
there are studies on this also, that they don't prefer thing of the margin.
yeah, but still, what happens? Sometimes this epithelium goes across the margin of the perforation to some distance. And we should not take a chance to leave the epithelium behind. So we always make a habit, in spite of doing interlay, to make the margins fresh. It's a good habit, and you don't leave any possibility of any epithelium, which has grown beyond along the margin underneath to leave behind. This is how
So
you
how
can,
much, Dr. Satish,
yeah.
how much do you agree with technique of Dr. What you in which technique Dr. Suri he used to
Yeah,
look
that is
at us
total annular reconstruction proposed by the great Dr. Suri.
in
There is
every
no question over any technique. I mentioned in the beginning, all techniques are good. The idea is how you execute the fundamentals behind that, and see and we always, are concerned with his concern, why he opted to that technique. See, the tympanic membrane is composed of layers,
yeah.
wherein the epithelium should remain above, mucosa should remain below, and the graft in between.
Okay.
In any given situation, if epithelium gets trapped underneath, the graft may lead to cholesteatoma. At the same time, if mucosa is left above the graft, can lead to weeping tympanic membrane, which can keep on discharging. And his concern of removing the mucosa in toto to prevent the mucosa creeping over the graft is the main thing which led him to invent the technique of total annular excision, wherein he completely removed the annulus to ensure that the mucosa is completely sacrificed, which is not going to come over the graft at all, and the canal skin is going to flow over the graft. So here in this technique also, keeping the same concern in mind, that's a important thing. The mucosa should not come over the graft, and we'll ensure every possible thing to prevent mucosa coming over the graft. That is what I'm going to show you in this technique as well. And we have seen in our long-term results, which is, I would say, around 99%, which is comparable to any best technique in the world.
Dr.
So it's
Satish,
not about, being judgmental which technique is better or which technique is right or wrong. It is relative, how it works in your hand, keeping the principle in mind, that how you execute it. And TAE, what he has proposed is a wonderful technique, no doubt about it. And he himself has witnessed the results. Now even witnessing the long-term results also, so it must be good. I have no doubts about it.
so this technique, there are a lot of techniques of tympanoplasty, underlay, interlay, overlay, this, that,
Yeah.
huge number of techniques.
Yeah.
All didn't show that still we don't know what is the basic principles of healing. That's why we are lacking. A lot of technique itself,
Yes.
why that we are not knowing the basic fundamentals of
Science is evolving. We have not known 100% about anything so far, and we are trying to approach that. Your point is valid, but what we have learned out of our experience with now, the millions of tympanoplasties have been performed, and all techniques giving results over 90%. You can
doing more than
improve with the experience of others, following others, learning from others. It's all about learning from each other. That's how we keep on evolving. So in this technique, in interlay, the basic step is to divide the tympanic membrane into layers, and that is how it is done. I'm going to explain you. I'm going to demonstrate you. Now see, the incisions in the canals are always tailor-made. My incision, see the inferior margin of the perforation, you can see here. My inferior incision is few millimeters beyond the margin of perforation. It is not going all the way to the medial aspect or to the level of the annulus. I am limiting it to the canal so that I can convert to a circumferential incision later. I will show you. So this is my initial inferior incision, tailor-made beyond the few millimeter beyond the margins of the perforation. Can you see?
just lateral to the margin.
And this, you have to be careful in elevating this flap here from the tympanomastoid suture line to prevent any tears in the flap. Now, my superior incision, again, Look at the superior margin of perforation. Can you see here? Again, it is tailor-made a few millimeter beyond the superior margin, and here I can go little more medially close to the annulus because I don't need to make it circumferential from this side, and I can easily elevate this part of the flap, posterior flap, like any underlay technique or anything. It is not different, and you can easily elevate as compared to the other parts of the flap because this part of the flap being relatively thicker. Can you see?
Yes, posterior superior part is very thicker.
Yeah, relatively thicker. See this, the flap being elevated, and I will go until the level of the annulus, and stop there. See the level of the annulus. Okay, can you see the annulus?
It's very clear.
Yeah, so that's the initial part of the incision, posterior incision. Now I will make it circumferential. Now for the initial incision marking, I left my incision medially, inferiorly, a few millimeters above the annulus level. Can you see this?
Very clear.
Had this been a big hump, required drilling or anything, I would not go so medially and I would circumferentially raise lateral to the hump so that I can drill away or tackle the hump accordingly. But since this hump or this bulge is not significant, I can manage with my, tilting the microscope. I will ignore this. Tilt my microscope, you can see now. And now at this level, see, this is the level of the annulus here. This level, few millimeters lateral to the annulus, I will further complete my incision, and the limit is beyond the anterior superior margin of the perforation. Look at the anterior superior margin of the perforation here. My incision is again few millimeter beyond. So the bottom line is the incision should extend all around a few millimeter beyond. Can you see very clear? Is that clear?
Very clear.
Now, this anterior wall, bone looks decent at the level of the TM joint. It may be. This can you can find not uncommonly, I would say.
This is also
But
very frequently in the OPD also. Sometimes.
yeah, many a times.
Send live the picture.
Yeah. Now the next step is to raise this flap carefully. See the difference in the posterior and the rest of the flap. It is much thinner relatively. Sometimes even looks like a single layer of epithelium. So you have to be very, very careful in raising the flap at this part of the canal.
So in this technique, Dr. Satish,
Pardon?
this technique, when there is a lot of granulations along the margin, when it comes beyond the tympanic membrane area of the annulus, goes very.
So we will oppose the margins of the skin flap back to the same place at the end of the surgery. I will show you.
In that situation, I want to just convey that in that situation, technique of Dr. Suri Prabhu is really needed. When the relation is beyond, it may come up to right up to very long distance. It may travel long distance laterally in any quadrant of the canal. It can.
So you can go with this technique 360 degree into the canal. That is the basic advantage of this. That's what I'm going to show you. That's what I'm going to show you. And see, while raising this flap, you have to be equal at all levels so as to prevent tearing the flap. See this?
Yes, that is most important part.
That is most important part. And see, all along my goal of initial flap raising is to reach the level of the annulus all along equally simultaneously. See now, anterosuperiorly. Use your suction judiciously away from the flap to prevent the flap being sucked and get torn. See this, the anterosuperior annulus, can you see clearly?
It's very clear.
Now coming to the anterior part, all along equally. You will find very commonly a band here antero-inferiorly
Yes, they're very strong band.
that you have to, cut it sharp. See the annulus antero-inferiorly.
It's very clear.
Now coming inferiorly and complete this annular exposure. This completes the initial part of the flap raising. Can you see?
Yes, it's very clear.
What did I write? Now, the next step, see in interlay, the hallmark of the technique is to leave the mucosa below. That is very, very important. That is why Dr. Suri Prabhu is so,
Adamant.
adamant, and it's important to ensure that the no mucosa is left along with the flap. See now, antero-inferiorly, what I'm doing, now I'm getting this flap or this, annulus out of the sulcus, out of the tympanic sulcus. After the exposure, this annulus is, inserted into the bony sulcus. And see now, can you see this?
Yes. Very clear.
All along, this annulus is out of the sulcus. And what you see there is reflecting
Mucosal layer.
mucosal layer. See this? This annulus is the condensation of fibrous layer. And underneath that is mucosa. You can see very good, very clear. Let me show in high magnification. Now with this blunt hook, see this?
Yes.
Engage your hook and peel it off, not to tear it. Can you see the distinct mucosal layer or not? Let me show you again.
Clear.
See this?
Yes.
Very clear?
Yes.
See this? No part of the mucosa should come with the flap. That will otherwise defeat the purpose of this technique.
But
It's not the fault of the technique, it is how you execute it that is more important.
in a smaller perforation, Satish, what I have observed in this technique, mucosal layer gets almost always turned.
Yeah. So in more smaller perforation, generally we don't go ahead with this technique.
So
We don't propose it.
what
There are many other techniques.
what's your technique in that case? That is because also that a small and even medium size perforation has good. They are maximum in the number. If you see the percentage by perforation, not most of the perforations are subtotal. Most of the perforations
Yes. So this is best for the large and subtotal perforation, obviously, though you can use for any. See this, anterosuperiorly now. I have gone beyond the margins of the perforation, leaving the mucosa below. Can you see very clear?
It is very clear. So question still remains, what's your approach in that cases, in those cases? A smaller
Okay, in a smaller, perforation, having the malleus in margin, posterior perforations, we do variety of over underlay and tucking procedures along with the underlay technique.
Okay.
So to ensure that we maintain the principle and we maintain the, ensure the stability of the graft. Now you see here again, at what level till I have raised the flap. See, this is the margin of perforation.
Yes, very clear.
I will raise it beyond the margin of the perforation. See this?
Yes.
And this is the same mucosa which is coming from below. on the promontory, growing along the walls, and then coming underneath the tympanic membrane. Can you see?
Yes, 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 yes. The same.
And see, this is elevating this beyond the margin of the perforation. My perforation margin is here, and I have elevated till there to ensure the extra, tucking of the graft in the proper plane. Okay. The same
Good
thing.
morning, Dr. Satish.
Good morning, sir. How are you?
Oh, fine. I will be joining just in half an hour. Actually, I have just reached Bhagalpur.
Oh,
And,
you have come all the way to Bhagalpur?
Yeah.
Oh, you are on the phone. I think you have reached here.
I am coming, boss.
Okay.
And the same thing I am completing postally. Sir, looking forward to see you and to interact with you.
Sure, sir.
And see the same thing posteriorly. This is the plane behind where you can see the chorda tympani here.
Yes.
So this is how you can elevate your flap beyond the margins of perforation everywhere. See that? And what you see underneath is the incus. In long-standing perforation, it is not uncommon to see the bands between the mucosal bands between the malleus and the incus, and some adhesions around. That is not uncommon to see. What more important is to ensure your ossicular chain, continuity, to ensure your editus patency, because your mastoid air cells are dependent for their aeration through the editus from the Eustachian tube, and that space is very, very important. See my malleus, can you see very clear?
Yes, man, that's very clear.
See my incus, and I can see the continuity of the ossicular chain very well. Can you see?
Yes, yes, yes.
And this
Sometimes
is-
movement of the scales is little restricted.
Yeah,
It's normal, but after surgery we get a lot of conductive hearing loss.
yeah, that is because many a time it is missed mucosal continuity. It is missed mucosal continuity that you have to be careful in assessing the ossicular chain movement for that.
Because sometimes there is strong band connecting the incus to the stapes, or that may
Yeah. It could be just a mucosal continuity,
yes. And the
giving you a false impression of an intact ossicular chain. And see this, I'm elevating the malleus, and see the movement of the stapes as well as the foot plate even.
there is granulation on the stapes head, I think.
Can you see the
There is, yes, movement is there.
not only movement of the stapes, you can see below,
Round window reflex.
not the movement even to the level of the foot plate.
Okay.
And that too when I am elevating the handle of malleus laterally.
There is
If I-
a small niche below the stapes, that is round window. Or
The
there
round window is inferior. I have not focused here.
is a small opening that is seen there.
Yeah, round window is here on this side,
Okay.
which I have not focused, and because of the overhang, you may not be able to see. I can see the just glimpse of the round window.
Okay.
If you can see,
Actually, whatever you can see, na, we cannot see. The quality.
that is binocular. What I'm
Yes, yes.
seeing is with the binocular vision, and you are seeing through the camera, that is uniocular.
That
So
is,
that can lead to a little bit of the perception difference.
picture cannot be relayed. I
Yeah.
have seen that microscopic picture cannot be relayed. Exact picture cannot be relayed on anything.
Yeah. So, but
Maybe camera maybe actually.
close to it, you can see not exactly the same binocular.
I'm talking about the color fidelity, not talking about the stereoscopic vision. Even color is a huge difference when the best camera 4K or HD, whatever you are.
Yeah.
Still, we are not getting the exact picture what we see in the microscope.
Absolutely. Absolutely. We can just hope to see close to it, but cannot be the same one.
Still we are large, far distance.
See now, if I reposit my flaps back, can you see?
Yes, yes.
If I reposit my flaps back, you can see the same perforation like it was before.
Yeah.
The difference now is the epithelium, the intact epithelium and the fibrous layer has been elevated off the mucosal layer which is left behind. Can you see very clear?
This is very clear.
And that is the aim of this technique to divide the tympanic membrane into layers. That is the hallmark of this interlay technique. So my graft is going to be in a natural, I would say, bed between the mucosa and fibrous tissue. Now I am flushing the eustachian tube. This is our usual approach to flush the eustachian tube. If anything dislodged in the eustachian tube, these are long-standing perforation. Many times we removed mastics, even flies, dead flies, because these years getting repeated infection can attract flies. People have a habit of picking the ear with the mastics, broken mastics you may find, and it's a good habit to flush it in case anything lost there, you can easily remove it to prevent the future possibility of infection. Now, yes, boss.
Actually, a lot of people are still doing underlay technique with a very good result.
Yeah, I am not saying that the technique is bad.
Not in
Any
fact,
technique gives over 90% result.
they are getting the why they are getting the 90% result, and we are still very bullish about removing the mucosal layer, and they are not at all.
Yeah. So it is all relative. I told you, you can't be hard and fast about the things, the healing mechanism. The left mucosa can start weeping. It doesn't mean it is bound to. So it is better to remove the mucosa coming off the graft. It is all relative. Nothing is hard and fast. Science is all relative. There is no technique you can say bad or wrong, whatever. It is all relative, and this is how we have to evolve, or we are evolving, learning from each other to remove or to go for the betterment and leave those things which have poor results. It's all relative.
Have you cut the tensor tympani tendon there?
Not really. Yes, in case my malleus is too medialized, I would prefer to cut the tendon rather than nipping off the handle of the malleus.
Yes, yes.
Will that have an impact on the hearing, sir, later?
No, not
Not really, not really.
because in OPD we are regularly seeing the patient with short handle of malleus.
Yes, sir.
Yeah.
Sir, I can see you are removing the mucosal tag around the IS joint. So any precautions that we need to take specially so that
No, you have to be very careful, specific to the point. And this is an exercise to, like Ashwani boss mentioned, to ensure that you don't have any mucosal continuity itself. So in assessment of the ossicular chain, you have to be very, very particular. Otherwise, you can leave an, disarticulated ossicular chain behind an intact tympanic membrane, giving maximum conductive hearing loss.
Yes, sir.
So now, having done this graft elevation, we have seen eustachian tube. We always talk about the eustachian tube function. This is all mechanical assessment, functional assessment we do with tympanometry, and elevation of the flap, inspection of the ossicular chain. Then I was trying to look into the malioinguinal space or the inferior inguinal space leading to the editors. Many times because of the recurrent infection, you may find fibrosis, mucosal bands, or tympanosclerosis, and all those you can clear off from this side.
In this case, are you going to open the mastoid as usual?
Yes. It's not about opening the mastoid. I don't have any 100% test to ensure that my mastoid air cells are being aerated down the eustachian tube. Either indirectly you can predict with having this space very clear, but that is not 100%. Or to add on to the specificity, you can use your angle telescope to look towards the editors whether it is patent. But still that is not 100% because you may have blockage beyond the editors which is not visible by the endoscope even.
Yes.
So the best test 100% on the table, not taking more than a minute or two, is to check from behind. Look where the mastoid air cells are being aerated down the eustachian tube on the table directly rather than relying on indirect methods. And that too you can, complete in a minute or two. And that gives an additional opportunity to rectify in case it is blocked. You can correct it.
Yes.
Initially, if the aeration is good, you may find the patency even quite laterally while drilling.
Yes.
When
Yes.
you open up any lateral cell, and you can stop there because our aim is not to do any mastoidectomy, any enterostomy or anything. Our aim is to ensure patency. The moment we find patency, we'll stop. But if we are not getting patency, we may have to go up to the level of the editors
Yes.
and clear it off.
Yes, because sometimes very thick
Mucosa.
and or very thick fibers are completely occluding the your editors.
Yes,
So
and
next
this
to my
is
next
the
not to
this-
open the mastoid. Satish, when not to open the mastoid?
when not to.
Not to open the mastoid in routine plasty.
Yeah. For if you are not treating for a chronically discharging ear, then is the difference. Sometimes you
But
repair a non-healing.
dry perforation in the complete dry perforation for a long time. I think
Even I would not leave that. The reason is, if it is a dry perforation for long time without any editor's blockage, my patency I will get very superficial in few seconds.
Okay.
There is no harm in establishing that rather than relying indirectly, number one. Number two, we have seen even in a long-standing dry perforations, in some number of cases, that it has blocked because of the thick mucosa, adhesions, or tympanosclerosis. So, in dry perforation, even if you find that the editors is patent, if so, it won't take more than few seconds to establish it. So then why not to do? Because this gives you 100% opportunity to establish on table. On table that your editors is patent. Why to take a chance? We are striving for results close to 100%. And we have an opportunity here to establish this on table 100% rather than relying indirectly. That's why.
So, do you like to take the CT scan in the patients of simple CSM, what you call tubotympanic type? When you go
for safe CSOM, generally we don't get the scan done. For safe, like this. Just for cholesteatoma, it has ample of benefits, you can say. But here on the CT scan, on basis of the CT scan, pneumatization, again, gauging the patency of the editors is an indirect sign. So why not directly go to the site and check it once your patient is on the table and you have 100% method to confirm that. Why to leave that 100% opportunity? That is our thinking.
there are a lot
Philosophy.
of ENT surgeons are also doing endoscopic ear surgery. And there are a lot of ENT surgeons who are doing and they are switching over to endoscopic ear surgery. There's no doubt. This is not a bad thing. It's also a good technique.
Yeah.
How they will approach that case?
So indirect. You put your 45-degree endoscope to look at the editors.
But that is not a good sign. That is not a very good sign to.
Majority of the time, they will be correct, but
Majority.
still it is not 100%.
Yes.
Now, once you check the patency, there is a cautionary tale I would mention here. Stay superiorly close to the tegmen. See what I have exposed?
Tegmen is in.
Yeah, I have seen complication. People looking for this patency went inferiorly by mistake, kept on going and damaged the facial nerve.
Facial nerve, or they can even drill.
That's a disaster. So don't get distracted. Stay close to the tegmen. If you stay close to the tegmen, you are away from all these critical structures. and keep widening from above. See, this is more like a sclerosed mastoid.
Actually,
So
some
keep thinning the canal wall as you go down. Keep widening as you go down. You are not supposed to create a well.
tegmen should be your first landmark in mastoid surgery.
Yes.
Tegmen should be your first landmark. One should always check for the tegmen and proceed accordingly.
That is the best safety landmark. The best landmark to keep you oriented all the time, that you are not by mistake inferiorly placed.
And when the tegmen plate gets ruptured due to drill, there's nothing to worry about that.
Yeah. Small defect, you don't need to bother.
Actually, what we have been taught in our earlier days, don't touch dura, don't touch sinus, stay away from the sinus, stay away from the dura, stay away from the facial nerve.
That often leads to leaving the disease behind.
Yes.
Sir, Satish Jain sir always says, the only and the best way to preserve any structure is to positively identify it. So that leads to more safety. Am I right, sir?
Always,
Yes,
yeah.
Right.
Always. Yeah, you'll see in other demonstrations today. Identify the landmark which you want to protect. See, it is not a big mastoid.
This is sclerotic mastoid.
See,
Dura is also low
to
lying.
protect yourself.
Dura
Another cautionary tale. See,
hello, Satish, is it not low lying dura? Don't you think
little you can say.
It is low lying.
Doesn't make any difference as long as you
This
keep
is
your
very
landmarks
new,
in
but it
view.
makes difference for a new.
एक साइड छोटी दे दो. Now another cautionary tale. You see this. Another landmark to keep in mind during this step is the annulus. Regarding the depth,
Yes.
don't keep drilling without keeping the annulus in view once you go deeper. That will give you a very good idea about the safety, about the semicircular canals. All critical structures are below the level of the annulus. Can you see?
Yes.
We are quite lateral to the annulus. Can you see?
Yes.
And see the air cells coming into the picture.
This is thickened mucosa.
Can you see the thickened mucosa?
What is your take on this type of mucosa?
Yeah. I will do everything to ensure my patency. That's it.
Type of mucosa, almost arachnoidal in character. Lot of fibrous like mucosa. There is no clear-cut mucosa. And
The quality of mucosa depends upon the length of unaeration, on the incidence of repeated infections, all those things. So that determines the quality of the mucosa. Now see,
inflammation, nothing more than that.
as I go deeper, that's very important now. As I go deeper, see this?
Pleasant light, the picture says.
Yes. See this, it is completely blocked.
Yes, completely blocked.
See this mucosal bed, completely blocked. And if you graft such a ear with a dry looking perforation, it is inviting failure. Certainly inviting failure. Use your blunt instrument. Separate the mucosa. The most important is to use the proper instrument. See this?
Yes.
Still no patency at all. See this. Now how to reach further? Keep reducing your size of the section, your size of the bird tip. Now see what is hidden from both sides. How the editus is hidden? With this canal wall, the thick canal wall. Can you see? Hello?
Yes, it's very clear.
Now,
lot of bone is still to be drilled.
Carefully keep thinning this canal wall from behind. From lateral to medial. Medial is your incus. Be careful.
Yes.
See how I'm going anteriorly? I'm creating a ledge of bone. and then remove that ledge under vision. See this? More and more, we are exposing the editors now. See, my step was not
Would you like
mastectomy.
to take help of endoscope in microscopic surgery, Satish?
Now the things are crystal clear. I am directly visualizing through the microscope without any need of any endoscope. I'll ensure the patency very soon. See, this editor's completely blocked. If you graft such tympanic membrane without looking at the editors, there's no fun in operating. This is almost certainly inviting the complications.
Very thick mucus.
See this mucosal bed. Maintain the integrity of the mucosa. That is most important. See the thick mucosa wrapping, the incus is wrapping.
Now it is
Such a-
maintained.
Yeah, I opened up the
So
mucosal
how will
bag.
you ensure about its patency? Because it is still, again, it may lead to closure of the patency.
Yes.
Because
So
all around
if you have damaged the mucosa, peeled off the mucosa, you can leave a small silastic strip there. If you maintain the mucosal surface, don't need to do anything. See now what I'm seeing both the spaces.
Yes. Not very clear.
Most important is this inferior incudal space.
Yes.
This is my inferior incudal space, and I can see.
Will you like to drill little bit of posterior superior canal wall from inside?
Not really. No need to. I don't disturb that, posterior superior canal wall for the reasons I tell you.
So what's the reason behind that?
Yeah, I don't want to give any additional, possibility of retraction in future. So don't want to maintain the, disturb the integrity of the, canal wall, patli. So I can see my ball probe going between through the space very carefully without disturbing anything, and I can see my patency coming very nicely. Now, how to satisfy yourself with the patency? How to ensure an adequate, work done?
Free water
Give
flow.
me free flow. That is most important. See this.
Free flow and water level should be same on both the sides.
Yes, same. It should be same. See this?
Yes, sir. It is absolutely patent now.
Brother.
So one thing more, we have seen that you are not a strong proponent of canalplasty. Would you tell us the reasons why you avoid doing canalplasty and majority of
I
cases?
tell you one thing. We this entire flap. Hey, what happened? Disconnected. Hello.
Yes, sir.
See, we raised this entire almost 360-degree flap attached to the part of the superior canal wall, part of the malleus. We'll reposit it back. There is no as such named vessel supplying this entire flap. How is it all working?
Yes, sir.
Why it is not getting necrose? Because the blood supply to this entire tympanomeatal flap comes from the underlying bone through the vessels in the Hebosian system of the bone. Okay?
Yes, sir.
And that is how, even if you bring this graft out of the flap, out of the field, into the saline outside the body and replace it, it works very well.
Excellent, sir. Yes.
So, during I am not against canalplasty to limited extent. At some point of time, if I find a hump or something, I'll not mind, I'll not think twice if it is really obstructing my view beyond, to remove that with the diamond drill or so. But doing a extensive canalplasty all around as a default is basically using a diamond drill, basically intentionally obliterating all those Haversian channels which can devascularize your graft later.
Yes.
So we are never, strong proponent of canalplasties, large canalplasties. Just limited canalplasties, no issues.
And that also you would prefer doing with the cutting burr instead of diamond burr, because cutting burr obliterates
Yeah,
the.
but you have to be very careful.
Yes, sir.
See the free flow now.
Absolutely free flow.
Can you?
Yes, yes.
We can appreciate, sir. Very well.
Ashwini boss,
Yes, yes, yes. Very good. Very excellent.
this is my level of, finishing this step using. See now, we have gone up to the editus.
Yes.
Can you see?
Yes, it's very clear.
You can see the glimpse of the incus. See this here?
Yes, it's very clear.
And that is the space medial to the incus with mucosa preserved. And that is leading to the middle ear from here. Okay? So, and things should be thoroughly checked, cleared off, completely ensured, and then move on to the next step. Okay?
Yeah, hello.
Now the next step is grafting. Again, as I said, we are striving for the betterment, more and more better results. That's what we are learning from each other. And in the next step also, we do something we feel it improves the integrity of the graft.
Okay.
Or you can say it is never inferior to any other technique if you don't do so. Now see, I have not harvested the graft so far. And my next step is to
Take the graft.
harvest the graft. We call it bed-to-bed grafting. The graft we harvest, we call it as a fresh graft. It's not dry graft, wet graft. Dry graft means you harvest the graft below, make it dry under the lamp or leave it outside to get dried up. Wet graft is you harvest the graft
Keep it there for some
and make it later on before using it. This is fresh graft. See, the quality of graft matters because ultimately it is going to get revascularized. And the integrity of the collagen tissue in this fibrous layer is important. The fibroblast is important. So our idea is to minimize the damage to the fibroblasts. So what we do, why we call it bed to bed? Are you getting the picture?
Yes, yes, yes.
See, what I am removing is the innominate layer of the temporalis fascia.
Superficial fascia, what you call loose.
Intermediate layer, and exposing this true temporalis fascia. Can you see?
Yes, very good fibrous view. Fibers are looking very nice.
Yeah. See
Sometimes
the
fibers are not visible in the temporalis fascia. No, not in all cases that this type of very beautiful graft is there.
so this is temporalis fascia, true temporalis fascia. Now we need temporalis fascia as a graft because it is the best. Whatever free graft you use should have a least metabolic requirement to survive until it acquires vascularity. And for that, the temporalis fascia is considered to be one of the best graft material. We don't need any muscle. We don't want to traumatize muscle or anything. See this? I'm injecting saline to lift it off the muscle to prevent the muscle getting traumatized while making the incisions on the graft or anything. Because if the muscle get traumatized and you keep cauterizing for the bleeding and all that, lead to scarring. Sometimes many patients complain of persistent pain in this region, which is very, very bothersome to the patient as well as surgeon. So follow the atraumatic technique. That is the best way to prevent that to a certain extent.
Sharp scalpel is the best.
Yeah.
Best.
And the size of the graft required, we, now with the experience, we gauze on the bed itself so that we don't do any alteration later. Okay.
We are taking a almost longitudinal graft.
Yes. My idea is to keep the graft length more than 1.5 times or almost 2 times the size of the perforation. See that without traumatizing the underlying muscle. That's how was the idea to inject saline. Now, see, lifting it off the bed.
There is also a small thin layer of fascia underneath this fascia.
Yeah, over the muscle.
All over the
That is the sheath of the muscle. That is the sheath of the muscle.
especially in the posterior part, but it is absent in the anterior part.
It is very, very important to keep that in view, that itself protect the muscle from getting traumatized. See the true fascia itself?
Hmm?
True fascia?
Rectangular flap, what you call it.
Can you see the true fascia?
Yes. Very, very nice.
This is my true fascia. This is the true fascia, and I am elevating it off the muscle. I want to keep this muscle along with its sheath intact.
There is a lot of fat tissue also.
Yes. As you go anteriorly, you will find more and more fat in the temporal bed, you know.
Yes. Anterior there is fat.
Yeah, so that is my graft. That is my graft. And what I will do, I will bring it to the new bed. Can you see this?
Yes.
Turn it upside down with my more raw surface is going to face the underneath of the tympanic membrane.
Okay.
Just to have more and more, surface tension effect.
Sometimes there is a lot of bleeding from the basically inferior part. How do you control that bleeding?
Inferior part of the
External canal. From there, the very strong fibrous tissue attachment where if you have pointed, there is a dip in the basically posterior inferior.
yeah. Just leave a adrenaline ball for 5 minutes. Rather than fiddling with that.
Because long back ago at Ranchi workshop, Viskarma sir was doing this tympanoplasty. Yes, I still remember that incident. Actually, bleeding could not be controlled.
Yeah. Put a pure adrenaline ball for a few minutes.
He took every.
Have patience.
He took every measure. He did everything, and still pushing didn't stop.
It has to. It is not very significant most of the time. It all requires patience. That's it. Now see this graft. Can you?
Yes.
With this technique, the best part, the grafting is the simplest of all steps. The first step is advance the graft into the middle ear adequately, as it has to go above the mucosal layer anteriorly. So it should be adequate advancement. See this. With experience, you know how much need to go. You can further manipulate for that matter.
Okay.
So this first step is advancement into the middle ear. Number 1. See my flap?
Yes. Very nice.
See such a fresh graft without being traumatized at all. Now I will reposit my flap initially.
Okay.
and bring this graft. Second thing is, see this graft. This is the flap, this is the graft.
Okay. Very clear.
Now is the attempt to bring this graft underneath the malleus. This is very important.
Yes.
And you can easily now manually, I will show you. This is very, very important step. See the surface tension effect.
Yes, sir.
It literally holds so well the two layers each other. Now, first of all, see where your malleus is. Look at the malleus. Can you see down?
Yes.
And
Malleus visual there.
yes, slide it underneath the malleus, under vision. See that?
Because that to avoid lateralization of the graft.
Yeah, this is a very, very important step. Can you see this now?
Yes, yes, very clear.
Graft completely, glided underneath the malleus handle. Okay? And now we'll reposit it back. See this.
Yes.
Now I will make this posterior flap and the graft one unit. And that is to take the advantage of surface tension. See this now. See this now?
Very clear.
One unit together. So that when I manipulate anteriorly, it is not going to get disturbed. Now anteriorly, I am raising the anterior flap again, bringing the graft in bed. Can you see this now?
Yes, very clear.
So it is so simple now. You have practically fixed your graft and flap behind. Now repositing your graft anteriorly and now bringing your flap back into it. Can you see?
Yes, very clear.
So your graft has come in between the mucosal layer below and rest of the two layers of this flap above. See this?
Yes, very clear. Any
Now-
special precaution in this? Any special precaution in when keeping your anterior flap, replacing your anterior flap in the area?
See, any precaution regarding?
Special precaution regarding reposition of the flap, especially in the anterior part.
Not really. The thing is, everywhere you keep the integrity of the flap, well.
I think margins of the cut margin and flap margin of the flap and margin of the external canal, especially anterior, must come in proper contact.
Yes. So now we have reposited our flap back by and large. We'll check now everything is in order or not. See that?
Yeah.
That is your initial grafting. And you can see your handle of malleus. See the graft. See the tenting of the tympanic membrane. And see the antero-inferiorly this cone of light as well. Now we'll check every corner 360 degree that whether our this sandwich what we have created, the mucosa, graft and the flap, whether this sandwich is in order or not all through. See that? See the cone of light, everybody?
Yes, yes, it's very clear.
Now I will check everywhere whether this sandwich is intact or not. See this. See my graft is between underneath the malleus and lateral to the incus. Can you see the incus?
Yeah.
Everywhere, underneath the flap, posterior superiorly, posteriorly and posterior inferiorly. Can you see? And see this inferiorly, this is lying on the mucosal layer. Can you see the strip of mucosa? Below.
Yes, sir, we can see them.
So I am just manually repositing this flap on the mucosal strip. Now this is under vision reposition of the flap. That is very, very important. Now I will elevate inferiorly again. Posterior inferiorly. See my graft and flap together.
Yes, sir.
That should be all the way. See these two graft and flap above elevated
It is
and the mucosal layer below. Can you see?
mucosal layer is well supporting the graft and the flap.
Yes, see, just reposit like this. Automatically it has to stay. Now this bed, mucosal bed, is an amazing bed for the graft. This will not allow the graft to get dislodged. The mucosa will creep underneath the graft. The epithelium will creep over the graft. Now coming anteriorly. And this graft being a fibrous layer will remain in place. Now see anteriorly, again the flap and the graft, I will join them, making one unit anteriorly. Can you see?
Yes, sir.
And that is the anterior mucosa. You can see very clear.
Please centralize. Yes, sir.
Very clear?
Yes, sir.
And now I will reposit it. Another important thing that is always, I've been asked about the use of this fresh graft, the handling of the fresh graft. There's always, a lot of question about difficulty in handling the fresh graft, possible difficulty. Believe me, those who have been doing, dry graft, one of the reasons behind doing the dry graft is the ease they consider. Believe me, this fresh graft follows your instruction, your moves so well. It is much easier than dry graft to handle.
Yes, sir. Handling of wet graft is much easier.
Yeah. And many a time the dry graft becomes so stiff, difficult to handle, and that can be certainly avoided. See my anterior superior reposition. Can you see?
Yes, sir.
The mucosa, these two layers, and all the way we have seen posterior superior to anterior superior, that our sandwich is in order. Everywhere the mucosa is below the graft and rest of the two layers are above the graft. That is what we wanted to ensure in this technique. Can you see?
Yes.
Any doubts?
No, sir. It has been very well explained. And we can see such beautiful new tympanum.
See, this is fresh graft and or graft or fibroblast of the graft is minimally disturbed, and we hope them to work better, faster recovery. And this cone of the light you can see here, and this graft is so well secure. Can you see?
Yes, sir. It is not going to go anywhere.
Yeah, this can neither lateralize or no medialize. This is how it works so well. And we have our long-term results. See, all the edges of the incision should fall in place back to prevent granulations. Is Ashwani boss there?
I just went out to attend a call.
So that is, it looks like the graft is vascularized.
Yes, sir.
The look is so good. And now what I am, using is the blood soaked gel form on the periphery of this entire, racket. It's like a
White
tennis racket.
blood soaked gel form.
Blood has natural fibrin. We saw in the solution of ciprofloxacin dexamethasone as well. The antibiotic, steroid and blood to minimize the inflammation, keep the things in place. See everywhere. Everything should fall in place automatically.
Yes, sir.
And that's the beauty of this technique. See the cone of light.
Very well appreciated, sir.
And now we can. So this was all about the
Interlate impanel.
interlate tympanoplasty. The goal is to, inspect the entire medullary cleft or circular chain, ensure the patency. In this case, interestingly, had the great example of editus blockage. Fortunately, we got this case for demonstration.
Yes, sir.
And see how the editus was cleared and how the graft has been placed. So we have now intact drum. See the water level.
Yeah, you can see it moving.
That's the,
Airtight packing.
airtight. So this was about the first case.
So what is the next case that you want to demonstrate now, sir?
Thyroid? Color? So the next case is a thyroid. We'll keep, alternate ear, nose and throat cases.
Yes, sir.
So the first case to start was otology. We'll take stapes later. Now is the head and neck case, thyroid. We'll keep submandibular gland later. Then we'll have nasal cases, including rhinosporidiosis and JNA. So according to, and we'll have larynx case also. So depending upon the requirement, depending upon the scenario, we'll keep changing to. Finish. Thyroid ready. So next case is the thyroid. Quickly we move on to. Hello.
Yes, sir. Yes, sir.
So now with the first case, the momentum starts and we'll go quickly now. So this case is a thyroid nodule. इधर लाना ऑडियो, इस ओटी में लाना ऑडियो, इस टीवी पे
Thyroid nodule.
इधर ऑडियो.
Size of the thyroid nodule is small or this is bigger?
हेलो,
Is it small thyroid or big thyroid?
हेलो,
Hello? Hello?
हेलो.
Yeah, sir.
Yes.
What is the size of the thyroid nodule?
This is more than 4 centimeter, almost 5 centimeter in size. Huge one. Is a middle-aged lady and looks benign, though it is a little bigger. See, for thyroid workup, why we are operating all thyroid nodules? All nodules need not to be operated. So the concern is there are certain percentage of solitary thyroid nodule may turn into malignancy. And your initial workup should be able to pick up those cases which are actual candidates for surgery. Pure benign cases can be left without operating, and observation can be the primary treatment with serial, sonography and other thing to measure the growth and all. But those suspicious ones need to be operated, or those who are clearly malignant must be operated. So in pre-operative workup, there's a huge subject. Thyroid in itself is a complete, science.
Three different sciences.
You know, 2 years back, there was a 3 days only thyroid workshop, dedicated 3 days workshop in Tata. There was with discussion on workup, surgical management, follow-up, malignancy, everything in detail. So it's a huge subject. But in brief, the workup involves, besides the hormonal testing to rule out thyrotoxicosis, the main workup involves ultrasonography and fine needle aspiration. Can you hear me?
Yeah.
So ultrasonography is the most important tool to assess the thyroid nodule, and in the good hands with good sonologist, there are good chances you can pick up the malignant nodules. There are certain characteristics which favors malignancy, and all those need to be thoroughly assessed. So sonography is an operator dependent investigation, and you should have a good sonologist in the team to work for you and pick up those suspicious areas, nodules which need to be operated.
But sometimes it is even FNS is negative for malignancy. Surgical assessment turns out to be malignant.
Sometimes what?
At times, generally FNS suggests there is no malignancy, and after operation, the histopathology tells that it is a malignant case, that is papillary carcinoma or other carcinoma.
Yes, yes. So to improve the sensitivity of all this, your point is valid. Nothing is 100% sure in the preoperative workup to say that it is malignant. But yes, in majority of the patients, you can reach to a correct diagnosis by means of a good sonologist. I told you this is operator dependent investigation, and good as fine needle aspiration. Again, need to have good pathologist in the team. Again, it is an operator dependent investigation. And more importantly, those which are clearly benign, by all means, by taking care of the family history, the nodule characteristic, age of the patient, and other clinical features, those benign appearing nodule, both on sonography as well as aspiration, taking everything in consideration, not a single investigation, you can reach to a conclusion that it is really benign. Okay. Now, the suspicious are the areas where you need more focus. Like if you have a sonographically, suspicious nodule, you need to have a proper aspiration from that suspicious area. Yes. And in those cases, you need a good sono-directed FNAC.
Guided FNAC.
Yes. Otherwise, you can take aspiration from area which is not looking malignant, and you can, term it benign. Okay. And like you mentioned, later on it turns out to be a malignant one.
Cytological aspiration should done only by sonologist.
Yeah. So in those suspicious areas, so like patient may have a multiple nodules, sonologist will tell you which nodule is suspicious and that need to be aspirated.
Yes. So ENT go for FNAC.
Yeah. So our take is to take all these investigation protocol in in a sequence, not all together. So first get ultrasonography done to see the entire characteristic of the entire picture, and if you find anything suspicious, if it is purely benign on FNAC, then you certainly don't need a sono guided FNAC. But in complex situation, complex nodules, you should take the help of the sonologist to take the aspiration from the right space, right area.
What is the role of immunochemistry in this type of nodules?
Yeah.
When you like to go for immunochemistry?
Not only histochemistry, it is all about the nowadays with the genetic studies.
Yes.
See, the idea is to pick up correctly the malignant nodules. Got my point?
Yes, yes, yes.
If you miss the malignancy, then it is a disaster. The whole aim of the workup is to pick up the malignant nodules for surgery, to avoid benign nodules for unnecessary surgery. So the goal is very clear. Are you getting the picture?
Yes, we are getting the picture.
See, we have already raised the flap.
We have not seen anything regarding that flap elevation. We are directly
Yeah.
seeing the tumor.
That we skipped. That we skipped. See, this is superior. This is inferior.
I think
This is right side.
decrease the
And this is
magnification.
left side. This is midline.
Little-
Okay.
Little zoom out, Satish. You
Yeah,
can
this is the lowest zoom I can say.
lowest zoom using Vario.
Yes, S88. With my, varioscope, the focal length, this is the highest. 400 plus, around 440.
Yes, 440.
Yeah. See now, to orient you, this is superior. Can you see?
Yes, this is superior.
This is inferior. This is right towards me. And this is midline and that is left side. Okay.
Yeah.
So you can see this large nodule on the right side. Can you?
Yes.
So here we are going to discuss the surgical technique in detail. Okay.
Okay.
And this surgical technique in this thyroid will be doing almost a hemithyroidectomy, will revolve around preservation of certain critical structures. Tony.
Sir, do you always prefer to use a microscope in thyroid surgery?
Pardon?
Do you always prefer to use a microscope in thyroid surgery?
Yes. For the reasons I am going to tell you, it's not about the removal of the thyroid nodule or thyroid gland or whatever. It is removal along with preservation of certain critical structure. That is what my focus is. Retractor. There are certain critical structures we must preserve in all thyroid cases. The number one is the rectal laryngeal nerve. Then comes the parathyroid glands. And then comes the external branch of the superior laryngeal nerve. Even that is very important for many people.
Yes, sir.
Okay.
Especially the professional voice users.
Yes, 100%. So this is the midline. Can you see the midline here?
Yes.
And see the anterior jugular vein being prominent over here?
Yes, sir.
Yes.
So what I will do, staying strictly in the midline.
Very lowest magnification, Satish.
Yeah. This is lowest for this microscope here.
Actually, here it is.
See,
you are seeing
yeah. I see. This will help you once we reach to the critical area, because anyway that requires high magnification. So this initial part, I'll keep orienting you, boss.
Okay.
See what I'm doing? Splitting in the midline. Can you see?
Yes.
I'll keep changing microscope focus. I'll keep orienting you all the time. I'm in the midline and what? Lift the fascia. The best thing is
Lift the fish.
don't poke your cautery inside. Just lift the fascia. Take the advantage of the full incision.
Yesterday, I was watching a video of thyroidectomy by someone, and he removed both of the anterior jugular veins.
Why to unnecessarily
Right.
to give
Both
edema
ends
to the flap?
by tying superiorly and inferiorly, and kept it.
That is not needed. Yes, sometimes in large, nodules or goiters, in large one, bigger one, you need to, to improve the exposure, you need to do that, but otherwise it's not required as a routine part of the surgery. Now see what I'm doing. I am dividing this midline raphe. Can you see?
Yes, sir.
See, without traumatizing the muscle.
Yes, sir.
And this lateral muscle which we separated, see this?
Yes,
This
sir.
is sternohyoid.
We are identifying and separating the sternohead of both the sides.
See under microscope the beauty. Pakadna yaar.
With the naked eye, it is sometimes difficult to identify this.
Yeah. You can always take the advantage of microscope. See this. So this is the most lateral muscle. I hope you are oriented.
Yes, sir.
This is the most lateral part of the surgery, and this is the facial plane. And can you see underneath?
You can see the thyroid gland.
Yeah, I will show you the another layer, thin layer of the muscle underneath the original, the first layer.
It is very important to come in the,
सूता क्या रहता है?
otherwise it leads to bleeding.
Yes. Now same way, elevate from this side. करना. Serious. Elevate. Utilize the full incision. See, a good exposure make your surgical life much easier. Can you see the entire flap being incision being utilized?
Yes, sir.
Yeah, leave it. Now see the two layers of muscle, sternohyoid, and see you can push, and see this second layer of muscle right on the gland. This one, this second layer of muscle, this one.
There is always a very thin layer of fascia between
Yes.
the thyroid and the sternum.
Yes. See this, I will show you this thin layer of muscle separately. See this thin layer of muscle, can you see?
Yes.
This is sternothyroid. Can you see this?
Yes, yes, very clear.
Now the gland being exposed. Now the first step, very, very important. Be careful. See, all these vessels coming laterally are never arteries.
Yes.
These are veins, these are more prominent as the nodule is bigger in size.
Yes, yes. Bigger the nodule, bigger the vessels.
Yes. Can you see this big vein?
Yes, that middle.
This
thyroid.
is middle thyroid vein. You may not find it always so prominent, but since it is a bigger one, it is really prominent and you need to tackle it properly. फोन किसका बज रहा है? See this vein?
Yeah.
So I am purposely taking this vein to prove. This part I will coagulate that this is going to come with the gland. Like it. So idea is to stay deep to the muscles. Bipolar. Bipolar. दूसरी लगाना है. बुलाना ही चेंज कर.
Hello, Satish.
Yes, boss.
Is that a vessel?
No. It's just a vein. Nothing else. I was just waiting for the right instrument. See, now the most important why I elevated this is to go into the right plane. That is most important. And what is right plane? Is this avascular plane. See this?
Yes.
This avascular gutter. Can you see?
Yes, very clear.
Lateral to the thyroid with the great vessels lateral to it. Can you see this plane?
Yes, very clear.
This avascular, this avascular plane. This is most important to attain at this point of time. Now see, there are different levels. You can see very carefully. If you are right in this avascular plane, everything will come automatically in front of you. You don't need to look for the inferior thyroid artery. You don't need to look for the recurrent majority of the times. If you are in the right plane, see carefully. This is still the same facial plane or the part of the muscle. Can you see?
Yes, sir.
This is lateral to the great vessels. Can you see the great vessels below?
Yes, sir.
So I am further improving my inferior exposure to show you something in the simplest way. See this. Now having seen this avascular plane, the first structure I need to see. First structure I need to see is the inferior thyroid artery for many regions. See this. The inferior thyroid, why I said the earlier vessels as the, the veins, why not arteries? What is artery? Clear nahi aa raha kya?
We can hear you, sir.
Yeah. How is the focus now?
It is better.
It is better.
See now, my inferior thyroid artery comes from deep carotid.
Yes, deep to the.
It's a part of the branch umbilical trunk. It's given off from the part of the subclavian. Can you see here?
Yes.
This vessel is coming from deep to carotid. It runs carotid and turns horizontal in the middle of the neck. Can you see?
Yes.
And then goes towards the thyroid gland. This vessel is important to see here for the reasons that it should not be ligated at the stump level so laterally. And this is the principal, blood supply to the parathyroids as well.
Yes.
We could
Basically,
see
this is
the
the
glimpse of the
principal supply of the
recurrent also.
parathyroid.
Can you see? Now this is a very, very important, thing to identify the recurrent also. Landmark. The recurrent laryngeal nerve, I can see the glimpse. Can you see the glimpse of recurrent?
Already seen.
Without even dissecting. Because you are in the right plane.
Let's say bifurcation, when the bifurcation is seen.
Yes. And see the right plane. Why? See, this is the recurrent laryngeal nerve. I didn't even try to dissect it. Can you see?
Yes, sir.
Sometimes, yes. Sometimes.
Because you were in the right avascular plane. Got my point?
Yes.
Now, what is this area? Once you have seen the inferior thyroid artery, this triangle is Lore's triangle.
Lore's.
What is Lore's triangle? See the trachea here.
Superior thyroid.
See trachea here.
Superior
See
thyroid.
the common carotid and see the inferior thyroid artery completing this triangle. And this Lore's triangle is the one through which this recurrent laryngeal traverses. Can you see very clear?
Is it anatomical triangle or it is just when we dissect it appears as a triangle?
No, it is a triangle described by Lore, the great head and neck surgeon.
Yes, but it comes only when we dissect.
Yeah, but so first you dissect, see the trachea you can see anytime.
Yes.
Great vessels you can see anytime.
Yes.
Once you see the inferior artery completing this, you need to look for this recurrent right here in the triangle. Number one. Number two, if you have the right avascular plane, this nerve automatically, comes to your visualization. Third thing, in any given situation, you are not able to see the nerve. It is advisable to look for the nerve as inferiorly in the triangle as possible. Suppose you don't see the nerve here, like what you see in this case. I would prefer to look for this nerve at the inferior most part of the triangle. The reason being, I am operating on the right side.
Maybe.
Many a time means not commonly, in less than 1% situation, it may be non-recurrent. And you don't know pre-operatively because you don't really get CT scan always done for the thyroids. This recurrent laryngeal nerve in normal situation, it loops around. See, it is given off in the upper part of the chest. On the right side, it loops around the subclavian artery and wings around and come back in the neck. In the left side, it is much lower down. It is given off little lower down and wings around the arch of the aorta to come back in the chest, neck. Okay.
That's it. That's why it is very near to the.
In situations of abnormalities of the subclavian vessel, subclavian artery, this may be a non-recurrent laryngeal nerve, wherein the nerve is given off right in the upper part of the neck and comes like this in this direction to supply the larynx. It enters to the it enters the larynx where the upper part of the recurrent enters here and then goes to the larynx. So it comes like this. So in that situation, you may not find this nerve in this plane. Now, why I said you need to look for this in these situations or all those situations when you are not able to find this. Why not superiorly? Because superiorly it is often branched before entering the larynx. Quite often it is branched. If superiorly you find one of the branch, finding at the nerve itself, you may ignore the other branch. This nerve is always in a single trunk inferiorly. So in all those difficult situations where you are not able to find the recurrent laryngeal nerve, must start the dissection inferiorly. Can you see this?
Yes, very clear.
Now see. See the nerve very clear?
Yes, very clear.
Now see the relationship. Why I said inferior thyroid artery should be seen before. Many a times I have shown in demonstrations this nerve passing in different relationship with the artery. You must have seen in your life the nerve passing deep to vessel, nerve passing through the branches of the vessel, or the vessel passing through the branches of the nerve,
Yes.
or nerve passing lateral to it. It can be any relationship. A lot of variation. You look at the studies done and see in this particular case, very important, the nerve is passing lateral to the vessel. It is not so common otherwise. See? Can you see?
Yes.
Your inferior thyroid artery is deep to nerve.
Yes.
Your inferior thyroid artery is
Good to know.
deep to nerve, and that is something important. Otherwise, if you are not aware of this fact, you may injure it. While handling the vessel, sometimes if suppose bleeding happens to occur, in order to control the bleeding, you
What
may end
I
up damaging the nerve.
Satish,
Yes, boss.
hello?
Yes,
What I
boss.
said, when the artery passes lateral to the superficial to the nerve, there is always a branch lying medial to the nerve. Very small twig of.
Yeah, there could be, I told you, n number of variations of this relationship between these two.
And that vessel is very difficult to control once it gets cut.
Yeah. So all these vessels close to the vicinity of the recurrent or the nerves, you have to be careful. See the nerve,
Yes.
and
yes.
see most importantly, it is dividing into branches. Can you see?
Yes. Very clear.
And that is the beauty of microscope. Now, there are other things which are very important. I would say most important to preserve in thyroid surgery are the parathyroid glands. If you happen to remove in a total thyroidectomy all parathyroids, it's a disaster. It makes the patient literally crippling with a permanent hypoparathyroidism that is more crippling
Then the disease.
than the thyroid cancer itself.
Okay.
Thyroid cancer majority of the time are well differentiated and do very well. Their prognosis is measured in decades. With the permanent parathyroidism, it is disaster. And how can you pick up the parathyroids? Now let me tell you. Keep your eyes, focused. How you can easily pick up, because identifying the parathyroids is always challenging.
Yes.
Challenging for many reasons. Let me tell you the reasons. Number one, the location is not constant. These parathyroid develop in the embryo and descend in the neck towards the thorax, And at any point of time or any place where the descent is, stopped, arrested, that is the final location of parathyroids. It could be many a times in the mediastinum itself, in the thymus, in the gland itself, in the lower part of the neck, right from the upper part to lower part, they can be distributed anywhere in the neck. But by and large, superior parathyroids are more constant in location than the inferior ones. And another thing is, wherever the arrest is there, is always symmetry. The rest is at the same level on both sides. That is something, relieving. So to pick up the parathyroid is always a challenge. They are so small, their color is variable. In the young patient, ranging from the caramel color to brown, to in the adult to the yellow color with more fat content. So the color is variable. In cancers where a lot of lymph nodes in vicinity, adding on to the challenge to identify the parathyroid further. Because sometimes you may, you are mistaken with some lymph nodes, sometimes with the thyroid tissue itself, sometimes with the fat. You never know whether it is parathyroid or not. This microscopic surgery, why, Farooq asked initially, why microscope? This is one of the biggest reasons to use microscope. To differentiate, identify parathyroids further, number one. And the best way to parathyroid, in my opinion, we have seen over the years, is to find the vessel going to the parathyroid. Parathyroids are extremely vascular, and there is almost always a network of capillaries over the surface of parathyroids. And majority of the cases, you will be able to find a vessel emerging from the inferior thyroid artery, coursing towards the parathyroid. What my point? With this microscope, if you are able to find that vessel coursing towards the parathyroid, there is no doubt, I would say no doubt remains in identification of the parathyroid at all. And to me, this is the most definite way of identifying the parathyroid. So that's why I told you, keep your eyes focused now and see what I'm going to show you. The most common location for the inferior parathyroid, let me tell you, is in the anteroinferior quadrant. What is that? See this recurrent laryngeal now? This is midline. Hello?
Yes, sir.
The inferior parathyroid by and large are inferior to the level of the inferior thyroid artery. Number one. Got my point? And number two, they are anterior to the plane of the recurrent laryngeal nerve in the most common situation. Not always, but most common. Got my point? Now, look, this is inferior thyroid artery. Can you see?
Very well, sir.
Can you see the vessel emerging from the inferior thyroid? Can you see or not?
It is faintly visible, sir.
Oh, come on, man.
Yeah, now it is better.
Let me increase the magnification. This is very, very important step. You can ask me 100 times. Can you see the vessels emerging from the inferior thyroid?
Yes, sir, we can see. Yes, yes.
Very
sir.
clear
Now,
or not?
very clear, sir.
Coursing anteriorly underneath the recurrent laryngeal nerve. Can you see this?
Yes, sir. Yes, yes, yes.
Can you see this and see this? Can you see this network of vessels over here?
Yes, sir.
Can you see there? This is inferior to the inferior thyroid artery and anterior to the level of the recurrent laryngeal nerve. And can you see this? This is the fat, pad of the fat underneath which is the parathyroid gland.
Very well appreciated, sir.
And this is my parathyroid. Can you see the network of vessels over the surface? This is my parathyroid, this one. See the capillary network over it. Can you see this? This one.
Yes, sir.
This is different from the fat. And see faintly, are you able to see the capillary network or not?
Yes, sir, we can see the capillary network.
That is the vessel coursing toward the parathyroid, and this is the typical caramel color of the parathyroid here, with a network of vessels coursing over the surface. That will never happen over the lymph node. That will never happen over the fat. Got my point? See
Yes.
the distinct parathyroid amongst all tissues. See the parathyroid. See the parathyroid with network of vessels over it.
Yes, very
Aren't
clear.
you? Ashwini boss?
Yes, yes, very clear.
That
No
is
doubt.
how you can
No doubt.
identify the parathyroid most definitely. Not only identification and preservation. It means nothing if you don't preserve the vascularity.
So we have to follow the inferior thyroid artery. So that will
Yes.
ultimately.
Suppose I happen to ligate the inferior thyroid at the stump over here before the branch to the parathyroid emerge. What is going to happen? That will end up devascularizing the parathyroid.
That will become devascularized.
Got my point?
Yes.
And this is something very, very important to understand. I hope it is very clear.
Yes, very clear.
Now, this is the inferior parathyroid. So we have identified
One thyroid, inferior parathyroid.
recurrent laryngeal, inferior thyroid artery in sequence, then the inferior parathyroid. Now we move on superiorly for two more structures.
Yes. Superior parathyroid and
Superior parathyroid and
external branch of
Yes. Yes, let me reduce the magnification now. Now see, these superior parathyroid glands are most often behind the plane of the recurrent laryngeal nerve, as contrary to the inferior, which are anterior to the plane most often, and superior are more constant in their their location as compared to the inferior one. And inferior, that's why are the biggest challenge in the central compartment dissection, and you can preserve the superior ones during the dissection, because your central compartment in dissection you need not to go high up to the level of the superior parathyroid most often. Any doubts, anything, any suggestions, please?
There is a technique. Hello. There is technique very much popular, that is capsular dissection technique of for thyroid.
Yeah.
Which they no need to search for recurrent laryngeal nerve, parathyroid, both all the structures.
Yes.
Because very safe.
Yes, there are many ways to
using that technique, but in that technique I am always very afraid of that. I left the parathyroid intact or not? There is always, but in this technique, what we see that we can assure that everything is in right place.
It is not only physical preservation of the parathyroid, it is important. The most important is the preservation of the vascularity.
Yes, yes, yes.
Otherwise, it is of no use. Now, coming superiorly, see this. Again, my superior parathyroid will be, will find
fat
in the bunch of, fat. And the level, most commonly the level is this. I can find the cartilage of the larynx above and the upper ring of the trachea. I can feel. So it is right at the cricotracheal junction.
Okay.
Behind the plane of the recurrent laryngeal nerve. And again, I am looking for that. This is inferior thyroid artery. The vessel there.
Very thin caliber vessel for the parathyroid.
Yes.
Sometimes very difficult to identify.
Yeah, that's why the microscope helps you. Microscope always helps you. So now what I can see now here, see this tissue.
Yes, yes.
See this tissue. This looks like the parathyroid to me, superior parathyroid here.
Yes.
With a lot of vessels running on the surface. See this?
Yes, yes.
The tissue, with the microscope, you can differentiate the parathyroid from the other tissues by means of vascularity over the surface. you can differentiate the, the lymph node and the fat from the parathyroid by means of the surface vascularity.
But once these structures are smeared with blood, it becomes very difficult to differentiate.
Yes, 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 yes. Now keeping this behind, see this with the vessels. Can you see?
Yes, yes, very clear.
What I will do now, bring my, the lobule towards me, the same side. Can you see here?
Yes.
Now, see how big the nodule was. Now, the last part and the most important, I would say, as far as the dissection is concerned now, for the professional voice user, is to identify the external branch. How can you identify that? You need to understand the course of this branch.
Along the superior laryngeal artery.
How it travels. Superior
thyroid.
laryngeal nerve comes from the uppermost part of the neck, just below the jugular foramen, from the vagus, and coursing anteroinferiorly towards the larynx.
Yes.
Before entering the larynx, it divides into external and internal branch. Okay?
Yes.
Internal branch above goes piercing the thyroid membrane to the upper part of the, larynx, the mucosa to the supraglottic larynx, and the external branch turns down along the superior thyroid vessels.
Yes.
Along the superior thyroid vessel, which run across the superior pole of the thyroid, and just before the thyroid pole, just before it enters the thyroid, it takes a medial turn to supply the cricothyroid. Okay?
Yes.
That is what we want to grasp. Look at the same anatomy here. I am pulling intentionally the gland towards me, the nodule towards me. See this? This nodule I am pulling towards me to open up this space. Can you see now?
Yes, yes. There is very loose areolar tissue in that area.
Yeah, let me open up the roof of this triangle. This was described as a Joll's triangle.
Triangle.
With the airway in the midline, the superior pole vessels laterally, and there is a step muscle forming another boundary. The biggest region, towards sacrifice or damage to these vessels is the handling the bleeding in the close vicinity. See this?
Yes, yes, very, very.
Now, what I'm trying to pick up is to see this superior pole, to open into this facial plane to look for the superior pole vessels. See this? Opening up.
Yeah, different types of external branch of superior laryngeal nerve.
Oh, there is a classification by this our top Brazilian head and neck surgeon. See now, I am opening up the, Can you see the number of superior pole vessels?
Yes, yes, yes.
This superior thyroid artery has number of branches,
Yes.
before it enters the superior pole, before it supplies the thyroid.
Don't you like powered instruments in this surgery, like harmonic, vessel sealer?
Harmonic is good, yes.
Vessel sealer.
Welcome, Dr. Prakash Munka.
Welcome, Sarji.
Welcome,
Munka
Dr.
Sarji,
A.P. Saha, sir.
boss of the boss.
Welcome, sir.
Good morning, sir. Now I am in the auditorium.
Good morning,
Hello,
sir.
आपको बोला था होटल से. Yeah. Yeah.
Good morning, sir.
आइए, sir.
Now, hello.
Yeah, please go ahead.
Sir, we are at the dissection of the superior pole of the thyroid for the external branch.
Yeah.
And what I've exposed is the superior pole vessels. See, I'm pulling
Yes.
the superior pole vessels towards me. This external branch running along the superior pole vessels leave the superior pole at a variable distance before the superior pole vessels enter the thyroid gland. And now, See, variable distance means, see this. Can you see this thin slant coursing horizontally? Can you see? Hello?
Yes, yes.
Let me open up some better way. Now, see, these are the superior pole vessels. See, these are the superior pole vessels. Number of superior pole vessels. And they don't enter the superior pole right at the pole, but goes to a variable distance into the superior pole. And this nerve has an amazing anatomy, leaving the superior at a variable distance. Variable distance means
Away from
if it is too inferior, means close to the pole, more difficult to preserve.
right.
If it is below the level of the superior pole, you can ligate the superior pole without damaging the nerve.
Right.
See now the variable distance. Let me show you.
Yeah.
And this is very, very close to the pole. I can see here.
Yes.
See the nerve coming from below.
Yeah.
See the nerve.
Yeah.
See the nerve taking a turn over here.
Yeah.
See, turn. And the pole is retracted laterally out, and see course of the nerve
Yeah.
taking a medial turn. Can you see there?
Yes. Yes.
That is the nerve.
Dr. Satish, what is the difference in antegrade and retrograde following of the nerve?
See, the idea is to establish the relationship of this nerve to the vessels.
Right.
I'll tell you the reason behind it.
Yes.
Earlier, the standard teaching was to clamp the vessel as close to the pole as possible
Right.
without looking for the superior laryngeal external branch.
Yes.
If this nerve is away from the pole more superiorly, you can easily preserve.
Yeah.
Assume that it is preserved, but that is a blind technique. Like Farooq mentioned, our policy always is the positive identification of the structure which we want to preserve. Can you see this now beautifully? Can you see this now very clear?
Yeah.
Can you see this?
Yes. Yes.
And now I will ligate my pole inferior to it. Can you see very clear now?
Yes. Yes. Actually, Dr. Satish, this was the technique in general surgery we used to follow without following the nerve, as you said very correctly. We keep close and we think the nerve will go down.
Yes. So that was the standard teaching initially.
And we have among us the head of the
Now,
surgery.
with the advancement in the anatomy, understanding of the anatomy,
Yeah.
advancement in the surgical technique like microscopic, we can take the advantage of this relationship and identify the nerve, see the nerve, protect it, and then ligate the vessel. See, this is what I did.
Basically, in general surgery, we never used to bother for the nerves and we used to keep away ourselves from the nerve in
Yes.
the anticipation that we won't damage. We have very renowned general surgeon, head of general surgery, Professor S.N. Jha, joining us. And sir, if you want to make a comment.
Well, when I trained in surgery, the trend was to keep away from the nerve, to
Yes.
safeguard the nerve. But nowadays, the trend is to identify the nerve.
See this nerve, very slender nerve,
This is the trend now.
very, very slender nerve. See this nerve? Can you see this nerve? This one? This nerve coursing to the cricothyroid, this one.
Yes.
So now with the advancement in the surgical technique, you actually identify it positively. And that is what I mentioned, that we are striving for the betterment. See, now the patients are very demanding.
Dr. Satish, you will agree with me. Once ENT guys took over this surgery, they always used microscope and positive identification. Whereas in general surgery, we hardly
Yeah.
use.
Yeah, because they are not used to microscopic surgery anyway.
Yeah.
And now this head and neck surgery being the domain of general surgeon, so you can't imagine the microscope will ever be propagated.
Yeah.
Well, 50 years ago used to be part of the general surgery, but thereafter a trend developed where cancer cases were all referred to either oncosurgeon or ENT surgeon. And the benign cases, the surgeons used to try their hand on it.
Yes. See the branch of the this thing. Can you see the branch of the recurrent?
Yes.
So you have to carefully under microscope preserve the nerve by keeping your tools away,
Yes.
using your bipolar. See this? Keeping the
Right.
nerve away. See, my nerve is going towards the larynx now.
Right.
It's being kept away here.
Yes.
And my gland is now, I can say, miles away from the nerve.
Yeah.
See my nerve very clear?
Yes.
See the branches of nerve. One lateral branch,
Yeah.
one medial branch, the parathyroid superior one, the inferior one, this inferior thyroid artery. This is the network of vessels and nerves you can see very clear now. Any doubts?
Not at all. Audience, any doubt? Any question? Okay.
See now, my nerve is away and my thyroid is away. Now at this point of time, I will take my inferior thyroid artery.
Right.
Once it has given off, see the branch given off to the parathyroid.
Yes.
Then it is crossed by the recurrent laryngeal nerve.
Yes.
And now I am going to ligate is close to the gland. See this.
This relationship and identification is most important.
So my ligation is close to the gland.
Yes.
That is what I want to propose.
Yeah.
After it has given branches, now I can identify.
Yes.
The other side I will remove with the specimen.
Yeah. This is basically to safeguard the parathyroid blood vessel.
Yes, exactly. Yes. You can see my inferior thyroid artery
Yeah.
ligated.
Yes.
Now the last is to remove your specimen.
Yeah.
And this vessel I will remove along with the specimen.
Yeah.
So now we have preserved almost every possible, the desired things.
Yes.
And here I will take my inferior pole now.
Yeah.
Inferior pole we again propose to be taken as close to the gland as possible.
True.
To protect the venous drainage from the parathyroid going to the veins lower down. These are inferior thyroid veins
Yes.
which drain to the left brachiocephalic.
Yeah.
This is my plane now.
Yeah. So beautiful.
Pretracheal fascia, that is again the condensation of the deep fascia.
Yeah.
See, my all critical structures are under vision and away.
Yeah.
See, all are behind there.
Yes. And you created a beautiful plane for dissection.
Yes, now everything is under vision. This is pretracheal fascia.
The microscope definitely provides an added advantage to identify all these structures.
Yeah, see, it takes little bit 10-15 minutes more, but this is something as an distinct advantage, I would say. which cannot be overlooked.
Especially identifying the branching of inferior thyroid arteries as they supply to the parathyroid.
Most important is parathyroid. See this plane? That is my plane. And I have taken the isthmus also. The classical hemithyroidectomy is basically lobostomectomy. So now soon I am going to complete the dissection.
Yes.
See the entire trachea now, bare.
Yes.
Sir, what
So
is your
again-
take on the use of harmonic scalpel? Ashwini was also mentioned.
Good. It expedites your procedure as well. Because at the same time you can cut, coagulate everything, and very safe on the harmonic principle. It is ultrasonic principle. It is safe to the nerves. So you can work effectively in the close vicinity to the nerves as well. Carefully. See now the
Yeah.
recurrent with these both branches. See
Yes.
this?
Yeah.
Parathyroid superior, inferior here. This is the branch going to, and external branch here. This is the external branch.
Yeah.
And this is, and now we will take this and finish our surgery. Okay. So, Bandana.
Our
So we finish this step, we'll close it. Bandana.
Our President-elect Dr. A.K. Thakur has also just joined us. We welcome you, sir.
Welcome, sir.
An eminent surgeon of Professor Bhagalpur, Professor S.N. Jha. So he is also with us. He's watching your entire surgery. He's mesmerized by your skills.
I'm very impressed.
So what is the next case that you plan to show us?
ये आया था और ये अभी अभी एडमिट हुआ है ये जो है ये माइक्रो एक्सीजन की है
Hello.
Sir,
Yes.
Yes, sir. So now we move on to the next case. And next case is another interesting one. It's a young male, 13-year-old, presented with nasal bleeding. 13-year-old presented with nasal bleeding. Endoscopy revealed some nasopharyngeal mass. In an adolescent male presenting with obstruction, some bleeding with a mass in the nasopharynx, points out to none other than
angiofibroma.
Angiofibroma.
KNA. And that is how most of the time you can make your clinical diagnosis. And most often it is correct, but not always.
Satish,
So,
hello.
yes?
Are you relaxed?
Yeah, absolutely.
Okay.
So, most often you are correct in your diagnosis by clinical means, but not always. And to reinforce your diagnosis, you need to substantiate your diagnosis with something, and there comes the role of radiology. Because once you suspect JNA, you are not supposed to take any biopsy or anything because it has a propensity to bleed. And you can never take that chance in a patient with a tumor with a bleeding mass. So the radiology has a very, very important role, and the most important radiology is a contrast CT scan. The CT scan will tell you any enhancing mass, any flow voids, vascular lesion, and the typical location and extensions which are classical of JNA. It has a characteristic pattern of spread, which itself is diagnostic. It's not that JNA arises somewhere and is spread somewhere. It spreads in a circumferential manner with predilection to certain areas. That is how it is diagnosed. And we have a good CT scan as well as the MRI. So first of all, to save the time, I'll come directly to the MRI with certain findings, certain, the sequences required from the MRI. This year we diagnosed 8 cases malignant, which was initially referred to us or came to us with a diagnosis of suspected diagnosis of JNA, which were not actually JNA. Nasopharyngeal mass in young patient could be something else as well. This month only we diagnosed one hemangiopericytoma, one gangliopericytoma, and one salivary gland tumor with malignant differentiation. Looking like JNA, referred to us with JNA, came with a clinical diagnosis of JNA, but MRI revealed everything crystal clear. So why MRI is important? MRI will pick up the exact lesion. If JNA, the flow voids, the classical extension patterns of JNA, and with the diffusion weighted imaging, it makes everything crystal clear whether it is malignant or benign. That is almost always certain in these situations. So like we have a T2 weighted image here. See this?
Yeah.
Coming from anterior to posterior, there is nothing significant anteriorly.
We cannot see the, yeah, now we can see. Yeah, please. Go ahead.
So now you see, as we go behind, now some mass lesion appearing.
Yeah.
Some mass lesion appearing. See the nasopharynx and occupying the entire nasopharynx. See bulging towards the sphenoid sinus, and this is involving the pterygoid process. The opposite pterygoid is normal. See, classical. Now look at the contrast picture. That will make things very, very clear now. Because Jain has a characteristic pattern of spread.
Yeah.
See this. On contrast, see this mass lesion in the right side nasal cavity.
Right.
This is the maxillary sinus.
Yeah.
And as you go behind the maxillary sinus, this is the area where it is attached to. Can you see this?
Yes, yes.
That's the pterygopalatine fossa. That's the pterygopalatine fossa. And that's the pterygoid process itself behind.
Yes.
And then see the pterygoid fossa completely. Look at the normal pterygoid fossa on the opposite side.
Yes.
See, this is so important to see on MRI, which you can even miss on CT scan. This is a benign tumor. This benign tumor, as a standard treatment, complete excision. That cures the patient.
Dr. Satish,
Right.
to make a statement, if the mass is coming from pterygopalatine fossa, it is most likely to be JNA?
See, depending upon the clinical findings,
Right.
age, sex of the patient, history. See, this is painless obstruction with the history of intermittent bleeding. Then MRI showing you flow voids, enhancement,
Yeah.
and then characteristic spread pattern.
Right.
So here you can see this lesion, it typically arises here in the pterygopalatine fossa, protruding into the posterior part of the nasal cavity and then nasopharynx. See this like a ball in the nasopharynx.
Yeah.
Then going behind in the pterygoids. This is pterygoid process.
Yes.
And from here it protrudes in the floor of the sphenoid a little bit.
Yeah.
It never enters the sphenoid through the natural ostium.
Yes.
And then occupying the entire pterygoid fossa, see superior to inferior.
Yeah.
To what level the pterygoid fossa is involved? See, there are change in patterns of spread sometime, but still typically it is the pattern of Jain. Now, what happens further? If this lesion grows, it preferentially goes through the pterygomaxillary fissure into the infratemporal fossa, which this tumor has not gone. Can you see?
Yeah.
From the pterygoid process, the next spread occurs. See how close it is to the middle cranial fossa. See, that is the floor of the middle cranial fossa. Can you see?
Yes. Yes.
By means of eroding the pterygoid process, it frequently goes up towards the temporal fossa.
Yes.
Very frequently, it goes into the middle cranial fossa, mostly extradural, but in the middle cranial fossa, and it goes there through the anterolateral and anteromedial foramen, triangles, you would say, between the V2 and V3 and between V1 and V2. And through this, all these, these nerves passes through the pterygoid bone.
Yes.
The V2 passes through the foramen rotundum. V3 passes just behind the pterygoid plate, and between them is the anterolateral triangle, through which very frequently, very often, this tumor can, by means of eroding the pterygoid bone, can progress towards the temporal base. So this is how between V1 and V2 and V2 and V3, it goes towards the middle cranial fossa, alarming the surgeon. But this is not alarming at all. Believe me, even the large middle cranial fossa extensions, being extradural, you can pull them down without needing a craniotomy. Once it goes further in and acquires blood supply from the intracranial vessel, then it is a challenge, because pulling this out can shear off the vessels and can lead to intracranial hematoma. And then it requires the control of the vessel from above and a craniotomy. So there are indications for open and endoscopic approaches differently, but this extension is very important. For this patient, we have this tumor in the pterygopalatine fossa here, then behind in the pterygoid process, and then in the pterygoid fossa completely. And as you go behind, this goes in the sphenoid. Now the same thing, let's take the axial and sagittal pictures together. Let me take all axial, coronal, sagittal together to see the three-dimensional, extent of the tumor.
Sir, are you using navigation also in this case?
Not in all these cases. These are simple cases. Yes, in most extreme situation, using the endoscopic approach, yes, we should use the navigation, as it helps you orienting more, but not in all cases. Now see the antero-posterior and lateral dimension of the tumor. In all planes. See the antero-posterior dimension this is in this level. This is in the nasopharynx, upper part of the nasopharynx. This is in the pterygoid fossa. Can you see?
Yeah, very clear.
And this is in the pterygoid fossa, but not going laterally in the infratemporal fossa at all.
Yes.
See here in the axial picture, this is the nasopharynx, a little bit protruding here in the sphenoid sinus. Can you see?
Yeah. Here the important message is one must learn to read the radiology by himself or in association with the radiologist. Don't just go by their report. Am I right, Satish?
Absolutely, sir. Moreover, that is the bottom line, what you said. Moreover, since the surgeon is going to order the investigation himself, and what he orders is going to be done by the radiologist.
Yes.
Most of the time, you write a MRI PNS, goes to a diagnostic center, and the MRI PNS is done.
Yeah.
It is not even seen by the radiologist what the diagnosis is.
Yeah.
The technician takes the scan, If you have not ordered the contrast, they will never take the contrast.
Right.
Obviously, they have to follow your prescription, what you have ordered. They can't take a call on their own.
Yeah.
Unless you have a close liaising with them, with the radiologist for each and every diagnosis. So what will they do? Otherwise, a simple MRI PNS is 1 or 2 sequence, which can be finished in 5 minutes.
Yeah.
MRI, you have to acquire each and every sequence differently in different planes.
Yeah.
Axial coronal sagittal T1, T2 axial coronal sagittal,
Yeah.
T2 fat suppressed axial coronal sagittal, contrast axial coronal sagittal, every sequence.
Yeah.
That you have to order in your prescription, that like 3 Tesla MRI PNS skull base with T1, T2 multiplanar with T2 fat suppressed and contrast multiplanar. Otherwise, they will never scan and you will be left with a, incomplete information.
So the requisition to the radiologist is very important, and we
Yeah.
must mention what you want. At the same time, we should give your provisional diagnosis so that the smart radiologist will look for it and report properly.
Yes, you must have a liaising with the radiologist, very, very close relationship,
Right.
so as he can scrutinize your each and every case thoroughly and speak to you. Now, what happens otherwise? We get many patients coming with a scan in hand.
Yeah.
MRI PNS, 1 or 2 printouts, that's it. With no fat suppressed, no contrast, no diffusion, nothing.
And Dr. Satish, most of these reports are done online. The radiologist just look at those cuts and give his opinion without knowing the symptoms, without knowing what surgeon is looking for, because
Yes.
surgeon has not provided the details. So the requisition is very, very important.
Very, very important. Now, second thing is to get the complete information. How will you get the complete information? See, what is complete information in this case? Look carefully on the left side.
Yeah.
How many slices were shot? See this, the last one, 49. Can you read?
Yeah.
49.
Yeah.
These are 2 diffusion images, 120, 3D contrast,
Yeah.
39, 49, 49, 12, 12, 250. Can you see?
Yeah. Yeah.
49 slices, 49, 98, 98, 78, 18. How many slices? More than 1200 slices.
Yeah.
How will you get this complete information with the printouts?
Impossible, sir.
A single printout will carry 12 to 20 slices. That's it.
Yeah.
With maximum 2, 3, 4 printouts, how many? Less than 5% of the entire information, that too static.
Yeah.
How will you get a complete information? When you order this entire thing in digital format,
Yes.
on a DVD or a pen drive, whatever. Now this, what we are having in a DVD, has a complete information, that to dynamic. I can relate all the sequences together
Yes.
in a dynamic fashion. See, I am running. See where my cursor is running, all the 3 together. Can you see?
Yeah. Yeah.
See this pterygoid component, I can see in all 3 planes together.
Yes.
In the coronal, this pterygoid upside down. In the sagittal antero-posteriorly, can you see?
Yeah.
And in the axial mediolaterally. Complete information you can't get on 2 or 3 printouts. Number 1. So the onus is all on the surgeon, because there is a big gap among the surgeons and radiologists. Big gap, I tell you.
The
Everywhere
bottom line-
you see
Bottom
the
line, everybody must learn to read the DICOM images by himself.
believe me, if I give you examples, I have hundreds of examples of misdiagnosis done earlier, and on a 3D complete scan, we found a different type. Recently, last week, a guy referred to us with a huge angiofibroma.
Yeah.
Similar picture with a nasopharyngeal mass, infratemporal fossa extension, on a contrast CT scan and a 1 or 2 MRI printouts showing angiofibroma. We got the complete MRI done, and the patient was resisting that he has already got the scan. Why are you investing unnecessarily, spending our money? You know.
That's the usual story, Dr. Satish.
Yeah, they always resist. Now what happened? We got the diffusion, and it was a diffusion restriction. It was a malignant tumor. It took a biopsy and turned out to be a malignant tumor. There was no need of any surgery. Otherwise, it was totally exercise which was not required at all. So that is the value of diffusion. Now let me tell you what is diffusion. It is game changing, I tell you. With the diffusion, you can discriminate a benign from malignant lesion which look otherwise similar. Now see, this is the diffusion MRI together. What does diffusion MRI do? Diffusion MRI tells you the tissue characterization, what kind of tissue it is. Diffusion is what? The diffusion of tissue molecules in the magnetic field, water molecules in the magnetic field. Any benign tumor, any infection for that matter. What is MRI? Is magnetic field. Now the motion of the water molecules is assessed in the diffusion MRI, as simple as that.
Yeah.
Lesions having more water content, like infection,
Yes.
will not show any diffusion restriction. The water molecule will move freely. No restriction to the diffusion of water molecule. In a tumor, particularly malignant tumor, what will happen in malignant tumor? There is more nuclear cytoplasmic ratio, less and less cytoplasm, more and more nuclear size, and less water content overall and less diffusion.
Yes.
So it will show diffusion restriction.
Yeah.
What's my point?
Yeah.
In benign tumors with more water content, they will not show any diffusion restriction. Now see, this tumor on contrast, and see this tumor appearing bright on diffusion. What is this? This cannot be malignant.
Yeah.
As simple as that. Had this been malignant, this would be utter dark.
Yes.
And that would give me a strong suspicion that this is not JNA. This could be some malignancy, and this is now the time to take biopsy to reach a proper diagnosis. This is how the MRI is game changing in these situations.
Yeah.
So your radiology can save you from a lot of problems, from medical legal problems, from misdiagnosis, losing faith of the patient, because ultimately you tell patient you are going to remove a JNA, and post-operatively it turns out to be a malignancy which was never informed to the patient.
Yeah.
And that's how the patient loses the faith and invites some medical legal problems. Because once you have operated, then a lot of things starts from the patient sides after that.
And a proper radiology helps you in planning your surgery, which can be done in no time. If you don't have the information prior to surgery,
Yes.
you are going in a little wizard manner.
Yes. Now for this patient, my plan is very clear. This patient has this much of lateral extension in the pterygoid.
Yeah.
I will come, since it's a vascular lesion, I want a good exposure. I want to catch the vessel supplying this. This is not embolized. No need to embolize the principal vessel in such without, skull base extension is most often, the internal maxillary, which I'm going to catch. And see what I'm going to do. We'll do the modified Dankers with this wide exposure. With a 0 degree, this will be complete exposure with a 0 degree lateral to the tumor. Can you see here?
Yes.
By means of removing this medial wall of the maxilla and part of the anterolateral wall.
Yeah.
Though it is not going far laterally, so I'm not going to remove far lateral wall.
Right.
What's my point?
Yeah.
Now, another information I want to get is these patients is the vascular information. What vessels are supplying to this tumor? That is again very important in decision making.
Yes.
Now we have a MR angiogram. CT angiogram, I would say, is more informative. But this is not a very complex situation. Even the MR angiogram tells you everything. Now, what you see on MR angiogram, the advantage, the biggest advantage is no need of contrast.
Yeah.
Unlike CT angiogram, which requires a contrast, MR angiogram is without contrast at all.
Yeah.
Can you see the vessels bright?
Yeah.
These are two common carotids.
Yes.
See, this is the level of the larynx, two common carotids. And what are these two? Vertebral. Hello?
Yeah.
Vertebral artery. Now focus on the right side, common carotid. See this? This is common.
Yeah.
Dividing into internal and external. Can you see?
Yes. Yes.
The first branch of external. Can you see emerging from it?
Yeah. Yeah.
What is that? First branch is mostly ascending pharyngeal.
Yes.
Sometime could be superior thyroid.
Yes.
How you can get to know? Now forget everything. Follow this branch. Follow this branch where it is going. Follow this branch. Follow this branch. Follow this branch. What is this? This is thyroid gland.
Yes.
Can you see?
Yes. Yes.
This is superior thyroid. Can you see?
Yes. Yes.
This is how you can identify. So now I am going. See, this is the first branch.
Yeah.
Now going up, up. Now see another branches.
Yes.
Can you see?
Yes.
These are two branches. The one going in the tongue. Can you see this? Lingual.
Lingual.
See other going. This is facial.
Yeah.
This is facial artery.
Yeah.
Going towards the mandible. Can you see this?
Yes.
Then follow the external carotid itself. See, follow the external carotid itself going behind the mandible. Can you see very clear?
Yeah.
And now it is dividing into two branches. See the division.
Yes.
The smaller one, this is superficial temporal. See this going laterally.
Yeah.
And the bigger one. For the tumor, it becomes much bigger.
Yes.
Can you see what is this?
Internal maxillary.
Internal maxillary and ascending towards the posterior wall of the maxilla. See, this is maxilla. Can you see the maxillary sinus?
Very clear.
And this vessel is going in the pterygopalatine fossa like this. See the multiple branches of this internal maxillary here as it enters the pterygopalatine fossa. You can see all. So clear. And this tumor here, see this?
Yes, yes.
See what is it, how it is being supplied? Can you see the branches?
Yes, yes. It's a spinopalatine artery.
Very clear or not?
Yes, very clear.
So this tumor is principally being supplied by the internal maxillary. Can you see very clear?
Yes.
The branches going inside the tumor. See this?
Yes.
So in my surgery, my goal would be to go lateral to the tumor and catch this vessel to devascularize to a certain extent. Can you see this?
Yes, yes.
That is the value of MR angiogram.
MRI.
See, many a times we get resistance from patient for unnecessarily expending money on surgery, but how can you be so sure about, the three-dimensional anatomy, the vessel supplying, so many things? You are never at ease. You are likely to get intraoperative surprises if you don't have all this. As simple as that. You may get away many a time without any problem, but see, once in a while you will be in big trouble if you don't do this. So, as I said in the beginning, we are thriving for the betterment, and this is something really makes our life at a different level once you have complete three-dimensional radiological information. So, having known all this fact, now we are all set to take the case. Plan is very simple. Modified Dankers, go little lateral to the tumor, catch the vessel. What my point?
Yes.
And take the tumor out with completely exposing
Single
all around the tumor, or 90% of the time will be
divided
spent
pieces.
exposing the tumor, and then we'll remove it.
Hello, Satish. Will you take
Yes,
it
Bob.
to pieces or in single piece?
Pardon?
Will you take it out this tumor in single piece or will you divide it at the level of
This tumor is not far laterally extending. So
will
this
try
will
to
come out in
divide
a
it.
single piece. No need to divide.
Okay.
Division is a policy for those tumors
Yeah,
which are large to be accommodated in the nasal cavity for removal, which have large lateral extensions to be, removed along with the nasal cavity part together. So that is a strategy to divide the tumor in those situations. Now the same angiogram, if I take three-dimensionally, see that?
Yes.
Can you see? Once you see the angiogram, though this patient has no carotid artery involvement at all, had there been a tumor in relationship to the carotid, we must see thoroughly the cross circulation at the level of the brain. Can you see?
Yes.
That you need to see the cross circulation. This is basilar artery behind,
Yes, this is basilar artery.
dividing into the two posterior cerebral vessels there.
Cerebellar, yes.
And this is the carotid artery. See here. Carotid. See the carotid dividing into middle and anterior cerebral. These two anterior cerebral meeting in the midline here and forming the A2. Can you see very clear?
Yes, sir, very clear.
This is the anterior and middle cerebral of the right side.
Yes.
And how they take, the posterior communicating as a branch from the middle cerebral. The posterior cerebral. This is the posterior cerebral and this is the posterior communicating branch. This is the posterior communicating branch coming to the carotid artery. This is the posterior communicating. So this is how you can see how the circle of Willis is formed, but this is not important. Just I showed for the sake of demonstration. Otherwise, in patients where the carotid is involved, we need to see thoroughly the cross circulation. So in any given situation, if the carotid need to be sacrificed, the patient should not suffer from stroke. If so, very critical, we must get a three-dimensional DSA, digital subsection angiography, to clearly see the cross circulation. By using the balloon, you can see the cross circulation if it is affecting the brain. So there are many ways. That's a different topic. But here, as far as your vessel is concerned, see this vessel is ascending. This vessel is ascending into the maxillary sinus in the pterygopalatine fossa, as I shown you earlier. Can you see here? If I take my cursor there, you can see in all three places. Now see the same vessel here. Can you see the same vessel here?
Yes.
Now in the coronal plane, in the plane which you operate, now you can see your intraoperative picture. You can imagine how your vessel is entering into your tumor. Can you see this?
Yeah.
You are operating with the coronal plane showing you this is the tumor, this is the maxillary sinus, this is the tumor, and this is the pterygopalatine fossa.
Yes, sir.
And see how your vessel is entering into it. Level of the vessel you can see. Can you see the level? Hello?
Yes.
How you can ascertain the level? Let me take the length marker. This is the level of the palate. You can see here. Can you see here?
Yes.
See, this is more than 2 centimeters above the level of the hard palate.
Okay.
How it is important? Once you enter the pterygopalatine fossa, the next challenge is to find the vessel. This vessel is so tortuous passing through the pterygopalatine fossa. Sometimes it is difficult to find the main trunk. And that difficulty sometimes is for everybody. This why I am showing purposely this 3D angiogram, this coronal picture. Now it tells you that how the vessel is lying in the upside down plane in the pterygopalatine fossa. Can you see? Hello?
Yes, sir, we can see.
Almost 2 centimeters above, more than that, above the level of the hard palate, it is coursing horizontally in the pterygopalatine fossa. Can you see very clear?
Yes, sir.
So now you don't need to look into the lower part of the pterygopalatine fossa unnecessarily. You will not find anything.
That makes our life very easy, sir.
Yes, so you are more focused towards finding your vessel now. Everything has importance. So you have a Google map now. We have every information about this tumor, about the vascularity, and now we are at complete, ease of, at our planning to remove this tumor. Any questions? Ashwini boss?
Ashwini boss has just gone out to attend a call. He will be back soon.
Anybody, any question? In a couple of minutes, we'll be there with endoscopic picture.
Sir, what is the software that you are using for reconstruction of this anatomy?
This is Radiant Dicom Viewer. Radiant Dicom Viewer.
Okay, sir.
Versatile, any kind of imaging with any CT, MRI, PET scan done with any machine in the world can run on this. Any scan.
The take home message for radiology is that we should always order this in a digital format.
Always order all sequences yourself. Always order in a digital format. And why yourself? Because if you order MRI, PNS, you will get 1 or 2 pictures. That's it. That is MRI, PNS.
Yes, sir.
But that is without any useful information.
What is your take on embolization preoperatively in this NPA patients, sir?
Embolization has been is all strategy to handle vascular tumors, to reduce the vascularity, so can be handled much better. But embolization has its own advantages, disadvantages, and that was a time when handling these angiofibromas with the endoscopic approach was not there.
Yes, sir.
Now with the understanding of the endoscopic approach, with the equipments, everything, you can catch in majority of the patients when the angiofibroma, which has not gone much beyond to the skull base and everywhere, most of the time, the main vessel is the internal maxillary, which you can catch intraoperatively and avoid the need of embolization. Like this is the classical example for this patient.
Yes, sir. No need of embolization preoperatively in these cases. It saves
Not at all. In this patient, not at all.
Yes.
I will go and catch the vessel, will show you why to embolize unnecessarily. In centers, good centers, the cost of the embolization is much more than the cost of the surgery itself.
That was the point I wanted to make, sir.
And embolization, if being done, should be done by the expert intervention radiologist. Many a time there are dangerous anastomosis between internal and external maxillary or internal and external carotid system. And if the intervention radiologist is not experienced enough to gauge the situation, your embolized material can enter into the internal carotid system and can lead to havoc.
Disaster, yes.
Disaster. So then secondly, the embolization, the quality of embolization is improving with time, with the material. Now the onyx is the material by means of which you can really embolize the tumor, like, completely char the tumor, but the cost is very high up. For this kind of a tumor, if you use the onyx, it will not cost you less than 3 lakhs of rupees, Indian rupees in India.
Much more than the cost of the surgery itself.
Yes. So, you see, it depends upon the situation, experience of the surgeon, the cost, affordability, so many things. And more importantly, besides everything, ease and everything, the embolized tumors are more likely to be missed during surgery.
Yes.
I mentioned in the beginning, the core treatment is surgery, complete excision. Embolized, and this tumor has a propensity to go into the lot of fissures and foramina in the pterygoid region, and this tumor after embolization collapses and becomes difficult to be identified, and if you leave the tumor behind, it's going to come back. So embolization is a double-edged sword sometimes.
Yes, sir.
Studies have been done, the chances of recurrence are more in the embolized patient than in non-embolized, because tumor identification at the margin of the tumor is difficult in embolized patients.
Yes, and there are chances, but tumor has gone into some fissures that is very difficult to identify and remove that in toto. So we are getting the endoscopic picture already now. So what is the pre-op preparation of this such patients, sir, that you order?
We always give, once the patient is planned for surgery, to immediately start with antibiotic and steroids to reduce the inflammation, to reduce the bleeding due to inflammation, because the tumor in the nasal cavity leads to a lot of stagnant secretions, sinusitis. The mucosa remains inflamed because of the blocked sinuses sometimes. So we start antibiotic steroids to, decrease the mucosal inflammation.
Yes, sir.
So that is always a policy. The moment you diagnose, start antibiotic steroids. Are you getting the endoscopic picture now?
Yes, sir, we are getting endoscopic picture.
Are bulas?
You can see a lot of secretions in the nasal cavity. The picture quality is excellent, sir.
Good.
Yes, sir. Very good. Now just had a glimpse of the tumor.
Can you see the mass behind?
Yes, sir.
See the vessels over it. Now I will decongest the cavity. This is the initial preparation. This is the initial first preparation. I haven't done anything before. This is the primary picture, you can say.
Yes, sir.
This is adrenaline swabs. Topical. I always tell we never inject adrenaline.
So you are using swab this time. We have seen you using Merocel for this purpose.
Merocel for sinusitis,
Okay, sir.
because there the mucosa is immunocompromised and we don't want to further damage it. This is a normal mucosal situation. This is a different pathology altogether.
This patient has high DNS too.
Yes, yes. You will find some level of DNS in all these patients.
Yeah.
Everybody.
So by modified Denkers, we are going to bypass all this. I think we'll go.
Yeah, we'll have an ample of space with that.
With that, yes, sir.
Mix, no?
Hello, sir.
Yes.
This is Dr. Sanjeev here.
Hello, boss. How are you?
I'm fine, sir. Thank you very much. Sir, question है कि are you using different concentration of this adrenaline in different situation? And please.
Yes. Your question is valid. See, I tell you, first of all,
Yeah.
you don't inject adrenaline at all.
Yes, this is what.
With the fear of, dissemination in systemic circulation.
Yeah,
We
exactly.
never use, and we attain the same, efficacy with the topical as well.
Yeah.
Now, using the topical
Yeah.
in elderly patient, obviously it is diluted.
Diluted. Which dilution, sir? In adult?
So up to 1:4. But in young patient, we can use topical undiluted 1:1.
1:1. Okay.
Now see the tool which I call man of the match for this surgery is the cobblator. Can you see?
Yes, sir.
See, this tumor has maximum vascularity on the surface.
Yes, sir.
See what I'm doing?
Yeah.
The surface decongestion.
Surface decongestion.
See the surface coagulation.
Yes, sir. Very well.
The beauty of the coagulation is this tool is a versatile tool, has the ability to coagulate or cut along with irrigation, along with suction, everything inbuilt in one tool.
And what is the type of wand that you are using, sir?
This is Pro Size Max.
And you have done, I'm sure, some modification to this?
We cut the, we widen the bore of the suction,
Yes, that makes life easy.
so it doesn't get frequently clogged.
We remove one of the pins, I think.
Yeah, I think not removed so far, but if you want, I can show you.
Yeah. It does not get clogged easily after removing that.
Yes, yes,
We can use it for longer periods.
yes. Without affecting the efficacy of the blade,
Yes, sir.
you can do it. And another thing required is a good powerful suction.
Yes.
See the power of the suction.
Suction is of utmost importance, sir. Without a powerful suction thing, surgeon becomes helpless.
See, all the time what I am doing is surface coagulation. So any point of time, unintentionally or anything, if I happen to touch the tumor, my instrument happens to come in contact with the tumor, it should not bleed.
The message is we should avoid fiddling into the tumor as much as possible at this point.
Yes, yes, 100%.
Only
You
surface.
are not supposed to enter into the tumor at any point of time.
Yes, sir.
Exposure all around. Whatever tumor comes into exposure, keep doing surface coagulation all the time. All the time, surface coagulation.
One thing more, sir. We have discussed this time and again. From an anesthesia point of view, what type of blood pressure and heart rate would you like to have for such surgeries?
Yes. In this particular surgery, JNA, we prefer hypotensive anesthesia. Face and all, we stopped asking for that. In sinus surgery, we don't ask anymore for hypotensive anesthesia not. What we ask is the bradycardia, little lower heart rate, to reduce the cardiac output. This is because in face the bleeding is mostly capillary.
Yes, sir.
But here it is arterial bleeding, and here is the real role of hypotensive anesthesia.
In face, we
Now-
prefer bradycardia, and here hypotensive anesthesia.
Here
Hypo.
Pardon? Hello?
Face, we are more concerned with the bradycardia, and here hypotensive anesthesia as well as bradycardia.
Yes.
And what about the
Now-
setting of coagulator?
Coagulator 9 and 5.
9 and 5. Oh my God.
Now, as I told you, my goal is to do a modified Dankers to enter paramedian parallelly. So, this is the lateral wall of the maxilla, lateral wall of the nose, with the inferior turbinate being separate bone. Lateral to it is the maxillary sinus, and above the maxillary sinus is the orbit. And we need to go behind the posterior wall of the maxillary sinus. Okay?
Yes, sir.
So, to enter into the maxillary sinus, we are not supposed to violate the roof of the maxilla to enter into the orbit. We need to remove this inferior turbinate and the medial and anterolateral wall of the maxilla to go right on the posterior wall. So, initial landmark what I use is, see the level of the axilla. Roughly a centimeter below the axilla. Roughly, this is roughly. Precisely, I'll tell you once I reach to the maxilla.
So you
Goal is not to enter into the orbit. You are not going supposed to go so superiorly to enter into the orbit.
are you using cutting or coagulation mode now?
So far only coagulation.
Okay.
I will tell you when I use cutting. And see anteriorly, this is my piriform aperture. You are not supposed to come far anteriorly to damage the alar cartilage. Okay?
Yes, sir.
Now this mucosa, otherwise, see, coagulator makes your life so easy, absolutely bloodless. Otherwise, this mucosa is so vascular,
Yes, sir.
it won't allow you to work so easily with endoscope. And the primary, requirement for endoscopic surgery to be safer, to be effective, is to have a good visualization. If there is too much of bleeding, you may land up in complications. So that's the primary requirement for the endoscopic surgery. See this, the thing which I need to remove. Okay.
Yes, sir.
Now I'm going to use and show you the cutting, ablation. See, I'm removing this mucoperiosteum. Can you see?
Yes, sir.
Now,
Please, sir.
now this is the piriform aperture. Can you see the anterior edge of the bone?
Yes, sir.
Can you see this anterior edge of the bone? Yes or not?
Yes, sir. Yes, sir.
Yes, sir, clearly. And sir, one question, whether you to delineate the anterior fossa and piriform fossa first, or to just cut the lateral wall of the nose first?
Lateral wall of the nose first.
Yeah,
See, what I want to enter head on.
yeah.
To enter head on, you need to have a full exposure of the medial as well as anterolateral wall.
Okay.
See, this is inferior turbinate. It's a separate bone.
Yes, sir.
See this?
Yes, sir.
It's a separate bone. I can fracture it. I have fractured it. And this is the inferior meatus. See this? See this inferior meatus?
Yes, sir.
Yeah, yeah.
I am using ablation, taking away all this mucoperiosteum. Flushing with the floor. My landmark is the floor. I need to flush everything with the floor. See that?
Yes, sir. Very well visible.
This surgery, believe me, if you are doing endoscopic surgery, sinus surgery, you can do it. Follow your landmark, follow principle, good radiology, equipment. See this. Now this is your inferior turbinate, which I am going to remove. Why there is little bit of the bleeding? Because the vessel comes from behind.
Yes, sir.
This is the turbinate bone. See that? The brighter. That's the turbinate bone. Feel free to interrupt me any point of time. Okay.
That's the- हम तो चले सही से पहुंच गए सही से यहाँ कितना लेट देख रहे थे सर
See, I debrided the turbinate. ये बंद हो रहा है. See this turbinate I am taking off. I know little bleeding of the is going to come with the turbinate removal, which will handle.
Now, give me the cobbletter. See the part of the anterior half of the turbinate being removed.
Yes, sir.
So you can control this bleeding by cobbletter. Because this is posterior part which we are going to handle later on.
Yes, sir.
See, everything should be under vision. I hope the picture is good.
Yes, sir.
Excellent, sir. So what is the position of your assistant? And I presume you are using 4 hands.
Position is assistant is besides me. And see this gauze piece, I have intentionally kept over the tumor. What my point?
Yes, sir.
The tumor doesn't unnecessarily come in contact with my vessel to get traumatized, instrument to get traumatized.
And for the beginners, sir, what do you suggest that we should hold endoscope or the assistant should hold endoscope?
Depend. It's an interplay between your assistant and you. Sometimes the assistant takes up
But it is very
the
hard
scope.
to get a very qualified assistant. Like
Yeah, so you have to develop, a team. See the entire inferior meatus very clear?
Yes, sir.
Good field. Now, this was about the removal of the inferior turbinate and the inferior meatus. अलग से करो करवा दो. See this? I hope the picture is good.
Very good, sir.
Yeah. So feel free to interrupt me at any point. सिर्फ पकड़ना है. Now this is the pyriform aperture. Can you see?
Yes, sir. Clearly.
I will elevate this mucoperiosteum of the anterolateral wall. See this. See this. If you want to go far laterally, see these vessels being severed. Can you see?
Yes, sir.
See these vessels and nerve branch and nerve fibers being severed are anterior-superior alveolar nerve and vessels. I told you we need not to go far laterally in this particular case, as we don't have far lateral extensions. Okay.
Yes,
So
sir.
see the anterolateral wall exposed. Okay. Now the thin anterior part of the wall I can punch out. The more thicker wall is not going to be removed like this. See this? See how thick a wall behind.
It's
And
only
now,
going with the gauze.
pardon?
It is only going to go with the gauze and hammer.
Gauze and
drill.
hammer or drill?
Or drill, yes, sir.
See, this is the medial wall of the maxilla and this is the anterolateral wall of the maxilla. और पीछे जाओ, थोड़ा नीचे. Can you see?
Yes, sir.
And this is the point. This is what I am going to show you to make an opening in the maxillary sinus. आगे पीछे कर section periosteum ले ले. Take a section periosteum. I will show you to orient you with the maxillary sinus by making this opening. See this. And then we'll relate with the roof because anyhow we are not supposed to enter into the orbit. This is my favorite Karl Storz, the Matronic skull base drill with inbuilt irrigation and a 15-degree angle. चलो अंदर. See the inside of the maxillary sinus.
Yes, sir.
Can you see the inside of the maxillary sinus?
Yes, sir.
That is the interior of the maxillary sinus. Okay. And see what I want to see here is the level of the orbital floor. See high up. Still quite high up. Can you see?
Yes, sir. It is quite high up.
And what is this prominence inside? Medially, that's the nasolacrimal duct.
Yes, sir.
The structure which need to be managed during this surgery. The important critical structure to prevent, permanent epiphora is to properly manage this nasolacrimal duct, which I am going to show you. See, this gives you an idea how superiorly you can go without breaching the orbital floor. Can you see?
Yes, sir. It should be kept in view always.
Yes. ऊपर जा अंदर. Yeah. This gives you thorough idea about the level superior inferiorly. See the level of the floor of the orbit above here.
Yes, sir. You can still go a few millimeters.
Yeah. And now inferiorly you have to flush with the floor of the nose. I am thinning it so I can punch it out later. I am thinning this wall to be punched out. Suction कर ले एक बार अंदर. Yeah. See the maxilla inside?
Yes, sir.
And now I can punch out this wall. See this?
Yes, sir.
To show you the nasolacrimal duct properly. I could have removed in less than a minute with the Gaussian hammer.
Still gives us more precision.
Yes.
So the auditorium here is almost full and we are all enjoying your surgical treat.
Thank you, Farooq.
And online also people are watching all over the country.
Great.
Dr. Satish,
Yes, sir.
we have shared this link to all the groups and people are watching it because I am getting the feedbacks. So
Thank you, sir. See now, what you see, this is the cut end of the nasolacrimal duct.
Yes,
See
sir.
here. Can you see this?
Yes, sir.
That's the nasolacrimal duct. And see the treatment of the nasolacrimal duct, since you have to
Resect it.
remove it from the field, is to resect it sharp about just flush to the orbit, floor of the orbit.
as high as possible that we can reset.
Yes, so it should not remain hanging later on to prevent epiphora.
Yes, sir.
And that for that you need to have a proper exposure of the floor of the orbit. So this extra 5 minutes at this point of time, the brother, will help us achieve the exact level. See the maxillary sinus from inside.
Yes, sir.
That's the posterior wall behind. That's the posterior wall of the maxilla behind. Can you see?
Yes, sir. Visible.
This is nasolacrimal duct and that is the level of the orbital floor. See that level of the orbital floor.
Yes, sir.
See this?
Yes, sir.
So now we have to flush this duct to the level of the orbital floor. So this will never bother us, give us good exposure for the work behind and without giving a complication of epiphora as well. You have to cut it sharp, all that required is. See, precisely removing all around bone from the nasolacrimal duct. Can you see?
Yes, sir. We're denuding that almost.
Removing the bone from all around. So I can cut very, very sharp, that too close to the orbital floor. See, trying to remove the bone from all around. All this bone anteriorly, which is coming in the way, should be flushed. See now what is literally the meaning of flushing with the orbital floor. See all the way. Can you see?
Yes, sir.
Now, adding more to it.
क्वेश्चंस वाला जो है वो लिंक भी हाँ मेरे को या मैं उसको टेक अप करता हूँ बहुत अच्छा और कल का भी ऐसे ही चलेगा इसीलिए देखिए वी हैड नो अदर चॉइस
See the boundaries of the nasolacrimal duct all around. You really need to spend some time here. See the all around.
Yes, sir.
Very clear?
Yes, sir. Now,
so that I can properly flush.
Dr. Satish, just an information, around 677 people are logged in from all over the country.
Oh, great.
Watching your session. I
That
see
too on Friday.
Yeah. And it's a
That's
Friday
all.
working day.
See, remove the posterior wall.
Yeah.
And see, once I remove the posterior wall of the nasolacrimal duct, anybody, what is this? What is this?
Uncinate.
Yes. See, the close proximity of the uncinate to the nasolacrimal duct which we always mention during our sinus surgery to protect the nasolacrimal duct. So now this is the nasolacrimal duct overhanging, see this?
Yeah, very clear.
And flush with the flush with the orbital floor, see that? The
Yeah.
entry into the orbit there?
Yeah,
And that is where this need to be completely flushed.
yes.
Cut completely flushed.
And a sharp cut.
Now, yes, very, very sharp cut. You know. Now, see this.
Yeah,
We have little bit pulled it,
yes.
sharp cut, and see this.
Yeah,
So now we have better exposure of the,
Axillary sinus. and the-
yes. See that. Now, give me small gauge. Some mucosal oozing from within the maxillary sinus. This is expected. And our pack will take care of it. Every time you keep improving your field, that is the bottom line. Visualization. Now this is your uncinate. See that?
Yes, sir.
See the uncinate. Behind the nasolacrimal duct. There's the bone of the uncinate. Bone of the uncinate. There. And this. See this. See the uncinate process.
Yes, sir.
And what is there is the bulla ethmoidal is behind. That is middle turbinate, that is bulla. See that?
Yes. sir.
yes, yes.
We have to flush the posterior wall of the maxilla thoroughly. There should not be anything coming in between the posterior wall of the maxilla and the nasal cavity. See this?
Yes, yes.
See, that is the posterior wall of the maxilla behind. All this medial maxillary wall, see this?
Yes, sir.
Has to go. Simple. All this medial wall has to go completely. Coagulation. See the posterior wall of the maxilla.
Yes, sir.
Can you see the posterior wall flushed?
Yes, sir.
See, all this mucosal bleeding can be controlled with a coagulator. What is this? What is this? That is the sphenopalatine vessel.
Okay.
Can't you see the sphenopalatine foramen?
Yes.
Hello?
Clearly
Yes, yes,
visible,
very
sir.
clear.
Yeah. What is that? So that is, see the vessel coming from behind the posterior wall. Can you see this?
Yes.
See this posterior wall behind. See this vessel. See this vessel coming from. See the sphenopalatine artery.
Yeah, yeah.
This is just to show you at this point of time. I am not going to do anything. I'll first improve my anterior exposure and then go behind. Little bit of the finishing work left anteriorly. Wash. Now give it a wash to give you good field. See the picture now. Oh, okay,
Very
okay.
clear, sir.
See, this is the posterior wall of the maxilla. Very clear?
Yes, sir.
Yes, yes.
That is the orbital floor.
Yeah.
That was your nasolacrimal duct. That is the middle turbinate.
Yes.
Okay?
Yeah.
Okay. Anybody, any doubt about the orientation or anything you want to ask, please feel free. This little bit of the mucosal bleeding I am taking care of. Now, give me a gauge. Now I will improve little anterior exposure drill. I tell you reason behind it. Anterior exposure means this bone I need to remove. Because once I start working in the depth, my instrumentation will be hampered with this bone projection.
Yes.
So that is important now. I have adequate lateral exposure without any doubts. Bob later. See, my lateral exposure is adequate. See the maxillary sinus now. See this lateral exposure.
Yes.
The only thing is this inferior bone that need to be removed.
Yeah, that has
So,
to
but
through with the floor.
Yeah, flush the floor.
Yeah.
I can remove with a drill. I can use a chisel hammer, anything.
Yeah. The take home message is you should control the tumor from all the sides first and then go plane by plane.
Yeah, I am not going to the tumor anything now.
Yeah.
My tumor will removal
Yes.
will be last 10% of the entire time.
Right. You just control it from all along and then it will come out like Rasgulla.
Yeah. See this? I could remove it faster with a chisel than a drill. Because this was not a very critical step.
Yeah. Here the most important instrument is the cobbleter.
Cobbleter is man of the match. Section Cobbleter is man of the match. See now, I'll have from right from the floor to the roof, complete exposure.
Yes.
Now this bony oozing should never be attempted with a cobblator.
Yeah.
It can ruin the cobblator blade.
Yes.
What I am going to use now as an insulated suction cautery. See this?
Yes.
See this bony oozing. Wash. See how this bony oozing is controlled?
Yes. Yes.
Now I will remove all packs, everything, and show you.
Yeah.
Now see my full anterior exposure.
Dr. Satish, what is the role of hot saline packs here?
Not here, actually. Hot saline wash is useful to control the, bleeding from the bone,
Yeah.
particularly the skull base bone, which has a lot of, venous systems.
Okay.
Not for this area, and that is really useful.
Yeah.
Like if I am doing a clival lesion,
Mhm.
I would definitely
Yeah.
use the hot saline. See this?
Yes.
See the exposure now,
Yeah. Yeah.
top to bottom.
Yeah.
The only impediment a little bit here, but now this is not going to obstruct my instrumentation.
Yes.
देखा करो. तो धार से पानी डाल. See now the posterior wall exposure. You can see the glimpse of the tumor medial to the middle turbinate,
Yes, sir.
and we have ample of lateral exposure now. Okay?
Yes, sir.
Give me a gauze, please. Now, coming to the tumor attachments. This tumor frequently takes attachment on the septum, on the turbinates, never on the nasal floor, never inside the sinuses. It may bulge inside the sinuses, but never take attachment.
It attaches to the skull base also, sir?
Pardon?
To the skull base attachments? Does it sometime attach?
Yeah. It can erode the skull base.
Yes,
What
sir.
attachment? It can
Yes, sir.
completely go through.
Mhm. But it never enters the sinuses or the floor of the nasal cavity.
It can enter into the sinus. It enters, but never
Yes, sir.
takes attachment.
Yes, sir.
Now is the time to take a, before taking the vessel, I will improve further exposure. See the turbinate is the biggest obstacle, you can say. See this tumor?
Yes, sir.
This is superior turbinate. This tumor goes in the pterygoid process. It has gone in the pterygoid process, we know in this patient. See the tumor attachment to the turbinate here. It is attached to the turbinate.
Yes, sir. Middle terminate posterior part. So I would like to thank Mr. Dinesh and the audiovisual guy Anita Enterprises and the Wi-Fi concerned person. They are giving us unparalleled transmission, and the audio and visual quality is also too good. Thank you.
Dinesh is masterpiece.
Always. Dinesh is champion.
Doing it since last 2 years almost, isn't it?
See this the terminate was attached to. So now what I'm going to do is, see this. I'll cut the terminate, middle terminate, like this,
Yes.
and expose the tumor from above.
Yeah.
See the terminate gone?
Yeah.
And that is the bulla, debrider, straight debrider. I will go straight over the tumor
Yes.
to expose the tumor from above. So now this is our sinuses. See, this is bulla. I told you earlier when I removed the uncinate, this is bulla.
Yes, sir.
And why I am removing? To define my lateral limit of the entire work, that is orbit.
Yes.
Action karna. Here. See, that is the lamina papyracea. That is my lateral limit. I need not to go there. These are the ethmoid sinuses. All ethmoid sinuses.
Yeah.
This is all I can remove and go right to the sphenoid to expose tumor completely. See this?
Yeah. Mr. Dinesh, the picture is not coming.
What happened?
The picture actually is disappeared. Maybe internet problem. Mr. Dinesh will take care. Yeah.
Dinesh? Sir, let me know if the picture has come or not. Hello? Let me know if the picture has come or not. Right. Hello? 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 Right. No. Hello? क्या हुआ? Kerosene. Hello.
Yeah, Dr. Satish.
Yes, sir.
From mobile we can log in, but yeah, this is
Yeah,
okay.
yeah. Problem was at your end there.
Yeah, probably the internet problem, because from mobile link in the Zoom I can talk to you.
Yeah. So I have done nothing but just to enlarging the sinus openings.
Yeah.
See the sphenoid sinus.
Yes.
I have done this. The partial ethmoidectomy.
Yeah.
Let me show you. Dhar se dhar. Let me show you what I have done. See, this is the tumor below.
Yes, yes.
That's the tumor below. That's the sphenoid sinus behind.
Yeah.
See the sphenoid sinus.
Yeah.
And this is the tumor margin superiorly.
Right.
What I have done?
थोड़ा वॉल्यूम कम करो ना उधर, थोड़ा वॉल्यूम कम करो.
I have done this is the maxillary sinus.
Yeah, completely cleared. Yeah.
Posterior wall of the maxillary sinus. This is the ethmoidectomy I have done.
Yes.
The part of the middle turbinate and the superior turbinate exposed.
Yes.
And this is now the tumor surface here.
Yes.
Now give me the cobbletter. Now let me, I told you more and more tumor get exposed, more and more surface coagulation is required.
Yes.
This is the nasal septum posteriorly.
Yeah.
The tumor has a frequent attachments.
Yes.
See, I can remove this mucoperiosteum to devascularize the tumor from there.
Right. Sound.
Very clear?
Yeah, absolutely clear.
That's the medial exposure by removing the part of the septum from the level behind the tumor.
Yeah. Yes.
Okay?
Yes.
And this is all, exposure of the tumor. So my tumor is very much, in front of me here.
Yeah.
This is
This is a part of the turbinate which was left.
technology यहीं पे yes. वो भी आएगा. Yes.
Recording
Yes, now again the audience is with you. Yeah.
Okay, can you see the tumor now here?
Yes, very clear.
See, exposure is the key to prevent all complications. Now this tumor is attached there. You saw in the CT or the MRI, see this tumor is where it is infiltrating into the pterygoid there. Can you see there? Hello?
Hello, can you get my voice, Dr. Satish?
Yes, now.
Yeah, now, they have unmuted, now.
See this tumor and see where this tumor is going into. This is pterygoid bone there.
Yes.
Hello?
Yes.
This is pterygoid bone there behind.
Yeah.
Which this tumor is entering into. See this?
Yes.
And I had shown you this is the vessel.
Yes.
Sphenopalatine artery. Can you see this?
Right. True.
This one.
Yes. Over which your cobbletter is there now.
Yes. And I shown you this is roughly, see from the floor of the orbit, floor of the nose. It is quite high up, almost 2 centimeters high.
Yes. That you have shown on the radiology.
Yes.
Yeah.
Give me the kerosene. Now our tumor is centered as far as the attachment is concerned.
Yeah.
Here, this is pterygopalatine fossa.
Yeah.
So what I'll do, I'll remove this posterior wall of the maxilla anterior to the vessel.
Yes.
See the vessel there.
Yeah.
See the vessel.
Yeah.
This is the vessel.
Yes.
See, this is the vessel.
Yes. Yes. Will you clip it or cauterize?
I will clip it simply.
Yeah.
See how easily you can identify the vessel.
Up to what size you can cauterize it? Is there any guiding thing?
No, I have a vessel sealer. I can cauterize even up to 7 millimeter vessel.
Okay.
We have a Martin vessel sealer.
Yeah.
That is quite effective.
Mhm.
But I believe here the most, the sense of security here.
Yeah. Is the clipping.
Clip. Why to take a chance?
Yeah. Actually, clipping gives more satisfaction and there are chances that it will seal completely.
Yes. Now, see the pterygopalatine fossa in view.
Yeah.
This, for everybody, pterygopalatine fossa is a very small space.
Yeah.
Mediolaterally, anteroposteriorly, both.
Yes.
So mediolaterally, how wide is mediolaterally? See, behind is the pterygoid process.
Yes.
Here is going to be the medial pterygoid plate, here is going to be the lateral pterygoid plate. Okay?
Yeah.
So pterygopalatine fossa is just of the size of the width of the pterygoid process.
Yeah.
Pterygoid fossa. Immediately, see, this is posterior wall of the maxilla.
Yeah.
Behind is the pterygoid plate, lateral pterygoid plate.
Yeah.
Beyond the lateral pterygoid plate here, behind this, is going to be the beginning of the infratemporal fossa. And what will be the foramen to enter into the infratemporal fossa here? This is maxilla, behind is that lateral pterygoid plate. Pterygomaxillary space. So beyond the lateral pterygoid plate, between the lateral pterygoid and the posterior wall maxilla is the pterygomaxillary space. All tumors from here enter into the infratemporal fossa through the pterygomaxillary space. Got my point?
Yes. Yes.
Now this is the periosteum of the posterior wall of the
Yes.
maxilla, or the anterior wall of the pterygopalatine fossa.
Yes.
Anybody, any doubts, please feel free. Sickle there. Now, now I will open up this periosteum of the pterygopalatine fossa for your demonstration. See this?
Yes. Yes.
See the branch of the vessel.
Yeah. Otherwise, you can simply clip it here.
Yeah, but I will expose the vessel.
Right.
See, this maxillary artery
Mhm.
gives number of branches
Yeah.
into this space.
Dr. Satish, what special precaution you take at this point so that there is no residual mass left?
Stay lateral to the tumor when you get the fat space.
Yeah.
See, this is the vessel itself. See this?
Yeah.
Let me show you. The section got blocked. पानी मेरे को दे. Straight में डाल. चल दे. See this. Let me show you with the
Yes. Yes.
irrigation.
Yeah.
See, this is the vessel where my section is.
Yes.
That is the horizontal vessel you can see.
Yeah.
See the small branches from it. Can you see?
Yeah.
These are all branches,
Yeah.
not the main vessel. Periosteal branches, other branches.
There are a lot of branches. Infraorbital artery. This is also a branch of internal maxillary artery.
Yes,
Greater palatine artery, also a branch of this one.
absolutely.
The another branch that goes to the pharynx.
And this, now my tumor, which is centered here behind in the pterygoid,
Yes, yes, yes.
completely exposed. See this?
Yes.
Ablation. Just wait. Okay.
This coagulation will take care of the small vessels.
Yeah, not the main one.
Yeah.
Main one, we have to be very careful not to rely on.
Coagulation, but rather clipping it.
You
You
have
see the main vessel?
Yes, yes. Now we can see.
Yes or no?
Yes, sir.
no.
Yes, yes, it is there. It is there.
I am unable to.
Yeah, now he has shown you.
And now it's okay.
Yeah.
Is that vessel, Satish?
That's what I'm confirming
I
first.
have just hooked. I don't think that is vessel because it is not pulsating at all.
That's what.
This is most tricky job. This is most difficult part.
Actually,
Sometimes-
this area dissection is one of
Yes,
the
now-
very
now-
important
now the
steps
vessel has come.
to prevent the residual part. isn't
Now
it?
vessel is seen.
Yeah. See the main vessel?
Yeah.
In the center part. This is the vessel. Yes. जिस पे गुजरती है उसी को पता रहता है बस क्या
It is very easy to watch and comment.
See my vessel.
Master, yes. Now the vessel is very clear.
Watching Dr.
it-
Satish
no.
doing it gives the
But-
confidence that, yeah, anybody can do it. But it is not exactly. One has to graduate and learn
Not
step by
graduate.
step.
I will first put a clip over here.
Yeah,
Not graduate, have to do postgraduate.
that is the term we use. Graduate means gradual. Graduate is gradual, not graduate means postgraduate.
Hold it.
बहुत हाई फाई है
अरे
समझे नहीं?
One more. Do you see the clip?
थोड़ा चीनी कम है.
Hello?
Yeah,
Hi,
please.
So
Yeah.
simply you can apply the clip.
And what happened to your individual customized monopolar forceps?
Yeah, I used to do earlier, boss.
I have left that.
Yeah, but not now.
But now what are you using? Vessel sealer?
Clips,
Yeah,
clips.
Okay, you have clipped. But sometimes this clip now it gets opened during manipulation. The problem with the clip is that. नहीं यार.
Mr. Dinesh, can you share the question links
Now,
to the audience?
now, can you see something what I want to show?
Yes, yes, yes,
Yeah.
yes.
Can you see behind the pterygoid bone?
This is pterygoid process.
Can you see behind the pterygoid bone? See, I have clipped the vessel and elevated laterally.
That is.
Can you see something?
That is bone.
Yeah, that is pterygoid bone behind.
Yes.
Yes, that is nerve. That is
No. This is pterygoid bone behind.
that is Vidian canal. You are trying to show the Vidian canal.
Median, no. What I am trying to show, my lateral limit.
Lateral limit. Okay. Okay. Lateral limit. That is the okay.
See this. This is all infratemporal fossa fat.
Yes.
Yes.
Yes. Yes. Yes.
No tumor lateral to it. I have divided there.
Yeah.
And now my tumor is here all medially.
Yes.
Yes.
And
See,
this,
this is segregated from the, vascularity. Can you see very clear?
yeah,
Yes,
yeah.
very clear.
Completely segregated from the vascularity.
Yes.
See that?
Yes, yes, very
Actually,
clear.
this point is very important so that you don't leave out anything as a residual mass.
Now we can see the
Yes.
pulse of the internal medullary artery.
Yes.
Now it is visible.
Now I will remove all this bone because this bone has infiltration behind. That is the main involvement in this particular patient. And the commonest site of recurrence, so-called recurrence, that is the residual tumor left behind,
Yeah.
is the pterygoid bone.
Yeah, that is what I was insisting, Dr. Satish, because what we call recurrence is mostly residual.
It's always.
Visual
This is a benign tumor. If you remove the tumor completely, it cannot come back.
Yes.
Now, boss was talking about the Vedian canal.
Yeah.
Boss, look at this.
Yes, yes, that is
Yes.
visual canal.
This is your Vedian canal.
Actually, I saw this canal earlier.
There is a question, Dr. Satish, what is the importance of Vedian canal here?
The tumor very frequently invades the Vedian canal.
Yes.
Once tumor infiltrates the pterygoid bone, see this is Vedian canal, which I have coagulated here.
Yes.
And this just medial to the Vedian canal is the palatovaginal canal.
Yes.
Now this Vedian canal runs in the floor of the sphenoid.
Yeah.
See this part of the pterygoid I removed, and see, I told you the tumor bulge in the sphenoid.
Yes.
Can you see there?
Yeah, yeah.
Is it not that part of the lateral recess of a sphenoid?
See this tumor bulge
Yes.
But it is bulging from the lateral recess.
from the pterygoids. See how beautifully it is visible.
Yeah.
And this, I told you in radiology, the tumor bulging in the sphenoid.
Had you not appreciated this in radiology, probably chances are one can leave it.
Yeah, one can miss it.
Yeah. And
See,
later we
this
come
is
to recurrence.
not entering the sphenoid from anywhere else.
Yeah.
So what I will do now, I will remove the bone
Yeah.
anterior to it completely.
Will you use drill for that?
See this bone anterior to it.
Yeah.
See the bone tumor inside.
Yes. Yes.
Now see the pterygoid fossa. I told you the pterygoid fossa is involved.
Yes.
Now I am opening the pterygoid fossa.
Yeah.
See the bone removed, and see this is all tumor.
Yes.
This is all tumor. Now before attempting the tumor removal, I will expose it wide.
Yeah.
All bone has to go. I can pull it in no time without any problem. See the tumor is exposed.
Yes. Very well. Still there is some lateral attachment, I think.
Yeah. Once I pull it, it will come out. It is a gentle pull which is required. That's it.
This tumor is very gentle.
It's just a gentle pull required, nothing else.
Will it not break? It is not fragile that way. Yeah.
It is.
Yeah.
It is. Once it invades the pterygoids, it actually invades the Haversian system.
Yeah.
It can break if you are not gentle enough. See now, close up. This is tumor here anteriorly, and this is the pterygoid bone I am removing, uncovering the tumor.
Yes.
Yeah.
You uncap the tumor, let it come out.
See, more and more tumor being uncovered. These are our clips laterally. See that?
Yes, yes. Very clear.
हो रहा है। एक सेक्शन और है।
That little piece of bone.
Now, another thing, we have seen this tumor
Yeah.
going down in the pterygoid fossa all the way upside down.
Yeah.
I'm
We have to
completely,
remove the bone overlying it.
yes, that's what I've been doing for last couple of minutes.
Right.
Only bone.
Yeah.
Tumor will follow automatically once I start pulling it without any problem. Later. See my tumor exposed. What are the bone? Which artery is this? Anybody? This vertical vessel?
Greater palatine.
Yes.
Yes.
एनाटॉमी तो पढ़ा रहा है यार पिछले 20 साल से हम लोग को
That is very important, right?
पढ़ते पढ़ते याद हो
Is
गया
this greater palatine?
yes 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 actually this artery bleeds even after coagulation of the internal medullary artery because there is contralateral supply from the
These are not end arteries at all.
Yes.
that's why it's
Lot
when,
of
when you
collaterals.
clip it it will bleed yeah
Now see, this is pterygoid fossa tumor. See this?
Yeah.
Still, I am not keen to remove at this point of time.
Yes.
Give me Carison more, little bit more exposure, so that I don't leave the tumor behind. This is very, very important. It is so tempting.
Yes. And
See,
this is another
more-
important
More
message.
bone is exposed. More bone is removed. This entire tumor is exposed now.
is it not going little bit in the lateral recess Satish? Hello
Pardon?
it is entering from the lateral part of the lateral wall of the sphenoid sinus generally it comes from the floor of the
Lateral wall of the.
lateral part of the sphenoid process you can say
We will check, boss. I will show you. Once it is in the pterygoid process, means
it is
there is no lateral recess.
complete-
Lateral recess is at the expense of pneumatization of the pterygoid section. Karna.
yes
Got my point?
yes yes yes
See, the tumor itself is occupying the pterygoid fossa.
yes
See, I am leaving a pack for couple of minutes here. I am not keen to remove the tumor at all here now. I'll tell you the reason. I will improve the posterior exposure now.
Dr. Satish, there are few questions from audience.
Few
Yeah.
questions and probably from the across the world.
See this.
10
See
questions.
this? Oozing control. I'll leave this pack for 2 minutes, improve the posterior exposure and get rid of the tumor in no time. Yes, sir, your questions.
Yes, sir. A question from Muhammad Azmal from Rawalpindi.
Yes, sir.
He's asking about the surface devascularization. Can it be done by bipolar dithermy?
Yes, you can.
it can be
You can. But the thing is, the coagulator gives you the sense of ease, I would say.
Okay.
Under vision with ease, with less collateral damage.
Yeah.
And there
That's why coagulator is important with all the time irrigation. See this? I am leaving a pack here because I have to remove the tumor here. From here, nothing else is required now. The exposure part is done. Now,
Okay.
what all I need to do before that? Posteriorly.
remove the posterior part of the septum
Yeah, I need to disconnect the vascularity from the opposite side also.
yes
And then I will pull everything down. Okay?
Can we ask the next question, sir?
Yes, yes, please. Rukna, rukna.
And the same Dr. Muhammad Azmal from Rawalpindi ask, do you do maxillary swing for big tumor going into the temple?
Yes,
Temple
sometimes it has its own indications. Maxillary swing is a great approach. And then we combine it with the endoscope further to see any residual behind, because it gives very fast exposure of the entire central and paramedian skull base in no time. In 10 minutes, you are at the skull base. The procedure is fast. So for tumors, where the carotid is at stake, not very, the carotid is a big problem. The child is small. The operating time you want less, with overall less bleeding. There are indications. You can use it
Okay,
for
sir.
those indications.
And the next question is from Baghdad. And Hussein Mohsin has asked, where is the infratemporal nerve? And
Temporal nerve.
it has already, it's too late to ask this question. Because at the
He
beginning,
wants to ask V2.
infra or vital nerve.
V2. I will show. I will show.
Okay.
Wait. I will show later. See now. This is my दूसरा ले लेना section एक और
पैक करके छोड़ करके भैया
बंद है.
पेशेंस कुछ भी काम है ना लाइफ में पेशेंस
Now see, this is my tumor. What I want before delivery. यहाँ blood नहीं आना चाहिए.
one from organization
What I want before delivery. कब लेकर? This connection from the opposite side. See this tumor?
Yes, yes.
Yes, sir.
I am already separated from the septum. Can you see?
Yes, sir.
Leave a pack for a while. The most important component was the pterygoid one, which I will show you how to remove that. That is the most important part, as it has invaded the bone. Okay? No. Now give me the coagulator to go to the opposite side. See this?
उसके बाद आप इसको हटाइए तो करना बहुत आसान हो जाएगा ये थोड़ा सा टेक्निकली ब्लाइंड हो जाता
We have a huge nasopharyngeal component. See this?
है मेजो करें
Yes, sir.
ऊपर में पीछे से देख पीछे फ्री है ऊपर से टाइप
See such a big nasopharyngeal component.
मैं तो करता मेरा
See this?
पेरिनियल कंपोनेंट
Yes, sir.
Hello?
Appreciate very well.
What I will do,
सबसे पहले ये वाला पार्ट ये लास्ट में होगा नहीं है अब जैसे ऊपर से चढ़ाने का तो इस तरह दर्द से गिर जाएगा नीचे
ऐसे आएगा.
see, I am beyond the tumor.
Yes, we have control from almost all sides, excepting the pack which we have placed.
And I am just dividing this periosteum
Yes.
to get rid of, see this periosteum,
Yeah. Very nice.
to divide if any blood supply coming from the opposite side, because tumor crossing the midline
Yeah.
can easily acquire the blood supply from the opposite side.
ट्रांसप्लांटर
करके थोड़ा बोन को काट लेते थे आगे तक आगे वाला एंड में
See that?
Yes.
Fine. Now is the time for tumor delivery now.
Yes.
Now in next couple of minutes we'll be through. Let me give a pack over there. See, I will leave a pack there.
Yeah.
So now is the time for final tumor delivery, my dear. See, advantage of endoscopic approach is not just avoiding the scar, I tell you.
Yes.
The brilliant illumination, magnification, on-site magnification, looking into the corners, canal, crevices, all this is possible only by the
Endoscope.
endoscope. Open.
And here you have used.
You see people doing angiofibroma surgery open, they will remove fast and pack everything and come out.
Yeah.
Nobody bothers to see whether the tumor is left behind or not. So removing a major component of the tumor is not the surgery.
And most of the job is done by 0 degree. Here till now you haven't.
Always.
Yes.
That's the principle of skull base, to do maximum with 0 degree.
Yes.
Now see, now there's the time.
Dr. Satish, what about that small mass in the pterygopalatine fossa? Still we can see something?
Yes, the pterygopalatine fossa I have elevated.
Okay. And the
And see, this is the tumor.
yeah, that is the tumor. That is
Yeah,
what,
that's what I'm going to remove now.
yeah.
Upturned it. Now see the tumor, how it is going to come out.
Yeah.
That's the pterygopalatine fossa anteriorly where your clips are.
Yeah.
And this is the tumor behind. See carefully.
Yes.
See this tumor.
Yes.
This is the classical pull.
Who is assisting you, Dr. Satish?
Yeah.
Yeah, my assistant, Ramesh. Tetwa.
Tetwa, na? I don't call him Ramesh. We know him as Tetwa.
See this.
Yeah, yeah. Gentle pull will take
See
out.
how the tumor has come out.
Yes, yes.
Still has not come out.
Never ever try to pack this.
Yeah.
Don't try to pack it immediately because allow the blood to
Drain out.
come out. Don't pack with any tumor residue inside.
This is a big piece actually. This is a big chunk. This is not a small.
Yeah.
Can you see?
Yes,
Yes.
yes. Excellent. Now
See
I
this?
get to the
Yeah.
sum.
And see this tumor.
Yes.
That's a pull.
Yeah.
Where it is going, where it is entering in that area.
That's the pterygoid fossa I told you 10 times.
Hmm.
It was quite a mass.
Yes, yes.
It was quite a big one.
Yeah, yeah. See this?
Yeah,
How nicely it is coming out under vision.
yes.
See, this is the tumor.
Yes.
See this? Under.
Yeah.
See, this is the pull. Can you see?
Yes, yes.
The important is not to break.
Yeah. Be
See
gentle.
this?
Yes.
This is vessel.
Completely out.
This small tag of vessel of fibrous tissue. The vessel it will bleed.
For sure. See, this is venous bleeding, pterygoid venous.
That
Yes.
small
And
tag.
this is healthy bleeding, I tell you.
Yeah.
See this pterygoid component.
Yes, yes.
That was the hallmark in this case.
Yeah.
See this?
Yeah.
Yes, wonderful.
It has come out. That's the pterygoid component. All we saw bulging into the sphenoid sinus and pterygoids.
Yes.
And see now, what is this healthy pterygoid bleeding? Let me show you. Can you see this?
Yeah,
yes,
yeah.
yes, yes.
See this?
Yes, that's pterygoid bleeding.
This can happen only when the tumor has come out.
These
Got
tags,
my point?
these tags are the fibrous one. Few tags which we see.
Pardon?
Few tags which we see in the fossa. Is it the
That was the periosteum.
periosteum? Okay, yeah.
So I will do something to this fossa later. First, me leave it like this, pack for a while,
Yeah.
and remove the rest of the tumor.
Yeah.
See this pterygoid involvement, that is the region where most of the tumors are left behind.
Yes.
That was the crux in this patient. Now, see this rest of the tumor.
Yes.
Yes. शाम तक
I am suction karna. I am pushing it back into the nasopharynx. See carefully. That's the nasopharyngeal pack I kept. I will remove. See this pack.
Yeah.
Either. Now see carefully.
Yeah.
That's the tumor in the nasopharynx.
Yes.
Can you see this tumor in the nasopharynx?
Yes.
Yes, yes, very much.
See how it is pulled off.
Yeah.
Sir.
Can you see?
Yes.
Very clear.
And what is there up is the periosteal attachment. See this.
Yes. True.
I peeled off the periosteum.
Yeah.
Not to break it. Got my point?
Yeah. Gentle pull.
And now, see this periosteum attachment?
Yeah.
I will cut with my
Collator.
see this cobblator. See, this is the periosteal attachment.
Yes. Yes.
Cutting mode.
And then entire tumor will be delivered. See that?
Yes. Yes.
Sir, ये काम.
Goma. बंद हो गया. See the periosteal attachment.
Yeah.
Venous bleeding, don't bother for a while.
Probably a pack for a few minutes will take care of that.
Broken. Yes, segregated.
Yeah.
See now,
Yes.
adenoid surface
Yeah.
never takes any attachment on the adenoid surface. See this?
Yes. Yes.
This is adenoid surface.
Yeah.
The tumor has gone down.
Yeah.
Disconnected completely.
Yeah.
See this?
Yeah.
This is adenoid surface below. And this tumor never takes attachment to the adenoid surface. Only the periosteum.
Yeah.
Yeah, no? No. See this. That's the floor of the sphenoid. See, this tumor is completely down, pushed down. See that? Hello?
Yes. Yes. We can see it. Yeah.
Now see the anatomy, the maxillary sinus to sphenoid sinus to this tumor
Yes.
and the pterygoid, and imagine how can you remove without this exposure?
Exposure is most important so that
Yeah. See the tumor we could remove in last 10 minutes.
Yeah.
Tumor we removed in last 10 minutes. Now let me pack for a while, remove the tumor from below, and then we'll inspect the pterygoid region thoroughly.
yeah.
सरफेस ब्लीडिंग खत्म
जी जी सबसे दिक्कत तो सरफेस ब्लीडिंग होता है.
तो वो खत्म कर देता है.
अपना यूज करता है इसको इंसान में.
करेंगे
Collator divided. हटाएंगे सर वॉल यूनिवर्सल वॉल पर कैसे हटाइएगा. यही बोलो ना. 3 इक्विपमेंट चाहिए. एक फ्रिज चाहिए. पीछे नहीं करते.
ये क्या कर रहे हैं? अच्छा.
डेंटल तरीके से लगा. यही है.
Yeah, this mass is taken out from the oral cavity. Excellent. ब्रेक लेते रहिए, जिसको कंटिन्यू चलेगा इधर. डॉक्टर सतीश डजंट नीड ए ब्रेक. उनका नेक्स्ट केस चालू रहता है. ही हैज द एनर्जी फॉर 10 hours टुगेदर. डॉक्टर सतीश, for the venous bleeding, Dr. Satish, only the pack will be sufficient or something else is required? Periosteal drilling, anything?
Ice is not coming, sir.
Hello, Dr. Satish, are you there? Tattoo assistant. Better than most of it.
और कोई ऑडियंस क्वेश्चन आया है? देखो,
नॉन मेडिकल है.
अभी लोग जवाब देते हैं.
Hello?
Yes, yeah, Dr. Satish.
Yeah. So I am removing the pack now.
Yeah,
See below.
yes,
This tumor never takes attachment onto the adenoid surface. नीचे करना.
yeah,
See this?
yes.
Now I am removing the packs to show you.
क्या वाला
More
बात?
than that.
लिंक इसीलिए तुरंत लेना चाहिए. हम नहीं लेते गुरु, हम होते तो आ जाता सवेरे.
See, that was the region
Yeah,
where the tumor was. See that?
yes, yes.
And this,
venous bleeding or the periosteal bleed is stopped by itself with the pack, or
yeah. It will.
you don't need to drill
I
it?
will. No, I will.
Okay.
I will drill this little bit of the.
Diamond drill, yeah. Mhm.
That diamond will take care of bleeding.
Hello?
Yeah,
See this bone?
yes,
So I will drill away. There's a part of the medial pterygoid plate.
yes.
Remove this.
Yeah. Descending wala.
हटा दे.
Yes. Descending.
Now see the venous bleeding.
Yeah.
See the complete floor of the sphenoid. Relationship with the pterygoid. Can you see very clear now?
Very clear, yeah.
Since this tumor I saw was coming down in the pterygoid fossa,
Yeah.
you could never take a chance. See, all this is healthy area.
Yes.
Can you see?
Yes, yes.
Now I changed this polishing burr, not the coarse burr.
Yeah.
Earlier, what I was using was a coarse diamond.
Yes.
This is a pure diamond.
Yeah. This will take care of all the periosteal bleed and
Yeah. And I will ensure. Action करना है. सुंदर. Just a moment. Oh, section. The last step is to drill away this bone thoroughly. Section the panda. Now we will ensure under vision. देखो panda नीचे.
this is not clear. Dr. Satish, can you ask the cameraman to show the external camera? Some people wanted to see the position of surgeon and anesthetist.
Okay, let me call him to OT.
Yeah.
See now the bone. Though it gives you the feeling when you pull the
Yeah.
tumor, whether you are breaking or not.
Yeah.
But still, and I had a very good feel that I never broke the tumor. See, this is diamond bar. This is not the
That is the deviant nerve.
fourth diamond.
Deviant nerve.
I allowed the venous blood to come out.
Yeah.
To ensure that no tumor is there. Rather than packing these,
Yeah.
Now, see the complete.
What is the point of bleeding? That is a vessel coming from that
You
area.
saw the MRI earlier?
Yes.
Hello, sir.
Yes. That bleeder is.
Hello.
Hello. Hello,
You
Dr.
saw the-
Satish.
You remember the MRI which I had shown earlier?
Yes.
And now see, this is all, pterygoid venous plexus oozing.
Yes.
That is immaterial. See below.
Yes.
That's the medial pterygoid muscle.
Pterygoid muscle. Okay.
This is medial pterygoid muscle. See this?
Yes. 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 Okay.
See, let me stop this oozing to show you and see the bone around. Absolutely flush. See all around.
Yes. Only flushed.
This is most important.
This is muscle, no?
I'm coagulating the muscle.
Yes.
I told you medial pterygoid muscle.
Will it have any impact on muscles? Muscles of mastication?
No, nothing, boss.
इतनी बड़ी-बड़ी
This is to show you the skull base thoroughly. This was a soft muscle which are now coagulated. And now see the entire pterygoid complex and the roof of the pterygoid, the sphenoid. See, this is that is the interior of the sphenoid. Can you see? Floor of the sphenoid, floor of the lateral wall of the sphenoid. See that? Hello?
Yes, yes, Dr. Satish, we are with you. Yeah.
See this, see this. See the pterygoid walls all around.
Yeah.
This is radical, destruction of the pterygoid, removal. And if you don't remove the pterygoid, this is likely to come back. And the recurrences are more horrible, I tell you.
Yes.
The blood supply is unpredictable. See the adenoid surface? Absolutely normal.
Absolutely.
The floor of the sphenoid I have removed here thoroughly. That's the pterygoid fossa.
Yeah.
That's what this is.
लंच का ब्रेक नहीं होता है, लंच लोग जाएंगे आएंगे, सर्जरी चलती है।
पहले बंद हो गया था फिर चालू हो गया था कोई
Now I am just leaving a small surgery cell in the fossa. Take care of everything.
वही मसल से था दूसरा मसल
Dr. Satish, since it is a child, will you like to put a pack for a couple of days?
Yes, for 2 days at least. See now,
Yeah,
my surgery cell will take care of the pterygoid fossa. See,
Yeah.
it has stopped. That is the flush bone all around. See this?
yeah,
This is important.
yes,
See, that was the part of my drilling.
yeah,
See all this bone everywhere.
yeah.
See, close up.
Yes,
All flat bone, no porous bone now.
yeah,
वाले में भी अगर ज्यादा ब्लीडिंग हो यही रखते एकदम ठीक है
And that is what, see the pterygoid process, the inferior most part.
yeah,
This is the pterygoid fossa.
yeah.
And this is all,
I think
everything.
perfect hemostasis is obtained now. And will you like to keep a pack for at least 48 hours? Since
Yes,
it's a
yes,
child?
100% I will keep a pack.
Yeah,
I will definitely keep a pack for 48 hours.
yeah.
Anything you
What
want
is
me
that?
to show?
What is that? You are just plugging it. Are the tags only?
Pardon?
The one which you are putting up now are the tags only?
Yeah,
Fibrous?
that's a periosteum, periosteum.
Periosteal. Okay, fine.
That's the pterygoid fossa I told you.
Yeah.
इसका जो देख रहे हो इसका कारण
More.
So the take home message for this surgery was to take care of the, first understand the radiology and take care of the pterygopalatine fossa.
Most important is radiology.
Is that Dr. Satish, anything else you want to add?
No, no, absolutely agreeing with you. Most important is the radiology. Then exposure. Then give a special, attention to the pterygoid region. Because that is likely to be the most important site for the so-called recurrence. All this is muscular fossa. Drill. All this is muscular fossa. Drill. A little bit of the flushing here.
Yes. I think we are absolutely clear. There is no mass left. All areas has been seen.
Pardon?
All areas have been seen thoroughly. There
Yes, yes.
cannot be a residual mass.
Correct.
And do you take another radiology after how long to check about the residual?
See, the beauty of the endoscopic surgery is
Yeah.
now you have an opportunity to inspect for any recurrence.
Yes.
Somebody asked about the maxillary swing.
Mhm.
You swing the maxilla and replace it back. What happens? What happens? How will you monitor the recurrence behind?
Yeah. So that's why it is better to keep it open.
That is, then only the radiology will have a big role.
Yeah.
Every now and then, see this bone,
Mhm.
I wanted to drill it.
Yeah.
ये जो अभी कर रहे हैं
I mean, this makes your follow-up much easier. Just by putting an endoscope, you can
Yeah,
have
that's it. That's it. Nothing else.
nothing else. No radiology is required.
Nothing. No, wash करके pack कर देना. So this is all about this JNA.
Yeah, young PGs, any question? Young PGs, any questions from the master? You explained so clearly that everything is crystal clear.
फैन है
No, we have been interacting, so that's why.
Hello.
Yeah.
Hello. Hello.
Yes, yes.
Mr. Drokle. Hello.
Yes, please.
So this was about the.
Yeah.
Any questions?
I think you have answered most of the things during our discussion. Yeah, like, bolo.
Now we move on to the next case. Hello.
Yeah.
And next case is a interesting one.
Next question.
Next case is interesting one, and this is going to be submandibular gland excision. Again, coming to the head and neck.
Question है अभी.
Otology, rhinology, head and neck, again head and neck.
Few questions are still left, sir.
Yes, please.
The question from Kuldeep from Kota. How much the chance of opening of the clip in post-op period?
Chances of?
Opening of clips.
Post-operate 0.
I didn't get. Can you repeat?
Chances of open
Giving way.
giving away in the post-operative period. In the post-operative period.
Giving
Not
away.
in the post-operative 0.
What are the chances of?
Opening of the clips.
Slipping of the clips.
Okay, clip. If you place properly, it's unlikely to slip. It depends. If you are not happy with the, placement, you can attempt it again. But why we are using clip is for the best sense of security.
Yes.
If clips are not placed properly, then there is no fun.
Yes.
So out of all measures like unipolar, bipolar, Sagicel, whatever,
Clip is the
oblator, anything, the clips are the best.
yes.
The thing which required is proper placement.
How many clips minimal should be used? At least 2 clips.
Yeah, at least 2 clips, just to give additional sense of security. That we use 2 clips in case one slips, other is there to protect. And that rarely happens post-op, but intraoperatively with instrumentation in the same area.
I have also faced that situation.
If it slips off one, we can always use the other, take the help of other one. Post-operatively rarely happens. This is for intraoperative additional security.
Dr. Viral from Ahmedabad asking what type of was given. Is it warm saline or adrenaline diluted form of saline was? Never adrenaline.
It was simple ringer lactate, nothing else. Saline ringer lactate.
Saline ringer lactate.
Submandibular. Slap for it. Submandibular fine. Microscope. Hello.
Yeah. इसका खाना
Hello.
Yeah, please tell about the next case.
Yeah, the next case is I told you about the submandibular gland excision.
Yeah.
Patient has a stone as well, but this gland has become completely fibrotic.
Yeah.
With recurrent infection. And see the MRI.
Yes.
The gland with huge fibrotic gland with a.
Dr. Satish, just one question before you proceed. Is
Yes,
it
please.
CT or MRI? Which is the investigation of choice?
For salivary gland.
Mandibular, yeah, salivary gland.
Any salivary gland, submandibular, parotid, MRI is the investigation. There is no even alternative, no match to MRI because it gives excellent soft tissue details.
Yeah.
And with the MR silogram, you get the entire details of the ductal system.
Right.
Which you otherwise can't get with anything.
Even for the CA tongue also, MRI is the investigation of choice, not
Yeah,
the
yeah. For all malignancies.
yeah, any soft tissue
Even,
you can say that.
even earlier it was thought that for the bone erosion in malignancy, CT scan is the best.
Yeah,
MRI is the best. It will give you complete information about the bone marrow involvement, which CT scan cannot give.
and always a contrast enhanced
Always contrast with diffusion.
with diffusion.
Now, this particular patient,
Yeah,
look at this gland. This is T2 weighted. Let me show you contrast.
yeah,
This is right submandibular gland,
yeah,
which has completely become fibrotic,
yes,
had multiple stones. See the number 1 here
yeah,
in the gland also,
yes,
at multiple places stones.
in the duct system.
Yeah, as earlier got the this thing stone removal done 3-4 times.
Okay,
Gland ultimately has become non-functional fibrotic.
fibrotic. Okay,
See the gland from the opposite side to this side,
yes,
the kind of inflammation.
yeah,
It's completely fibrotic.
this is the beauty of MRI, which we can never get in CT.
Never, never. CT scan will give only bony details. That's it. But even those bony details are now best depicted, like if you want to see for tumor erosion or anything,
Mhm.
with MRI.
Yes,
Otherwise, by and large, for the bone, CT is better.
yes,
MRI doesn't pick up bone. In all sequences of MRI, the bone is always dark, signal loss.
yes,
See the mandible, the bone is black.
yeah,
For all sequences of MRI, the fat is always bright.
yes,
This is fat suppressed.
yeah,
Now, let me tell you the regular T2 weighted and what is the difference with the fat suppressed. So, fat suppressed sequences, like we discussed several times during mucormycosis time, the fat suppressed images suppresses the fat and that differentiates the inflammation from the fat.
yes,
So, in all sequences, the fat is always bright.
yes,
See this T1 weighted.
yeah,
Everywhere this bright is fat.
yes,
See this? And see this fat suppressed.
yeah, you can see all the dark areas. Yeah,
Now the inflammation is also bright on T2.
yeah,
Now, if fat is there and inflammation is also there, you can't differentiate.
right,
So then take the fat suppressed sequence.
Yeah.
Now, whatever enhancing remains is always inflammation.
yeah,
That's how we could pick up, this thing, mucormycosis easily on fat suppressed MRI. Suppress the fat and whatever enhancing remains is the inflammation.
yes,
So this submandibular gland excision is an important surgery from, technically challenging for certain regions because there are a lot of neurovascular structures.
yes,
Our goal in this surgery to protect all the nerves, the technique how to protect those nerves, like the marginal branch of the mandibular nerve, facial nerve, marginal mandibular branch,
yes,
then the lingual nerve, hypoglossal nerve, and then the preservation of the facial artery.
Yeah.
We know in submandibular gland resection, the facial artery is usually sacrificed.
yes,
Nowadays, in the era of free flap, facial artery has become a very, very important donor vessel
yes,
for the free flap. The facial artery sacrifice is justified when you do a radical clearance of the submandibular fossa, like in malignancy. When you are doing a neck dissection, then it is justified because you can leave the lymph nodes along the vessels.
yeah,
But in benign situations like for sialoadenitis or benign tumors or on all those, it is not justified once you can save it.
Yeah.
So we have shown always, and this is again a demonstration to the technique to save the facial artery, how the glandular branches to the submandibular gland are taken care of, because this artery passes through the gland posteriorly
Yeah.
and gives number of glandular branches
Yeah.
and a major vessel, submental artery.
Yeah.
Submental artery is a useful vessel for the submental flap, which is very useful in oral cavity lining sometimes, or for any facial defects. Submandibular flap, for us also submental is a popular flap. If you have a oral cavity defect, you want something for lining, like free flap, you use radial free arm. You can use the submental flap also. That is very, very reliable flap for any facial defect, skin or subcutaneous defect. You can again use the submental flap. So that submental vessel, of course, is sacrificed in the submandibular gland surgery, because you have to ligate the submental vessel. But rest glandular vessels can be preserved. So anything before we go into the surgical part? Any questions?
Anything? I don't think there is any.
The next case after this is going to be a very interesting one, rhinosporidosis.
Yeah. Basically, Dr. Satish, my view and I talk to you, we want the simple cases which people do in day-to-day life. Let them do in a proper manner, and whatever mistakes we were doing, we should not do it.
Absolutely, sir. That's how because of your suggestion,
Yeah.
I kept all these routine cases.
Because these routine cases are done by everyone in whatever setup they are working, and so they should be very clear about it.
Okay, sir. Let's move on to the surgical part. In a couple of minutes, we'll be there.
I will visit definitely. Yeah, sure.
सिगरेट पीना स्वास्थ्य के लिए हानिकारक है।
अरे ये तो है, चल बैठ लीजिए इसको। आ जाओ, क्या नाम है उसका? चल बैठो, हम बैठो। हाँ, हम
हेलो।
नहीं हम हैं, आप आइए नहीं करके, आप फ्रेश हो, आप आइए फ्रेश होके, बैठिए सर। लगातार चलते रहे। अपना खाना खाता
Good afternoon, Dr. Satish.
Hello,
Hello, good afternoon, Dr. Satish. Myself, Dr. A.K. Thakur from Dhanbad.
sir. Good afternoon.
Good afternoon. So,
So this was about this case. I had already given you the details.
yes,
This is right-sided submandibular gland excision.
okay,
Now to orient you. See, this is right side. This is the pinna.
okay,
That's the submental region. And that is the site. What I palpate always is the gonian.
okay.
Gonian is what? the posterior edge of the mandible, where it turns up. Got my point?
Okay.
That is a very, very important site for, some mandibular gland surgery. I'll tell you the reason behind that.
Okay.
And this is the stony hard gland. I told you got fibrous.
Okay.
So
So,
first of all, my incision
uh,
would be just below the gland, coursing anteriorly.
okay.
Once I elevate, like thyroid, I will change to the different areas because I'm operating to the microscope.
Okay. So please give the brief regarding the extent of the incision to the audience.
Yes. See, my incision is 2 finger below the edge of the mandible.
Okay.
That's the gland here. And this incision yes. Any neck incision, when you give in the neck, it is always subplatysmal.
Okay.
Subplatysmal. All neck incisions are given subplatysmal to keep the platysma in the flap to give it a strength. And number 2, you get a relatively avascular plane deep to platysma.
Whether you have infiltrated some,
Pardon?
you have infiltrated some local with adrenaline or anything else?
Yes, yeah. Yes, we have infiltrated saline adrenaline.
In what concentration?
That is, I think, 1:80,000.
Okay.
See the cut edge of the platysma, can you?
Yes.
See the cut edge of the platysma. This is the depth of the
Platysma.
yes. Your plane should be subplatysmal. Now I will raise my flap, the superior flap, and the important thing about this is to stay strictly subplatysmal to save the marginal mandibular branch.
Avascular one.
See now, as I raise my flap, I'll be going just hugging the platysma. Can you see this?
Very good level of the dissection.
This is hugging the platysma.
Okay. So you are using the unipolar.
Yes, for this, just hugging the platysma.
Yes.
I don't want to violate this plane. A deeper one, I'll come across the marginal mandibular branch.
Okay.
The branch of the facial artery. बंद है यार. So the I need not to go far anteriorly. I hope you are getting what I'm trying to show you about the incision part.
So what branch of the facial artery here?
This was a, it's not the named one,
Okay.
just a superficial branch somewhere. See, this is the gland.
Okay.
This is a huge one. Completely looks like very inflamed, calcified. This is an obese patient.
You have already mentioned that it's stony hard.
Yeah. And the thing which I want to palpate here is the posterior edge of the mandible.
Okay.
That is the most important anatomy, I tell you.
Okay.
See, there are many ways to identify and preserve marginal mandibular branch. But all those are indirect methods. The nerve crosses the facial vessels.
Yes.
This nerve coming from here horizontally
Yes.
crosses the facial vessels.
Okay.
So earlier the proposition was to identify the vessel, ligate below and turn it, fold it up to protect the vessel. Now,
Okay.
but this nerve has a variable course. You cannot protect all the time this way. This is indirect. You never know the nerve is protected or not.
Okay. Okay.
The most direct method is, as we always believe, positive identification.
Okay, sir.
So in this case also, we will do the positive identification of the marginal branch, and the landmark for that is the gonian.
Okay.
Now, what is gonian? Gonian is the posterior edge of the ramus of the mandible.
Okay.
Marginal nerve, most of the time, as it is given off from the lower division, run horizontally down and crosses the gonian. This is gonian where I'm feeling. A nerve is always there in a centimeter vicinity of the gonian.
Okay. So this is the important landmark during the dissection.
Yes.
That
For
will-
me, the biggest challenge here is he's too fatty to feel the gonian reliably.
Okay.
It's too fatty.
Okay.
So I will expose 1 centimeter of the vicinity of the gonian.
Okay.
So first goal is to identify and preserve this marginal branch. That's a very, very important, nerve which supplies various muscles at the angle of mouth. An injury to this, is a bad deformity, which is not acceptable to the patient.
So it should be preserved during the dissection, just to prevent the complication.
Yes, so it should be protected, preserved. This is a very, very slender nerve, and I can now see this. Can you see this?
Yes, sir.
Can you see very clearly?
Very beautiful. Excellent. Excellent, sir. Very,
And
very
that is a very, very important nerve. See and preserve. Another thing is the facial vessels. From the gonian, the facial vessels are roughly 20 centimeter anterior. See, this is the angle.
Yes, sir.
1, 2. This is the site of the facial vessels. See this facial artery.
Yes, sir. Very
You
good.
see?
Yes, sir. Very nice.
So the facial vessels are more than 2.5 centimeter anterior to the gonian. And see, this nerve crosses the vessels.
Yes, sir.
It divides into branches many a time. And one should try to preserve each and every branch of this if possible. See,
sir.
one branch is this, one is this.
Take it up.
This is another branch crossing. And going far anteriorly. Aim is to leave this nerve until it leaves the region. See these two.
Yes, sir.
So these two are the branches, one this and one this, and we'll do every possible effort to preserve this. Now the best, the beauty is with the positive identification, once you identify them,
Yes, sir.
they are under vision while you are working in this, triangle in this region. So you have a better opportunity to preserve these nerves. See these two branches?
Beautiful dissection, sir.
Non-tooth. So keep this nerve away from your area. Because vessels are below.
Below the nerve.
Yes. That's why the earlier indirect method was catch the vessel below and reflect up to keep the nerve away. But that is indirect method.
But you prefer to.
Yeah, see carefully, protect it, separate it, and then work freely. Scissors.
Yes, sir. Excellent.
I want to keep this nerve away from the field so that we can work. And the beauty is you see all this under vision because we are operating under microscope.
Yes, sir. Dr. Satish.
Yes, sir.
Our president, Dr. S.P. Singh sir, wants to tell something to you.
Yes, please.
Sir, to see your surgery, Dr. Harsh, Dr. Sumitro, and Dr. Sodipo has come from Medical Super Specialty for Calcutta.
Oh, great to see them.
Surgery, sir. I am giving the mic to Dr. Harsh.
Sir.
Hi, sir. It's a big honor to be here and watch your surgery.
All right, boss. Pleasure.
I'm a big fan of you and I've met you often at Tata Hospital, Bombay, sir, when I was training. So it's really great to see you, sir.
Great to see you, man. So see the mandibular nerve and its branches and see the facial artery and nerve vein. Can you see? Hello? Hello?
Yes, sir.
This is the marginal mandibular nerve and its branches.
Yes, sir.
Which I have reflected up.
Yes,
and
sir.
this is the facial artery and vein.
Yes, sir.
Okay.
Yes, sir. Yes, sir. Just beneath the nerve, the facial artery is there.
Yes, the facial artery and nerve is there.
Yes,
I
sir.
can push the nerve more and more up
Yes, sir.
so that it is away from our surgical field.
Yes, sir.
See this nerve has gone up all the way.
Yes, sir.
And now we can play our game below to remove this gland. Now, I told you, removal of this gland involves, preservation of lot of structures. One of them we have already seen, that is a marginal branch. Rest are the hypoglossal and this thing,
Yes, sir.
lingual nerve and the facial artery itself. Facial artery is very, very important nowadays. And in such benign situation, one should not unnecessarily sacrifice this. Now I am coming at the inferior edge of the gland. See this gland?
Yes, sir.
I am coming at the inferior edge of the gland.
Yes, sir.
Is some vein? Yeah. Yes. This is one of the facial nerve crosses the gland here.
Yes, sir.
Anyway, so this is the inferior edge of the gland.
Yes.
Blood. No, hold this. Give me one more. Like this. See, the gland is, I told you, completely because of the infection, like calcified,
Yes, sir.
hard, with a lot of infection as well. My goal here is to go to get below the gland. Get below the gland, since it is lot of periadenitis, you can see.
Yes, sir.
Inflammation around the gland. This is all expected in such inflammatory situations. Nothing new. But this is all periadenitis. It's adhered to the tissue planes all around. See that?
Yes, sir.
My goal here, as I go down, is to look for one structure, that is tendon of digastric.
Yes, sir.
That is the next principal landmark I wish to see.
Which belly, anterior or posterior?
Posterior belly of digastric.
Okay.
See how big and calcified gland it is. I lift up the gland. Yeah. यूं पकड़ ले, पूरा मत पकड़ दबा. See this. If I elevate the gland, you will find the level of the digastric there. Can you see here?
Yes, sir.
Can you see the tendon of digastric?
Yes, sir. Yes, very clear. Very clear.
So that is an important landmark. This is huge periadenitis. Normally, you will never find such adhesions unless there is recurrent infection and the gland, the stone impacted in the gland leading to inflammation, which is not resolving.
Yes, sir. So this is the posterior belly of the digastric.
Yes. There's a stone in the gland, I told you.
Yes, sir.
And such situations of, stone in the gland cannot be treated by any siloendoscopy or any other means. With thick periodinitis, you cannot handle by endoscopic or other approach. A lot of people have, nowadays publication of endoscopic submandibular gland excision. But this is impossible with this. See the posterior belly of digastric?
Yes, sir.
Again, see my marginal mandibular nerve there.
Yes, sir.
Since we have kept the nerve away, so that is the best way to protect it. And this is your digastric.
Yes, sir.
And if I look into this, see the periodinitis. See the digastric is adhered to the gland
Blind.
completely.
It's very adherent.
See, completely adhered. And now at the posterior inferior edge, I intend to see some, structures. वो दे दूसरा. Section. I intend to see some vessels there. छोटा देना right hand. Ear वाला. Ear वाला लगा. Give me the smaller retractor. So at the posterior inferior edge of the gland is what you see inside the submandibular triangle, the facial artery ascending.
Facial artery and the marginal branch of the mandible.
Marginal is away. Now the facial artery ascending in the submandibular region.
Yes, sir.
Facial artery is a branch of, see this facial artery?
Yes, sir.
Very nice.
That's a branch of external carotid.
Yes, sir.
See this? This vessel ascending in the submandibular triangle.
Very excellent.
Can you see the facial artery?
Yes, sir. Very beautiful.
So that is inside the digastric. See, you can break the adhesions
Yes,
with
sir.
the blunt dissection. See, I want to push my gauge piece just staying on the gland surface to the depth, and depth, the floor of this triangle is formed by hyoglossus muscle.
Yes, sir.
See, this is blunt dissection protecting everything. Could you see?
Yes, sir. Very clear.
Now see the artery. It is ascending from here and coming out of here.
Yes, sir.
See, it is passing through the submandibular gland. Go, give us one. And that is something you need to separate. Now this gland is very much,
Yes, sir.
having adhesions. So protection of the artery is a big challenge, like separation of the artery. Let's see. It has become stony hard. See the floor of the triangle.
Yes, sir.
And the structure which is passing through the floor, this is your hypoglossal nerve.
Hypoglossal.
So with this much of infection, periodinitis, little oozing is expected. And now the challenge is to separate this artery. Just a big vessel, branch of the external carotid.
Yes, sir.
See that? See the facial artery.
Yes, sir. Very excellent. Very nice.
But this is tightly, impacted.
Satish, Dr. Satish. Hello.
Yes, sir.
Hello.
Yes, boss.
Is it necessary to ligate the this facial art in each and every case at the both ends, because sometimes it can be separated very nicely from the gland?
That's what I was telling.
Okay.
I could have, ligated the artery here and there and could have removed the gland by now. So trying to separate this in a regular submandibular gland dissection, we are able to separate it easily. But here the gland has a huge, extensive periodontitis. Gland is calcified.
What is the history? How long it was there, sir, Dr. Satish?
For years, undergone, stone removal 3-4 times.
Yeah.
And since stone is there right in the gland itself, the inflammation is impossible to control now. See the vessel?
Yes, yes. Should you preserve the vessel in all the cases?
In benign situations.
Yes.
See my nerve above. That's the beauty that to preserve the nerve. See the nerve above.
Yeah. Yes.
It can otherwise come anytime in the instruments.
Yes.
So in benign situation, you must try
To
the
preserve.
level best to preserve this. Malignancy, neck dissection, that's a different scenario, because then the perivascular lymph nodes are there. That can affect the oncological, clearance. But in benign situation, important because the facial artery is very useful artery.
In future, if he has malignancy, some flaps are required. Then
Yes. And why unnecessary to sacrifice once it is not the culprit?
Right.
Use periodontitis.
Everywhere there are adhesions.
Had there not been periodontitis, would have been through by now.
Yes.
All those branches emerging from this are mostly from the anterior edge.
Yeah.
Mhm. See the vessel.
Yeah.
Sort of. This is the vein I am taking away.
Yeah.
Artery is away. I almost separated. Look. Flap उठवा दे. Hello?
Yeah.
Flap उठवा दे. Flap उठवा दे यार. हटा ना यार. फ्लैप उठवा दे. सुनता नहीं क्यों? ऑनलाइन हूँ. Hello?
Yeah. Yes, sir, Dr. Satish.
Yes. So look at the tortuosity of the vessel.
Yeah. If you take out the stone from the gland, will it make it more easy to maneuver?
No, no, no.
Okay.
Now for that you have to divide the gland.
Yeah. It is so adherent.
Extra 5 minutes.
Yeah.
See the vessel.
Yeah. Almost denuded and cleared.
See this?
Yes.
Bipolar. See, this is one vessel, glandular branch.
Yeah.
See number of glandular branches.
Yeah.
I am coagulating.
Yeah.
Tomorrow we have a live surgical demonstration of a cochlear implant. Now 1-year-old child, subtotal petrojectmin implantation, same stage.
Oh.
Those who are interested can log in and we'll make sure that this is available on the same, this login only. 1-year-old child, profound.
Tomorrow you have a lecture also in oration.
Yeah. See this branch. So that case is after that.
Yeah, you told me.
So those wish to join,
Yeah.
can join. I will make sure that this comes on this today's link also.
Okay.
So that's an interesting case of 1-year-old child, profound deafness, history of one case of some mucus cleft palate, recurrent secretory otitis media. So because of the recurrent otitis media, see now this bigger branch,
Yeah.
this one is the submental artery.
Yes.
So just So on this side, on this anterior surface has multiple glandular branches, which are coagulating. Another branch. See this big branch. Can you see here?
Yes, yes.
That is submental artery.
Centralize a bit. Yeah.
This is how this artery being separated off the bed.
Yeah.
सब लोग वही बोल रहे हैं जिसको जो अच्छा चाहिए मिलेगा तब सबको मौका देना
See all those glandular branches.
your life is off
Yes. Almost through, huh?
Yeah.
Yeah.
So nerve is above that. See here. See here. The vessel is there anteriorly. And now you can say it is completely segregated. Can you see?
Yeah. Yes.
See so many branches of this nerve.
Yeah.
Okay.
Keep close to gland and go on this.
No. So the vessel is separate now.
Yeah.
That was the biggest challenge. It was difficult. Now coming to the other aspect, we need to, see the lingual nerve, the hypoglossal, and the duct and separate the nerve.
Right.
So coming to the anterior edge of the gland.
Yeah.
See here?
Yeah.
That is where the digastric is.
Yes.
And underneath that goes the mylohyoid muscle.
Yeah.
This muscle is mylohyoid.
Yeah.
See, this muscle is mylohyoid. Can you see?
Yeah. Yeah.
This horizontal muscle,
Yes.
part of the gland is superficial to it, part of the gland is deep to it, which is known as the superficial and deep plate loss of this gland according to its relationship with the myeloid, superficial or deep to it. See, this is superficial part, this is deep part. Okay.
Yeah.
So, see, this is myeloid.
Yeah.
Inflammation means bleeding.
Yeah.
Yeah, I will retract the myeloid now.
So that the deep portion is exposed.
Bole. Yes. I can see the neurovascular structures also.
Yeah.
See how much of the periadenite. This is the stone there.
Yeah.
Come on. Amazing submandibular gland. That's the hypoglossal nerve, you can see.
Yeah.
Could you see the hypoglossal there?
Yes, yes. Just below your retractor.
This looks like the and a lingual nerve which courses from above, which is a branch of, see the lingual nerve, which gives postganglionic fibers. See everything adhered. All around thick adhesions.
उसमें थोड़ा सा आप एक काम करो, डॉक्टर समित लाल से बात कर लो. Accommodation part he will be able to help you because I am not looking at.
Now, even lingual is not clearly visible. ये वाला retractor ये लगा बड़ा.
Yeah.
बड़ा retractor लगा.
That is probably too adherent to the gland.
Yes, yes. So lingual here comes from the infratemporal fossa.
Yes.
Give the postganglionic fibers and then run again back in the oral cavity. Now see the lingual nerve.
Yes.
It arches in the submandibular fossa.
Yeah.
Let me show you. Can you see the nerve?
Yeah. Now we can.
And then turning anteriorly towards the floor of the mouth. Retractor लगा ऊपर. Let me show you the lingual nerve very clearly now. Yeah. See now, let me.
Yes, yes. We can see the main trunk.
See the lingual nerve coming from above.
Yeah.
This carries the postganglionic fibers for the submandibular gland, which join in the infratemporal fossa via the chorda tympani.
Yes.
And then it is going anteriorly into the floor of the mouth. Can you see very clear?
Oh, yeah, very clear.
Now, what is there close to this? This.
Duct.
Duct. See the purulent discharge. See how inflamed it is, you can imagine.
Yeah, yeah.
So inflamed. So first of all, I'll separate the lingual nerve to keep it away. No, no. Oh, no.
At what level the duct has to be separated and tied?
We will palpate proximally first.
Yeah,
Look for the stones.
yeah.
See, even after the submandibular gland excision, patient can develop stones in the Wharton's duct.
That's, yeah.
How come?
Because the mucosa is already there and that is secreting.
Actually, sublingual gland
Mhm.
has, sublingual gland drains into the oral cavity.
Yeah.
It drains through a lot of ducts known as ducts of Rabinus into the oral cavity. 5 to 20.
Yeah.
And there are certain ducts from the sublingual gland known as Bartholin's duct.
Yeah.
They open up in the Wharton's duct distally.
Yes.
So even if you ligate the duct, the stone can form.
Yeah.
Got my point?
Yeah, yeah. So it should be as distal as possible in the floor of the mouth.
Yeah. So don't give a patient guarantee that once I have excised the submandibular gland, now stones can't form.
Very important point.
Now see, I have elevated the lingual now.
Yes.
So tightly adhered.
Yeah.
The base also.
Yes. It has
See,
to.
this is lingual now.
Yeah, yeah.
I have cut the postganglionic fibers
Yeah.
and elevated.
Yeah.
See the lingual nerve separated?
Yeah, yeah. Easy.
Lingual nerve, duct, and this is hypoglossal.
Yes.
Let me show you. All three in a row.
Yeah.
This is lingual, this is duct, and this is hypoglossal. See the hypoglossal now.
Yeah, yeah.
See this hypoglossal?
Yes.
It's running with a lot of vena committents here. Now is the time to ligate this duct. And before that, I will feel in the oral cavity if there is any stone. There was no distal stone. The stone is right in the gland itself.
Yeah.
So now we can ligate it.
But that ligation should be as distal as possible towards the floor of the mouth.
It should be, but since the sublingual duct open up very close to the papilla,
Yeah, so it is
not going to make any difference.
right.
This is where the duct I am going to ligate.
Okay.
Now you can remove the gland without any
Hindrance.
See this. So we have lingual now. See this shining lingual now. This is hypoglossal now.
Yes. Yeah.
We have already preserved the facial artery. We have preserved the marginal branch. Because of the peritonitis, it took literally long. Otherwise, would have been through earlier.
The plane would have been much easier. Here, there are a lot of.
Then it would be different.
Yeah.
Now nothing, but just to. Yes, there's nothing, no attachment.
It's quite free now.
Out.
Yeah.
It's out now.
Yeah.
And what a gland it was.
Yeah.
What a gland it was. Amazingly, you know,
There must have been multiple stones in the gland itself.
must be.
Yeah.
Now, see the field now, and now the infection level of this patient will
Yeah.
be relieved like anything.
Yeah.
See, the field is good now. Again, लगाना है?
There is hardly any gland tissue left.
No gland tissue. Now, the important thing is some anatomy here.
Yeah.
See, this muscle is the hyoglossus muscle,
Yeah.
which the submandibular gland rests.
Yes.
This is mylohyoid muscle.
Yeah.
Underneath, all the three structures go.
Yeah.
Hypoglossal, lingual, and in between the duct.
Yeah.
This is digastric. The facial artery runs over the hyoglossus
Yes.
to come in the submandibular fossa. And you know, you saw in the this thing, CT angiogram in the morning, MR angiogram, the facial artery, the lingual artery. The lingual artery is given off just below, before the facial artery.
Yeah.
And that runs deep to hyoglossus, up. Lingual artery runs deep to hyoglossus, toward the tongue.
Yeah.
And parallel to the lingual artery and above, deep to hyoglossus,
Is the lingual nerve.
comes the glossopharyngeal nerve. So there is some oozing expected from this infected tissue. इसको उठाना, इसको ऊंचा कर. उठा.
In this, you put a suction drain or a corrugated drain?
Corrugated will take care.
Yeah.
I don't want suction drain
Yeah.
when there are a lot of nerves in the field.
Right.
See, just give me a piece of Surgicel. No pointing and fiddling into it. We'll just leave a piece of Surgicel and pack with the gauze for 5 minutes. It will stop. See the Surgicel? एक और देना, छोटा दिया है. Yes. Just 5 minutes.
Yeah, yeah, it is through.
After 5 minutes, we'll remove the pack and put a corrugated drain. There is generalized oozing. So this was all about the
Submandibular.
submandibular. The next case, hello.
Yeah, please go ahead. Yeah.
So next case is very, very interesting,
Mm-hmm.
very challenging, very frustrating issue for the patient as well as doctors. And that is a rhinosporoidosis.
Yeah.
And this particular patient has undergone multiple surgeries, I think 2 or 3 times.
And what is the reason for recurrence, Dr. Satish? Incomplete removal?
You never know. See, this problem is so frustrating.
Yeah.
Nothing, I mean, I would say much known about this rhinosporoidosis so far.
Mm-hmm.
There has been a big suspense on what kind of pathogen it is.
Yeah.
For decades together, it was believed that it is a fungus.
Yeah.
But finally, this theory was declined. It was not a fungus.
It is a parasite.
It could never be cultured outside like any other fungus.
Yes. Parasite, right.
Then it was considered as a protozoa,
Yeah.
sometimes as a parasite. Many different theories.
Basically, Dr. Satish, in our states, especially the people coming from the Bengal who are in the habit of pond bathing, it is very common. And
Yes.
now the incidence has really gone down because maybe people are more hygienic. And we have done so many cases. Only important point was the cauterization of the base. That was
Base.
the key.
Yes.
So,
A lot of things into it.
yeah.
So finally, nowadays, it has been believed that it is a, I would say, aquatic parasite.
Yeah.
Which infests not only human beings, but the fish also. And the treatment, like you said, rightly, the treatment is complete surgical excision with cauterization of the base.
Yeah.
There is hardly any effective medical treatment so far.
Anti-protozoans have been tried, but reports are
Nothing
not.
works. Nothing works.
Yeah.
Dapsone has been tried and it has been believed to work to some extent. And believing that, we also give Dapsone to certain patients having recurrent rhinosporidosis.
Yeah.
What we believe in the surgery, the most important thing is to prevent the dissemination to the other side.
Yes.
This we have observed for last many years and we could get success also with that. See, once you start removing rhinosporidosis,
Yeah.
it is not limited, some disease which is limited to the nose.
Yes.
It can be disseminated anywhere.
Yeah, yeah.
Any area which is abraded, this pathogen can inoculate again and start growing there.
And the spores can remain for a very long time as a dormant one.
Yes. So like if you have a raw area in the nasopharynx, it can infest the nasopharynx. It can, there are reports where there are disseminated rhinosporidosis involving the skin, eye, even in the deep visceral areas and many other areas. So it can practically infest anywhere by hematological, direct inoculation, by trauma or whatever region.
Yeah.
It is, many of the things are unexplained. The immune aspect about this pathogen is unexplained, is found in the immunocompromised as well as immunocompetent patients. Even the young immunocompetent patients are very commonly affected. The same story with this patient, a 34-year-old.
Yeah.
So the bottom line, what we can do is complete excision with cauterization of the base, preventing dissemination to the other sites during surgery. This is very important. So what we do when we operate such case, we pack behind with the nasopharynx, with the gauze. We never ever try to avulge it.
Yeah.
We remove it under vision. That is our technique of choice, by means of which we can do it under vision and prevent dissemination. Because that can happen only when it is done under vision, bloodless.
Yes.
And cobblator is the tool here. Believe me, this is one of the biggest use of cobblator. I told you this disease is frustrating not only for the patient but the surgeon also.
Silver nitrate pack, which we used to do in early days. To
What?
prevent silver nitrate pack.
Silver nitrate packs, betadine packs,
Doesn't
so many
really
things.
help.
Yeah, all been tried, but there is no conclusive evidence.
Right.
Still, we have been using betadine.
Yeah.
It's a pure povidone iodine solution.
Mhm.
We fill the entire nasal cavity for 10 minutes at least.
Yeah.
And then pack with the pure povidone iodine for 2-3 days.
Yeah.
It has been, known to have an effect on the sporangia.
Yeah.
To prevent maturation. That is what the medical treatment does. Dapsone. What does the Dapsone do?
Yes.
It prevents the maturation of the sporangias.
Mhm.
It induces fibrosis also.
Yeah.
So what happens? You know, where we are using Dapsone practically for all recurrent cases post-operatively in spite of having done well, because in spite of the good surgery done, you can never guarantee the recurrence. This is one of the problems
How
which is
long?
not fully understood so far.
How long you give Dapson?
So we don't give, we send to our medical team with dermatologists as well.
Yeah.
And they give it to 6 to 1 year by 100 milligram once a day.
Right.
And Dapsone is not a good drug to be given by ENTs. It has a lot of adverse effect, interactions, and so many things.
Yeah.
So better to leave on the medical team.
Yeah.
So we always send patient after counseling to the medical team post-operatively for all recurrent cases, not the primary one.
Yeah.
That is a different aspect. But the thing which we use most often, the Dapsone therapy before surgery.
Okay.
Once you plan this surgery, once you plan this surgery, start Dapsone a few weeks before. That is a good strategy that allows the sporangia to maturate, to prevent dissemination during surgery, and induces fibrosis to give overall less bleeding during surgery.
Right.
That is the biggest role of Dapsone in our opinion. So don't rely on the Dapsone too much. We don't know what exactly it does, whether it is effective or not. But this effect is certainly important.
In this case,
operatively.
Dr. Satish, was it incomplete removal or the cause was?
Pardon?
In this case, as you said, it is a recurrent one.
You never know. He was operated somewhere else.
Okay.
Came to us, though imaging has hardly any role.
Yeah.
Hardly any role. But we get imaging done to rule out involvement of the other areas.
Yes.
Sometimes hidden in the wall of the nasopharynx, somewhere behind in the airway or anywhere.
Yeah.
See this all clear. This is limited here, coming from the protruding into the nasopharynx.
Yeah.
Nasal cavity.
Yeah.
Could be attached to the here to the turbinate or medial wall of the maxilla or the orbit.
Yeah.
See here.
Yes.
That is the only area where this involvement of the rhinosporoidosis is.
Yeah.
In general, the lateral wall of the nose is most often involved.
Right.
We have seen involvement of the floor, septum, nasopharynx, eustachian tube, anywhere.
Yeah.
Even orbit, nasolacrimal system, skin, multiple cutaneous lesions, many a times.
Wherever it can get an attachment.
Not really. Sometimes it is unexplained. Could be hematogenous, could be trauma.
Yes.
We never know how it inoculates everywhere. And nobody knows for that matter. So these are a lot of things unknown about it, this pathogen. Immune aspect is totally unknown. Whom this pathogen infects, whom doesn't. Nobody knows. So, are you getting the MRI pictures?
Yeah.
So this is the blockage of the maxillary sinus. There is nothing else. This is the disease.
Okay.
The
So
area involved, if I come from anterior to posterior, see this. See the anterior most end of the turbinate?
Yes.
As I go behind, now see the lesion started coming, and this is the area where it is attached to, most likely inferior turbinate. Can you see?
So will you remove whole of the middle terminate in this case?
I will be radical wherever it is attached to.
Okay.
Don't want recurrence at any cost. Okay. So, and our cobbleter is the main key. Believe me, without cobbleter, there is no other way to assess whether you have completely cauterized the base or not. Under vision. Cobbleter will give you bloodless field as you keep on removing this. And you will exactly get to know where it is attached to. That's the beauty. That's what we want in this particular scenario, that we want to know the site of attachment. What's my point? If you start removing with a micro debrider, suppose, or pulling it, it is so vascular, the bleeding starts like anything, and then you never know what is going to happen. You can't see the clear-cut dimension of attachment, the site of attachment, and then a lot of things go, without vision. And that is probably the major cause behind the recurrence. Hello?
Yes, sir.
Sir, any suggestion? Because you must have been doing for years this in the medical college.
Dr. SP Singh is not here. I Dr. Ashwini बोल रहा हूँ मैं.
Yes, boss. Ready? Yes, boss.
You are inspiration for us. We love your watching.
You are inspiration. I bought lot many equipments following you earlier.
No. We all are.
I know. You are one of the person who loves equipments.
Yes. That is weakness.
That is important. Either ready? So the case is ready, and in couple of minutes we'll be ready with the endoscopic picture.
Okay.
Meantime, we can take question if anybody has any or suggestions.
Sure. If any question comes, I will refer it to you.
Sure. Next. वो मैस्टर ले लिया नहीं दूसरा वाला ले लिया तो वो वाला नहीं लिया ले लो उसको चालू करा Hello.
Hello.
Yes, boss. Hello.
Yeah. We are here. Actually, I have operated a case once I faced with this one. That tumor was coming from the nasolacrimal duct. And
Yes.
I operated, and what happened with that? That patient was suffering from some hemolytic disease.
Oh.
That was a nightmare for me.
And you know, this tumor, this disease, see this, maybe in the vicinity of the nasolacrimal duct.
Yes. Yeah,
but it never ascends. It never ascends up in the duct.
Okay.
So orbital rhinosporoidosis is common. I would say not uncommon. And from there it descends into the nasolacrimal duct.
Okay.
Now see this lesion.
Yes.
The important thing is to find out the attachment. See this?
Yes. Still.
See, it's attached to the. Can you see the inferior turbinate?
Yes, appears to be.
See, it is attached. See, it is clear.
Okay.
See the site of attachment to the inferior turbinate. Very clear?
Yes, very clear. Yeah, it's very clear.
So first of all, a small see the surface itself gives you diagnosis.
Yes.
What is that? Sporangias. See the sporangias.
Okay. Yes.
That is classical of rhinosporoidosis.
Yes.
Now my concern is to prevent dissemination. Okay, give me back there. Mukhol. First of all, I'll pack thoroughly the nasopharynx.
Okay.
I don't want this to disseminate lower down the airway. That's a disaster.
Are you using 4K, Dr. Satish?
Not really, boss.
Hmm?
You must be using.
No, no. I was waiting for your answer.
Not really. Actually,
Because I
the,
think you have
the
recommended.
spice camera is so good.
At some workshop, you have recommended that 4K is amazing, and
No, that was probably some demo from the company.
okay.
But 4K, I have never used in my practice. See this. I packed the nasopharynx from below tightly.
Yes.
Can you see?
Yes, yes, yes.
This is important.
Yes,
Imagine this dissemination
stop
to the
the spread.
airway. What is going to happen to the patient? Second thing, see, this is a small biopsy.
Okay. DG although in the middle meters also, I think there is some DG appears to.
Yeah. I will see. My suction will tell you where it is attached to once it pulls. See, this is a small biopsy.
Okay.
Now comes the role of cobbleator.
Okay.
See this?
Yes, yes.
The beauty of the cobbleator, this is the man of the match. Again, nothing can match the value of cobbleator.
Okay. For any macrovascular specimen, it is very good.
See, I want to remove it under vision. Simple. I don't want dissemination.
Yes. Like this tumor is very fragile, so it is very easily sucked out. It very gets sucked out with the cobbleator.
Whatever equipments, the debrider, cobbleator you are using for this surgery, you have to throw it immediately.
Okay. Should not use second.
Yeah. See this? The attachment to the turbinate. Could you see?
Yes. Very clear.
See how vascular it is,
Yes.
in spite of that
Cobbleator.
cobbleator being used.
Actually, cobbleator doesn't coagulates bigger vessel.
Yeah, it is not meant for the bigger vessel.
Yes. Fourth one. Is it fourth? There was some. That was wonderful. Every surgery has been
See,
wonderful.
my concern is to know the exact site of attachment. See this part of the turbinate, rest of the turbinate is free.
Okay.
Only here it is attached to. See this?
Yes. It's very clear.
See,
Yes.
this side of the inferior turbinate. On the inferior surface of inferior turbinate is it attached to.
Okay. Posteriorly.
Same here. See the middle meatus.
Yes, that is what I was telling. So from where it has gone there? Or this is two separate entity in the same patients?
Yeah. Sometimes have multiple attachments.
No, it is revision case, sir. It's a revision case.
Yeah, it's a revision case.
The region of multiple attachment. Okay. Yes. Dr. A.K. Jha sir is here. He is very prominent surgeon of Bihar, Jharkhand. He has been professor at our institute, and he is telling that it may be due to revision surgery. Earlier surgery has been done that led to the dissemination of the disease.
कोई color क्या हुआ?
Sir, color is a bit reddish. Can you do the white?
No, it's okay.
See, this is luminal component.
Which band is using? Which one are you using?
Precise max.
Precise max.
See, without coagulator, it would bleed like anything.
Yes.
Action. This is important. बेटा, आगे। ऊपर रख। So I want to see the site of attachment actually. So this luminal part which is overhanging is coming in the debrider with the section. Pull. See the middle turbinate. See the middle turbinate.
Yes.
See, it is attached high up in the middle meatus. There.
Real site of attachment is still not visible.
Or high up in the middle meatus somewhere.
Yes.
Now let us see if anything remaining in the inferior meatus or inferior turbinate. Nothing. See, even the middle meatus by and large is clear.
Yes.
What I will do now to get rid of inferior turbinate in this patient.
Okay, you will remove it.
Yes, obviously it was attached to it.
Okay.
That to the inferior surface. How can we ensure a radical clearance without that?
Sure. Yes.
And this inferior turbinate, something I will not leave now. See, it was attached to the inferior surface here. You never know how hidden was the attachment. This part of the inferior turbinate दिल निकल गया दवा ना wash. See, in spite of all that, see the amount of oozing this gives. लो पकड़ना, public. Turbinate itself is a vascular structure. Hello?
Yes, sir.
This is just the anteriormost part which I am concerned. Oh. See what a frustrating disease. Wash.
Without coablator, it would have made life all the more difficult.
Yes. The blood. See, with this kind of exposure. Hello?
Yes, sir.
Once you remove the turbinates, everything, wide exposure. See the vessel to the turbinate.
Yes, sir.
That is the vessel which enters the
Inferior turbinate.
inferior turbinate from behind. It enters the turbinate 1 centimeter anterior from the posterior end. $1. See, we know inferior turbinate, what posteriorly was not involved. Hello?
Yes, sir.
Only the anterior part of the inferior turbinate was involved. And we are staying little more radical, even more than required. Concern is how it is coming into the middle meatus so high up. God, section got. Beauty of the coagulator is it itself keeps coagulating the base. Hello? Hello?
Hello.
Yeah.
Yes, sir.
Beauty of the coagulator is this is itself cauterizes all the way.
Yeah.
So cauterization of the base is the integral part of this, important part of this surgery.
Yes. Dr. Satish, is there any bearing on the cauterization material?
Means?
Cauterization material, earlier we used to do chemical cautery, then bipolar, then coagulator. Is there any studies which says which is good?
No, nothing, no studies.
No studies, yeah.
See what I want to do, this area radically.
Yeah.
Cauterize
So that
more
no
and more.
mucosa is left.
Pardon?
Huh. All bones are there.
Yeah. Now this middle meatus components is worrisome.
Right.
Inferior meatus is never worrisome. Now the advantage of this, exposure turbinate resection, you can monitor the recurrence much better. Much earlier, I would say.
Hi, sir. Harsh here, sir. So just
Yes,
wanted
yes.
to ask you a question. That suppose, sir, this was a small proliferative tumor. We're not sure about the histology. Would you go ahead and do a complete medial maxillectomy, or would you wait for a histology and then do a second step? sir?
First histology. See, I told you in the beginning, looking at the sporangia leaves hardly any doubt about the diagnosis.
Right, sir.
Secondly, if you have any doubt, get the frozen section done.
Yeah.
Because rhinospheroidosis diagnosis is most of the time straightforward.
It's a clinical one mostly.
Yes, the classical picture of sporangias. Patla mangai. Yeah. So this is the anterior part. Look at that. Yeah, give me a back.
Because you are opening the newer areas.
Yeah, there can be a concern.
Yeah.
That you are giving raw areas.
Yes.
But these raw areas with the base cauterized are not the site to, for the rhinosporidium to grow.
Yeah.
Hello?
Yeah. That's very true.
That will not give vascularity to the rhinosporidium to grow.
Yeah.
So these raw areas, what I have burnt out, are never going to give any, site to attachment unless some sporangias left behind and then over the period of time during healing can involve this area. So goal here is to completely remove that possibility first. Now give me the 70 degree. I have to now stay little radical in the middle meatus also. Somewhere here. That was the probable site. Since I am away from the skull base, I am using my cobbletter like this. One can never think of using cobbletter in the sinuses like this.
Right.
But I will open up sinuses later. Let me first strike off this pathology. Creating raw area can invite sinusitis.
Yes.
But I will not leave that opportunity. Here the most important thing is to stay radical. Zero degree again.
Yeah.
Scissors. This is the possible,
Site of attachment.
yeah, I mean, close vicinity it was. Right. 40 दिन है यार.
That is for better visualization.
I'll take care of the sinusitis part now.
Yeah.
By means of widely opening the sinuses.
Sinusitis may be because of the mass effect that is blocking.
Yes, yes. Yes, but now with the raw areas created,
Yeah, you cannot leave it as such.
yeah, I should not block the frontal recess.
Yeah. Basically, for the recurrence, if more you open, more you are giving a space for that to inoculate. If there is a further.
No, it is not the further inoculation which is responsible for the recurrence.
Yeah.
It is the disease which is left behind.
Yes.
Person has acquired this, disease once.
Sorry. Yeah.
Backbiting. It doesn't mean that he's acquiring and getting exposure again and again.
Again, yeah. And once after undergoing a surgery, they are doubly sure to take care of the nasal hygiene and all that.
Yes, at least not to swim in the ponds.
Yeah.
That is the biggest reason
Yes.
for this disease. That's the maxillary sinus. We had a retained secretion there.
Yeah.
That's the maxillary sinus.
Yeah.
There's no disease. This was not for the disease purpose.
It's just to provide the drainage.
Yes. See the ethmoidal cells I'm clearing off. See the normal area?
Is there any disease in the maxillary sinus or just it is inflamed mucosa?
Inflamed mucosa. See the normal ethmoidal roof
Yes.
behind?
Yes. Ethmoids is normal.
Yeah.
This is
So
area
all
of-
that, doubtful area, I've radically removed.
Yes.
Section they will black. See the ethmoids behind, very nice. Even
Very
the
nice.
frontal recess above looks nice. Superior turbinate looks nice. The maxillary sinus looks nice.
Will you take out whole of the uncinate process in this case?
Already removed except the uppermost part. I will see with the 70.
Okay.
See the maxillary is clear. What my area of concern is this one. So this is the area where it was possibly attached. Now, practically I removed from everywhere.
Yeah.
Now is the time to reassess hemostasis. I'll be, as I said, using povidone iodine.
Yes.
Section the wash kar.
Otherwise, we never touch the sinus.
Now the biggest advantage is
Yeah.
I'll have the opportunity to inspect for any recurrence.
Yes.
These patients we call every month for 2 years at least.
इसलिए मेरा तरीका है ना, सरसों तेल उबाल के ठंडा करके नाक में डालिए, that really prevents ठंडा
70.
एलर्जिक राइनाइटिस, जाड़ा में
Now with the 70 degree. Uday, 60. See the polypoidal sinusitis,
yeah.
the maxillary sinus, nothing else.
If you just keep it open, it will heal by itself, isn't it?
Yeah, but there's some, secretion, the mucosa is bad.
Mucosa, those has to be taken care of. Yeah.
Yeah.
Part of the generator.
सरसों तेल उबाल के ठंडा कर दो तो गम निकल गया.
See this now wide opening.
Yes, very wide. It's very quite wide
ऊपर
open.
से आधा आधा ड्रॉपर डाल के पकड़ के रिंच करो 3-4 बार अंदर बाहर.
Layer.
Yes, sir. जी sir.
को बोला ना.
नहीं.
See the maxillary sinus from inside.
Yes.
So practically, I don't see any disease now.
Yeah. It's absolutely clear, Dr. Satish.
Just preventing the frontal sinusitis.
Yeah.
60. Because already the frontal sinus on MRI was showing haziness 129. और इधर आके सिर पकड़ना. What happened? Hello.
Yes, sir.
Yeah.
The last part is my frontal recess.
Yeah.
I should not leave it blocked.
Yeah, yeah. Basically, the purpose of all this is so that you, in the follow-up, you can do with the endoscope, you can see all the areas.
Obviously. Secondly, because of this, there was some secondary sinusitis because of the
Mass effect.
yes, lack of ventilation and drainage,
Yeah.
which I want to establish.
Yes. चार तक तो हम कर दिए, 2 बजे तक ही था. हम 4 बजे तक चलने दीजिए, जिसको बैठना बैठेगा.
See, it is so, even the mucosa is so vascular.
Yes. आने जाने में नहीं है, वहीं से कर रहे हैं. No, 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 no. Sir, this is the future of workshop. Why to unnecessary bother?
So wide opening to the frontal.
Yeah.
Give me a pad. अब लेटर देना called. Oh God, we'll pack it for a while.
दत्ता बोकारो में बहुत पहले 99 2000 में। जब तक मुखर्जी बात के हम लोगों का अच्छा बोकारो धंधा चल रहा था, अब आदमी
Just give me a pack for a while.
या
क्या हुआ इसका कलर को क्या हुआ?
सो नहीं अभी तो प्लीज बाकी है।
Hello.
या डॉक्टर सतीश
Yeah, this is just a pack for hemostasis.
या
We will wash and I will pack the entire cavity with the pure povidone iodine, pure.
and that's it. And pack you will remove after 48 hours?
Yes, yes. We'll keep it packed with the povidone iodine itself.
Yeah.
See, bottom line is you can't control everything. You have to stay more than radical.
Right.
You can give Depson as an adjuvant post-op.
Yeah.
Start from the beginning, pre-op.
Yeah.
You can betadine rinse post-operatively. You give all these patient betadine rinses.
Yeah.
Povidone iodine, there are publications has been, found to be effective. Follow this, bada wala. Choda wala था ना? छोटा था नहीं? कम मुड़ा हुआ। Hello.
Dr. Satish. Dr. Satish, all the delegates in the Bhagalpur auditorium, as well as across the world who are watching from the web link, have thoroughly enjoyed. We got very good comments. And Satish Jain, as usual, is always mesmerizing and absorbent.
Alright, sir, all your blessings.
No, it's all.
I don't know the time status.
We wanted to do it up to 4. I think, what is the next case, by the way?
Okay, what we'll do, I think there is no time left for the next case.
Yeah.
I will discuss some radiology of the next case. Is a cholesteatoma.
Yeah.
With lateral canal fistula.
Okay, that's great. Yeah. There are some questions. Sorry, Sanjeev.
The other cases will finish off the stapes, the cordectomy. See now, this is by and large, this is maxillary sinus. Above is the frontal wall. Radically to the maximum.
Yeah.
We have excised, we have thoroughly cauterized the base.
Dr. Satish, there are a few questions.
Yes.
Sambhaji Chitale, what precautions we have to take while opening the frontal sinus from Aurangabad?
Yes. So while opening the frontal, the best is open to the maximum to the limits.
Yes.
Remove all cells.
Yeah.
Because Incomplete removal of the septation can invite fibrosis, adhesion, scarring,
Yes.
and can be a big problem.
Yeah.
And you know, the revision frontal sinus surgery is one of the most challenging aspects.
It's very difficult to perform, sir. And you have always
Oh,
told
the-
there's no size of the opening. It should be removed to the maximum. All separation
Yes,
and should be removed.
yes. See this entire cavity, we have a pack behind.
Yeah.
Completely filled off with pure povidone iodine.
Yeah.
And we'll leave it for 10 minutes.
Yes.
See the entire cavity full of. So all the areas in the nasal cavity, let it be applied for 10 minutes at least.
Yeah.
This is found to be effective. So what we could do this for this patient is removal radically. More than that, not to lose the area of interest where the lesion is attached to.
Yeah.
Bleeding is part of the surgery. To minimize, you can use cobblator. That gives you better opportunity to look for the site of attachment. Like we could initially see, the inferior turbinate was attached to, and I could radically remove the inferior turbinate. Middle turbinate, because it was going in the middle meatus. So I went up till frontal recess. The maxillary sinus was clear. And now the cavities, all those areas, suspicious areas were cauterized.
Yeah.
Cavities full of betadine. We'll give Depson also sent to our physician.
Yeah.
And that's what we can do. And thorough saline wash at least 3-4 times a day initially because of a lot of crusting expected.
And how long should we keep these patients in follow-up observation?
At least 2 years, even if there is no disease.
Yes, sir.
Monthly nasal endoscopy, recording, crust clearance, saline wash, you know, until it completely heals off. Monthly.
Satish, there is another question from Krutika from Mysore. With such an extensive surgery, what are the chances of developing atrophic rhinitis and how you prevent it?
See, atrophic rhinitis is a different entity.
Yes.
That's an immune complex disease of the vessels supplying the nasal cavity. That is arthritis basically.
Yes.
That's an immune complex disease. This, what all this can give is little excessive crusting. And we have seen in our skull-based cases, even if we leave more roomy nose than this, ultimately it mucosalizes. So that's a different aspect. Atrophic rhinitis is a altogether different pathology. That's immune complex disease. So it can, what you can say is it can give excessive crusting. That's it. For that, I told you we have to be aggressive in nasal douching, debridement of the crust, and repeated endoscopy, close follow-up, all that. Even if there is a slightest suspicion of a rhinosporosis coming back, you can pick up earliest by means of regular follow-up, and then you can remove it without allowing it to grow up bigger.
There is another question by Pritam Chatterjee from Siamnagar. For extensive or multifocal involvement, should we rely on the medical therapy and how long?
Not really.
Other than
No medical therapy so far has been proven to be very effective.
Another
so far.
Question from Fajel Wahid from Peshawar. This cobblator which you have used for mucormycosis, can it be used for other cases?
Not really. Never. One should not even think of.
Okay. So you discard or get it sterilized?
Absolutely. And this also I mentioned in the beginning must be totally discarded. Cobblator, debrider vents.
Period of follow-up you have covered. Blood or blood constitution, no, that is not required. Yeah. Thank you very much. Excellent.
And thank you, sir. And I know the time is up. Just 5 minutes since we have taken this case, just to show you the radiology, what case it was.
We are with you, sir.
Yeah. So 5 minutes, just to apprise you what case it was, which we have started now. So This patient has a long-standing chronic suppurative otitis media and now presented with recurrent vertigo. The CT was obviously warranted, and what CT has shown, see carefully. Let me show you from up to down. See up there, this is the intra-aortic meatus.
Dr. Satish, please repeat how he presented once again.
And long-standing chronic otitis media,
Yeah.
suppurative otitis, and now presented with recurrent episodes of vertigo.
Vertigo. Okay.
And has a mixed loss now.
So provisionally, are we thinking in terms of fistula?
Yes, that's what I'm saying.
Yeah.
That this is the indication for a definite CT scan.
Right.
And what inference we can get out of CT scan is here.
That's very important.
So if I read the CT scan, see, CT scan has to be read differently for different pathologies. From cochlear implant purpose, we need to look at different aspects.
Yeah.
For otosclerosis purpose, we need to look at different aspects.
Yeah.
For chronic suppurative otitis media is altogether different.
Yeah.
And see in this case, if I go from upside down,
yeah.
See, this is superior canal.
Yeah.
Ampullary, non-ampullary, and this is your intra-aortic meatus. Can you see?
Yeah.
And from here, intra-aortic meatus, the most superiorly, this is the facial nerve going anteriorly.
Yeah.
From here, this is the geniculate ganglion, and here is the GSPN going.
Yeah.
And here is the horizontal portion of the facial nerve. See this, where my cursor is.
Yeah.
That's the horizontal portion of the facial nerve.
Yeah.
That's the cochlea.
Yeah.
That's the vestibule.
Yeah.
And this is the arm of the semicircular canal. See this? Yeah. That's the signature appearance of the lateral semicircular canal.
Yeah.
That's the facial nerve.
Mm-hmm.
And see before that, this canal is eroded laterally.
Yes.
Laterally by this opacity. Can you see here?
Yeah.
See this canal here, it is eroded.
Yes.
Look at the normal side.
Yes.
You can see the normal side. You can see the entire circumference of the canal intact.
Yes.
See this?
Yeah, yeah.
From the lateral most part of the canal, there is a thick bone over it.
Yeah.
But here, this canal is eroded with a cholesteatoma.
Yeah.
Clinically also is a aortic cholesteatoma.
Yeah.
And quite a length of the canal is eroded.
Okay.
See, right from here
Mm-hmm.
till here, this
Yeah.
is more than 3 to 4 millimeter of the segment of the canal is eroded. So it's a huge fistula.
Yeah.
That's why the patient has moderately severe sensory neural loss also, what he has developed. So this is the ampullary end, this is the non-ampullary end, and this is a big fistula from ampullary to non-ampullary end. And this is the facial nerve, which is exposed at the second genu.
Yeah.
You can see here.
Yeah.
That's the facial nerve that is covered with the bone in the vertical aspect.
Yes.
But if I go back at the second genu, it is uncovered. There is no bone, must be because of the cholesteatoma. And see in the horizontal segment, it is completely covered with the bone. Can you see?
Yeah, yeah. Very clear.
So all these aspects need to be seen. With such a big fistula, now there are many ways. There is a concern number one, whether to remove this epithelium sac over the fistula or to preserve it.
Yeah.
A lot of people favor the policy of preserving the, sac epithelium to prevent further sensory neural loss, which may happen with the handling of the inner ear structure. Once you remove the epithelium, it may open up the, endosteum and can lead to further sensory neural hearing loss. And believe in the philosophy of leaving a canal down cavity.
Okay.
Keeping the epithelium intact over the fistula.
Okay.
What my point?
Yeah, yeah.
But that epithelium is a cholesteatoma. It has a matrix. It secretes enzymes, collagenase. And if you leave it ultimately in the long run, it is going to give to the complete hearing loss.
Yeah.
Because that is cholesteatoma.
Yeah.
And secondly, with leaving an open cavity with a thin epithelium over it can lead to persistent vertigo.
Yeah.
Until it results into dead ear and complete compensation.
Yeah.
So the other opponent group believes in complete removal of the cholesteatoma.
Yeah.
Irrespective of the hearing concern, removal of this cholesteatoma is important to prevent inner ear infection and meningitis.
Yeah.
To prevent further hearing loss. Believing that according to the literature, if you remove the fistula completely, this epithelium completely, the chances of hearing loss are not 100%.
Yeah.
Still you can preserve the hearing. So this is a very, very challenging situation, and decision is always intraoperative, depending upon the size of the fistula, depending upon how the endostem is exposed or not, though it should be handled at the end of the surgery.
Yeah.
And if you're removing, you must cover with the, bone dust, fascia, tissue glue,
Yeah.
whatever, bone wax, so many things. So the point of, I just took your few minutes, is to discuss the pros and cons of various situations one may come across having fistula with a cholesteatoma, and that too with a big fistula like this. What exactly are the options that can be, undertaken? Sometimes it is because of the fistula, the kind of surgery is influenced. Some people opt for a canal down, intercanal surgery and close the fistula to prevent further vertigo.
Okay.
Others, I said, and they may even leave the epithelium, assuming that will convert to a pearl later on, and in a second surgery after 6 months or 1 year can remove the epithelial pearl with the intact eardrum, intact canal, without giving any possibility of infection to the inner ear, even if it opens up.
Yeah.
So there are different philosophies for different situations, but this is a difficult call, needs experience, and intraoperative situation is the final, decision-making step to take a call on this difficult subject.
So per se, depending on the situation right now, are you planning canal down and closure of the fistula?
Most likely, because there's a big fistula, already sensorineural loss set in. Mastoid is not very big, you can see.
Yeah.
Another decision-making factor, the mastoid is not very big.
Mm-hmm.
See, this is all sclerosed mastoid. It's not very big pneumatic mastoid. So you can do a good canal wall down job with complete removal of the cholesteatoma, closure of the removal of the this epithelium over the fistula. Closure of the fistula is bone dust, fascia, and you can reconstruct a little bit of the cavity with the cartilage and then fascia over it to prevent future sound reaching there, causing vertigo. But depending upon, because his mesotympanum is intact, it was atic cholesteatoma. If intraoperatively it favors us an intact canal mastectomy with a good eustachian tube function likely, still we can take a call of intact canal mastectomy with the decision of epithelial removal, taking in the end to remove it at the same stage or allow it to become a pearl to remove it later on after 6 months or 1 year. So both the things.
And sir, when the situation become more severe and the cholesteatoma is inside the vestibule, open.
Yeah,
vestibule,
then you have to remove it. There is no other option.
and then the canal wall up and down, what could be the
Whatsoever. That is depending upon the merit of the surgery. Depending upon the situation, that takes call of many things. Whether to take a canal up or down, and most importantly is the eustachian tube function. Because if you give a canal up, we call it interiorization.
Yeah.
Interiorization means now you're reconstructing everything and interiorizing the middle ear down the eustachian tube for the aeration.
Yeah.
And for that, the thing which is must is the good eustachian tube function. That you can assume by a good air-filled cavity in the region of the eustachian tube.
Yes, sir.
Rather than anything else.
Dr.
Like this patient has a good air-filled middle ear towards the eustachian tube. I'm expecting a good eustachian tube. There may have been impaired eustachian tube function long back, led to cholesteatoma, but now it has recovered and the Eustachian tube area is good and there is aeration.
Dr.
So,
Satish, canal
yeah.
up or canal down? Is it going to much difference?
In this case,
Yeah.
yes,
Because it is such a huge cholesteatoma, you will like to do canal down.
see, cholesteatoma, the extent of cholesteatoma doesn't always dictate the approach.
Yes, that is what
Even you can remove the biggest of the cholesteatoma in the temporal bone anywhere,
Yeah.
not Peter's bone, anywhere, keeping the canal intact,
Yeah.
provided the Eustachian tube function is good, we'll still going for interiorization.
Right.
Even if it warrants removal of some part of the canal wall, in order to remove cholesteatoma completely, suppose, we'll remove that part of the canal wall, remove the cholesteatoma and reconstruct it.
Yeah.
The basic principle of interiorization stands,
Yes.
provided the Eustachian tube function is good and you are able to preserve good amount of mucosa while removing the cholesteatoma.
And what the vital area of mucosa which should be preserved in middle ear cleft?
Yeah,
Probably
the
mesotympanic,
promontory and atic.
atic, periantral area.
Yes, that is most important. Suppose the patient has a good Eustachian tube function.
Yeah.
And during the removal of the cholesteatoma, you ended up removing all mucosa.
Yeah.
What is the fun in blowing the air in the, bony cavity?
Yeah, exactly.
How the normal physiology works?
Yeah.
Our Eustachian tube opens, every minute, every once in a while, it opens 1,000 times a day.
Yeah.
And every time what happens? Because of the constant air absorbing by the middle ear mucosa into the circulation,
Yeah.
it is constantly producing a negative pressure situation, which is neutralized by every other opening, every other time opening of the Eustachian tube, which delivers the air inside. That is the normal physiology to neutralize the pressure. My middle ear is, absorbing air continuously. The moment it comes to a level of negative, middle ear pressure, slight, the Eustachian tube opens and it neutralizes the pressure. That's how the Eustachian tube opens 1,000 times a day, and every time it delivers the air to maintain the air pressure behind the eardrum with the atmospheric pressure. So this function, this physiology can work only with interiorization, provided you have a good Eustachian tube function and you have adequate mucosa to absorb the air. If you completely, during the removal of the cholesteatoma, I have seen people removing the cholesteatoma like a pocha. Take a cotton ball and pocha on the bone, completely removing the mucosa in toto. And then reconstructing the ear is no fun. It is never going to work. And that's how the intact canal technique has gone to disrepute. It is not the fault of the technique. The wrong decision to do intact canal at the wrong situation. If you are doing intact canal, it should be done only if you have adequate mucosa to absorb the air into the circulation and good Eustachian tube function. If either of these is not there, better to do a good canal down. Once you do a good canal down, do a perfectly good canal down with all principles taken care of. It's not that the ridge is not adequately lowered down, the cells are not adequately cleared, all those things. And that, as the poor technique has, given this intact, the canal down a disrepute. It is, canal down is a wonderful procedure, provided adequately, the procedure is properly done, executed for the right indication. If you are doing a canal down in a big mastoid, pneumatized mastoid with good Eustachian tube function, you're unnecessarily giving a big cavity to give patient a lifetime, need of mastoid care.
Yeah.
So that is
ideal situation is that your canal wall is up and your mucosa is intact. That is the ideal situation you have to achieve. Otherwise, you have to compromise with the cavity, with the recurrence, with the
yes.
The non-functioning mastoid cavity.
Yes. So most of the canal wall are failures are because of these two reasons what you enumerated. Lack of eustachitive function, lack of adequate mucosa, and you are doing a canal of technique.
Yeah, yeah.
That's how a lot of people are given this technique at this repute, and a lot of people stop doing it earlier.
Yeah, yeah.
Same is for the canal down. A lot of people believe the canal down is a bad patient will require lifetime care, vertigo, can't swim, this every time recurrent discharge, and that is because of the poor execution of the technique, number one, and for the poor indication. A perfectly executed canal down works wonders, believe me. With a good metaplastic, good exentration of air cells, good ridge lowered, good lining epithelium reconstruction, it works like magic. So it is not the technique, both the techniques are good, provided used for the proper indication and executed properly. Bottom line is that.
Yeah, yeah. And do you feel the introduction of endoscope in cholesteatoma surgery gives some advantage over the alone microscope or endoscope?
Yes, definitely. Endoscope is useful as an adjuvant, I believe. Now the endoscope, like you people, you are so experienced. Dr. Sanjeev has been using endoscope for so many endoscopic ear surgeries like tympanoplasty and all that with good results. So endoscope has a lot of scope even for the lateral skull base cases nowadays. But in cholesteatoma, because it requires a lot of drilling, a lot of other things and removal of the cholesteatoma, other aspects, microscopic surgery along with the endoscope can certainly be useful at certain times, particularly when you have to look into corners. Anterior aortic, editors, the sinus tympani, all those hidden areas are best seen with the endoscope. And many a times we use endoscope to supplement that our belief that the cholesteatoma has been completely removed to ensure that it is not left behind. And these are the areas, particularly anterior aortic, sinus tympani, and editors. We must use endoscope. A lot of people, what do they do? Like I said, you can leave the pearl of the cholesteatoma behind in this fistula case, and you can come back after a few months to see if the pearl is formed. Similarly, this intact canal procedure, a lot of people do. Whenever you intact canal, give patient the option of a second look always, because you are never sure of the 100% second tube function or everything
interval
for the future.
Interval?
Here the endoscope can work wonders in the post-op. With a small opening post-oral, you can see inside if everything is good. No cholesteatoma. If you are in doubt, you can see with the endoscope.
After how many days and months we could see post-operative inside the mastoid cavity with endoscope?
Depending upon the need, symptomatology, your finding of the previous surgery. Like if you are in doubt during cholesteatoma surgery or done intact canal, that you are in doubt that you may have left behind some epithelium.
Yeah.
Not 100% sure it was piecemeal, whatever, with poor exposure, whatever.
Yeah.
You can always plan after 6 months to 1 year, anytime. If you are very sure, no need to.
Not before.
If you are intentionally leaving the epithelium, yes, of course you have to plan.
Not before 6 months.
Not because allow the the healing process to take place.
Yeah.
Rather 1 year, I would say 1 year, because whatever ear surgery you do, practically it takes almost 1 year to stabilize.
Okay, that's nice.
Microscopic level.
Okay.
Dr. Satish, once again, thank you very much. It was a great discussion and all of us enjoyed. And tomorrow morning, 9:40, no? 9:40, we meet again.
Okay, sir.
Okay.
Thank you. We'll be there. Thank you. Thank you so much. Thanks everyone from the organizing side for giving this opportunity. Special thanks to Dr. S.P. Singh, sir. Farooq is like brother, is always in part of our team. Thank you, everybody, once again.
Okay, sir. On behalf of the AOI Bhagatpur branch, we all thank you, sir, showing the so very nice and beautiful and very self-explanatory surgery. So we enjoyed too much, sir. And all the association members of the Bihar and Jharkhand enjoyed so much. Thank you so much, sir. And
Thank
we
you.
shall, we are hoping to see you again in the next day, sir.
Thank you. Thank you, sir.
Thank you, sir.